and Muckleshoot nations. Additionally, we would like to comment on the scheduling mistake we made by holding this event during Yom Kippur. Our clinic would like to sincerely apologize to our Jewish community members, clinicians, and patients who had to make the difficult decision between observing this holiday and attending the symposium live. We are committed to increasing accessibility to all communities because we believe that everyone should have the opportunity to learn about long COVID and participate in the discussions we will have today. For that reason, our group will work harder to ensure that any future events will not coincide with conflicting holidays. To provide another opportunity to engage with some of our speakers for those who were unable to attend today and are observing Yom Kippur or any other reason, we will be holding a follow-up Q&A session on November 18th. This virtual event will be held from 5:30 p.m. to 6:30 p.m. Pacific time. We have chosen to hold this event next month to allow for anyone who may be interested to review the symposium recording. If you wish to register for this event or submit a question to our team to answer, please review the event information on our website. It's available there. We understand that this does not fix our mistake, but we hope it provides another opportunity for all of us to convene and discuss this very important topic. Today we have attendees from 30 states and 4 different countries, and we are very honored for your participation. To give a quick overview of today's sessions, the presentations in the first half of our symposium until noon are geared towards clinician audiences. However, we welcome our patients and patient advocates who have decided to attend the morning sessions alongside our clinical attendees. Presentation topics include post-acute infection syndrome and small fiber neuropathy. The second half of our symposium is focused on patient education, and similar to our morning sessions, we invite clinicians to join in during these sessions as well. We will have a very, very special performance by the renowned cellist Joshua Roman, and you will hear from patients and clinicians on topics such as adaptive exercise, engaging in pleasant activities, and cognitive symptoms of long COVID. Today's event is hybrid, and we have many individuals watching this event live via our Zoom webinar. I would like to give a summary of the Zoom webinar functionality and what you can expect. Each attendee will have the opportunity to utilize the question and answer function and adjust your volume as necessary. The Q&A option should be displayed on your device, and at any time during a presentation, you are welcome to submit your questions. You will have the option to either submit your own question or upvote a question someone else has asked. Once a speaker is done with their allotted Q&A time, all questions from that session will be dismissed to create a clean slate for the next presenter. We will try to get as many questions as possible at the end of each talk. We apologize in advance if we are unable to answer them all. However, please use the upvote button if you feel strongly a specific question should be answered. I also want to highlight that we have ASL interpretation available on that screen over there. So for those of you who need that, that's the screen where that is happening as I am talking here. Before we move on, I want to take a quick moment to extend my sincere gratitude to our clinic's health service manager, Nova Rivera. Nova is right there in the back. He is there in the back. Both symbolically and metaphorically, he's the backbone of this event. He's the backbone of the clinic. Putting together an entire symposium, let alone one with over 600 registered attendees, is no easy feat. Thank you, Nova, for your dedication over the past 6 months towards putting together this event. Thank you very much. Now it's my honor to introduce Dr. Jana Friedli. Dr. Friedli is the executive director for our Long COVID clinic. She is a professor of physical medicine and rehabilitation and chair of the Department of Rehabilitation Medicine at the University of Washington's School of Medicine. Dr. Friedli is co-founder and executive director of UW Medicine's Long COVID Clinic and the editor-in-chief of the Physical Medicine and Rehabilitation Journal. It's the official journal of the American Academy of PM&R. Dr. Friedli conducts health services and outcome research related to chronic pain and disability. Dr. Friedli is the most exceptional leader and visionary I know, and she is my mentor. It's an honor to welcome her.
Thank you very much, Dr. Chopra, for that warm welcome. And thank you, everyone, for attending today, taking time out of your day to participate in this event. We really appreciate that. And I also want to extend my gratitude to Nova Rivera for all of his hard work on this symposium. It's my pleasure to talk today for a brief moment or two about our Long COVID clinic. And we started this clinic in the spring of 2020, really early in the pandemic. And so we have been in existence now for about 4.5 years. And since we launched the clinic in 2020, we have been providing services for patients affected by long COVID. And we have combined a hybrid model of care. So we see people virtually through telemedicine, and we also see patients in person in our clinics. And we have an exceptional team. This is really a multidisciplinary team. We have specialists in not only rehabilitation medicine, but also family medicine, internal medicine, and primary care, neurology, and many other specialties, as well as social work, physical therapy, occupational therapy, speech-language pathology, and many others on our care team who are helping to care for patients with long COVID. And it really, truly is a team approach. And today you're going to hear from many of our team members that are participating in this care today. Over the last 4.5 years, we have had the opportunity to care for over 6,000 patients who are affected by long COVID. But we recognize that there is a huge unmet need in our community. And so we have really focused our efforts on obtaining funding to support increasing access to care for those patients in need. And so one of the cornerstones of the work that we have been doing is in partnership with the Agency for Healthcare Research and Quality, or AHRQ. And they have provided us with critical support and funding, including funding for this event today. And through this collaboration, through this network that AHRQ has created for long COVID clinics around the country, we are working to expand access to care, not only for patients in our clinic, but we're also really taking some innovative approaches to try to expand the services in the clinic and advance how care is delivered, really with the goal particularly focusing on historically underserved rural and minority populations. So our overarching goal that is supported by the grant that we have obtained through AHRQ or AHRQ is to ensure that every patient, regardless of their background or their location, has access to high quality care and person-centered care for long COVID. And that is really at the heart of why we are here today. Our project is built on three main aims. One is to expand access to care within our own clinic. And so we have expanded our care coordination services, our behavioral health services in collaboration with our rehab psychologists, who are critical members of our team, and everyone else on our team, to improve access within our own clinic. But we're also focusing on community outreach. And so we are participating in community health events to help get the word out about long COVID, educate people about what long COVID is, how we might prevent long COVID, and what services are available for people who are affected by long COVID. And then we are also working to train our clinicians throughout the 5-state area called the WWAMI region here in the Pacific Northwest. And so a lot of our efforts are to try to help our primary care physicians throughout the area to have the knowledge and the experience to help care for patients with long COVID. We are also leveraging telemedicine. We're doing e-consults, so electronic consultations with clinicians to make care more accessible for patients across the region, including Alaska and many of our underserved rural areas. We also are partnering with many local community groups that serve communities with people who are disproportionately affected by long COVID. And there are many of these communities, such as Latino, Native American, Alaskan, Southeast Asian, and LGBTQ plus communities. We participate regularly in these types of public events and really trying to increase patient education about long COVID. As we look to the future, we have many things planned over the next few years. One of the things that we are looking to launch in 2025 is a mini fellowship program for clinicians, again, to help train a new cohort of clinicians to care for patients with long COVID. So before I turn it over to Dr. Bender to introduce our keynote presentation, I do want to emphasize our commitment to improving access to high-quality long COVID care, really through collaboration with other clinicians across a wide range of specialties, collaboration with our patients and patient advocates. And we also participate in research, and you'll hear today about a lot of the research that's going on nationally and locally as well. So I think together we are helping to address some of the unmet needs for patients with long COVID. So again, I'm incredibly proud of our team and the work that we've done. But I know that we have a long road ahead of us and a lot of work to do. And so I, again, want to extend my gratitude for all of you for participating today. So I'd like now to turn it over to my colleague, Dr. Jessica Bender, who will give us a few final details about today and introduce our keynote speaker.
Great, thank you everyone. I'm Dr. Jessica Bender. I am one of the principal investigators on our AHRQ grant and a clinician in the Long COVID clinic. Some housekeeping details for CME learners in person and online. Please use the link that will be available via a QR code that will be on one of these slides and on the flyer up front, as well as on our website. The feedback we receive is really important for our continued improvement in topics and scheduling. Please provide your thoughts on speakers, topics, programs, and you must complete the course evaluation and attest to your hours to gain CME credit. There's that QR code, thanks. And then the event is being recorded and will be uploaded to our symposium website in 1 week for online indefinite review without CME credit in the future. Note that between speakers, we will have a short break as noted on the agenda. Thank you for your patience with that. And as a reminder for people on Zoom, as you enter the webinar, please enter your first and last names and email address when you're entering the room. If you have problems on Zoom, please email our clinic, or you can chat with the webinar staff more immediately. If you have multiple attendees on one device, you can email our clinic, longcovidclinic@uw.edu. For in-person attendees, we will have food at lunchtime in the Vista Terrace upstairs. There are stairs and an elevator behind us. We will limit our eating to the designated eating areas noted by the signage, and then otherwise please remain masked in this room for the duration of the event. And now it's my pleasure to introduce our keynote speaker, Dr. Tiffany Walker. Dr. Tiffany Walker is an assistant professor of medicine in the Division of General Internal Medicine at Emory University School of Medicine and faculty at Grady Memorial Hospital. She's co-founder of the Grady Long COVID Clinic, where she co-established the multi-center CURE Long COVID Registry and Biorepository. She serves as PI of the AHRQ Atlanta Long COVID Collaborative, a multi-health system long COVID coordinated care model. She is the Grady Site PI for the NHL BI Recover Initiative, Meta-Cohort, and the Recover Vital and Auto clinical trials, and co-investigator for Recover, Sleep, and Energize clinical trials. She investigates long COVID health disparities through Alzheimer's Association funding, characterizing cognitive domains impacted in neurocognitive sequelae of COVID-19 in older African American adults. Additionally, she collaborates with colleagues to characterize innate and adaptive immune dysregulation in long COVID, leveraging multidimensional single-cell profiling and technology. After her presentation, Dr. Walker will take a few questions from the audience as time allows, and if you are unable to ask your question during this time, you will have another chance later during our final panel session of the morning. Please all join me in welcoming Dr. Walker.
Thank you so much to Dr. Friedley, Dr. Bender, Dr. Chopra for this opportunity to speak with you all. Welcome, everyone. Thank you so much for prioritizing this really challenging and complex disease, being here today in person and online. For those of you who are less familiar with long COVID, I hope to give a comprehensive overview. And then for those of you who are very familiar with long COVID, I'd like to propose a roadmap of how we might forge the path ahead. In an age when medicine is based on evidence, what can be done for people who live at the edge of medical knowledge? This is a really impactful statement. This is by Megan O'Rourke, who is a writer and poet from Yale University, but also a person who lives with an infection-associated chronic condition. To me, this really characterizes the paradox that long COVID patients face as they seek validation for their condition and relief of their symptoms. For us, this is a call to action. This is why we're here today, and I hope we use this to center us as we move forward trying to better understand long COVID and effective treatments in this space. So let's begin with what we currently understand of long COVID. So it's paramount to come up with a universal definition for long COVID. So we know how to guide clinical care, and we have research targets. So NASM, the National Academy of Science, Engineering and Medicine, heeded the call from patients, caregivers, researchers, and clinicians. And through a series of working groups, defined long COVID as an infection-associated chronic condition that occurs after a SARS-CoV-2 infection for at least 3 months as a continuous relapsing, remitting, or progressive disease state that affects one or more organ systems. So I'd like to highlight some of these manifestations because for the clinicians in the room, it oftentimes doesn't fit in our illness script to have someone that's so disabled by their disease they can't get out of bed one day, and the next day they can get out of bed, go to work, take care of their children, and do the grocery shopping. But this is very true in long COVID and is the reality for many long COVID patients because can be a relapsing and remitting disease. And that we shouldn't discount this just because it's unfamiliar in our illness scripts, because there are other disease states like multiple sclerosis where we see this relapsing, remitting nature. So something to point out and a potential pitfall. There are over 200 symptoms that have been reported in long COVID. I'd like to highlight some of the key symptoms that we see over on the right. The first one is post-exertional malaise. This one is a very important symptom because it's a hallmark symptom of long COVID. Not all patients experience this, but the majority do. So I describe this as a triggered fatigue that occurs after either a physical exertion, a cognitive burden, emotional burden, or an environmental exposure. And what happens is then it triggers a fatigue that is either a physical fatigue, but it could also be a cognitive fatigue. And the difficulty with this is sometimes it happens in the moment, but more often what happens is it could be delayed for hours or days, and then those symptoms can last for hours, days, or weeks. And so you can imagine this is really challenging to describe to a patient or to a clinician, and learning how to associate these crashes that patients experience with their triggers so that they can have some quality of life, so they can live within their energy envelope. This is a very important symptom for clinicians and patients to understand, as it is quite common and quite disabling for many. We also see persistent fatigue that's not triggered. We also see difficulties concentrating and memory changes. We refer to more commonly as brain fog, which Dr. Schamess will speak to in detail. We see recurring headaches, lightheadedness, fast heart rate, sleep disturbances, also shortness of breath and cough. You've heard about the taste and smell abnormalities, and then also GI manifestations. Now, as we learn more about long COVID, it appears that it is unlikely one diagnosis and more likely an umbrella that has individual phenotypes. However, this is a very heterogeneous disease. You can have certain symptoms and not have others. You have different combinations. So it is unclear at this time how to characterize these phenotypes, and this is a really important area of research currently. But there are two phenotypes that I think are really important that I'd like to highlight here. And you can see right here, postural orthostatic tachycardia syndrome, or POTS. If you're a clinician, you may have heard of this, but not a lot about it. This is a form of dysautonomia, and we see this in long COVID as well as other forms of dysautonomia. And this classically is that person goes from sitting to standing, they get short of breath, dizzy, lightheaded, they can get headaches, brain fog associated with it. We see it more commonly in younger patients, we see it more commonly in females, but this can occur in anyone, and it can be really quite disabling for the patient. Another phenotype to mention is myalgic encephalomyelitis chronic fatigue syndrome, MECFS. It's a mouthful, but you know it more commonly as chronic fatigue. And this is a very real disease that has diagnostic criteria that our next speaker will speak to, but this is something that's oftentimes discounted in the medical community. This is a disease that also oftentimes is very disabling. The post-exertional malaise is a hallmark symptom of it. It also can wax and wane. Both of these phenotypes existed long before long COVID, and they have not received the scientific rigor that they really warrant. So we're kind of behind the 8 ball on both of these diseases. Very common, oftentimes disabling, important to look out for in long COVID. So who's susceptible to long COVID? The answer is everyone, unfortunately, and we find that the more COVID infections you have, the more likely you are to then go on to develop long COVID. So just because you didn't get it after your first infection does not make you immune, which is quite concerning. We tend to see it in at higher rates in African Americans, Hispanic populations. We see it occur at higher rates with those who had severe acute COVID infections. But by mass, we have had more mild acute COVID infections, so we are more likely to see long COVID occurring after a mild acute COVID infection. And that's important for clinicians to understand as well, that someone could have had a very mild COVID infection and have very severe long COVID. We see it occur at higher rates in women, those who are unvaccinated. Also not mentioned here, LGBTQ populations. We see it higher in rural populations. So everyone is susceptible, but these are your vulnerable populations. Long COVID is more common than we give it credit for. So this is data out of the CDC showing that approximately 7% of the population is impacted by long COVID. And it appears to occur at higher rates in those who are aged in their 30s, 40s, and 50s. So this equates to about 20 million adults in the US alone. And it's really concerning because in the same study, we see that approximately a quarter are heavily impacted in their daily function and quality of life. So many of these are unable to return to work at full hours or maybe unable to return to work at all. And again, this is occurring at higher rates in our working age adults, those of child rearing ages. There are conflicting data on the prognosis of long COVID. We'll see some retrospective EHR studies showing that the majority of patients recover in time. We also, in this study, see the converse, where those who have symptoms at 6 months, the majority are unlikely to recover at 2 years. And this is important because, sorry, I got distracted. So you see on the figure on the right, this is the trajectory of individuals over time, and you see that the trajectory is different. It's highly variable between individuals. But you see those that have more severe infections are less likely to recover. And we do see improvement over time in our patient population, but those that recover, we see that is less likely. So we haven't defined the underlying drivers of long COVID, but we do have a number of rigorous studies that show us great insights into potential underlying mechanisms. So in the first panel, you'll see here that there is evidence of persistent viral antigen that exists at later time points, up to 12 months, in individuals who have long COVID compared to those that have no persistent symptoms. It's unclear if this is persistent replication or if this is just persistent antigenemia. But we do see immune responses in relation to this. So we see spike antigen-specific T cells at later time points. We see T cell fatigability. We also see some viral reactivation of other viruses as well, and what the interplay is there in between COVID and these viruses. We see evidence of gut dysbiosis, so changes in the gut flora that then impact immunologic responses to this change in flora, as well as persistent viral antigen within the gut. We see alterations in memory B cells and signs of reactivity, signs of autoimmunity. We also see here that we have endothelial dysfunction, signs of microclotting. These are things that you're not going to pick up on your CT scans, and it's something that we're seeing in these patients that might be contributing to their symptoms. And then finally, we see signs of dysfunctional neurologic symptoms. We see signs of autonomic neuropathies. We see activation of microglial cells that are associated with cognitive dysfunction. Also not listed here, we see signs of mitochondrial dysfunction as well. So impaired oxygen extraction from the peripheral muscles and signs of muscle necrosis. But it's unclear how these different mechanisms interplay and whether there are different mechanisms that drive different phenotypes of long COVID. We have limited evidence-based guidelines on how to diagnose and manage long COVID. You see here that the AAPM&R, American Academy of Physical Medicine and Research and Rehab, have largely provided the guiding principles and consensus guidelines on how to manage these diseases. They're quite comprehensive, and you see they're by organ system and by symptomatology, and we have a link here at the bottom to access these. So there are no FDA-approved medications to treat long COVID. And I think that's a really important thing to highlight because we are 4 years into the pandemic and we have treatments for acute COVID, but not long COVID. What I highlight here are repurposed drugs that we often use in our clinics that are based on anecdotal and published observational data, as well as small clinical trials in long COVID and overlap syndromes like ME/CFS and dysautonomia. I won't go into this in great detail because, again, this is a very low data zone. We're in the situation where we don't have a lot of resources, and we are responding to that call to action from that quote that I mentioned at the beginning of this presentation, where we really have to meet patients where they are and attempt to find some relief for their symptoms. So what's the next step? We need to identify effective drugs for long COVID, and the infrastructure for clinical trials is largely through the Recover initiative. You see here that we have Recover Vital that looks at Paxlovid, an antiviral for viral replication. We have Recover Neuro looking at neurocognitive rehabilitation for those who are cognitively impaired. We have Recover Auto, looking at Avabradine and IVIG for those with POTS or autonomic dysfunction. We have Sleep, looking at modafinil and solriamfetol for sleep dysfunction. And we have Energize, looking at cardiopulmonary rehabilitation for those with exercise intolerance. There's a couple other clinical trials that are worth mentioning. Reverse LC that looks at baricitinib, a JAK2 inhibitor for immune dysregulation in long COVID, as well as monoclonal antibodies for viral persistence and persistent antigenemia. But this is largely where we're at. And so, again, I want to highlight that we have approximately 20 million Americans, many of which are disabled, and we only have these clinical trials. We need to expand the scope and the diversity of clinical trials and not just run these clinical trials through one hub academic institution. And so this brings us to the path forward. We really need to bolster research infrastructure. No one knows this better than the patients with lived experience and caregivers. And through their boots on the ground advocacy, they largely should be credited for the funding for the Recover initiative. When they did not see the results in the timeline that they sought to achieve the Recover, they then continued to advocate and requested for a moonshot bill from Congress. And as a result, the U.S. Senate Help Committee held a full committee hearing on addressing long COVID, advancing research, and improving patient care. And you see here, they invited 3 patient advocates and caregivers who provided really powerful testimony on their experience and the disability that they have experienced, the stigma and the alienation they've experienced in their journey with long COVID. They also invited 4 clinicians and researchers who highlighted the way that we can structure these improved bolstering of research. The key items that were addressed were, we really need to define these phenotypes. If we don't know what we're treating, we won't be able to find effective treatments. We need to develop diagnostic biomarkers. This is a heterogeneous disease that's complex for primary care doctors to diagnose, so using biomarkers to help assist this. We need surrogate biomarkers. These can be used in clinical trials to see if the physiology is improving in response to treatment. We need equitable access to clinical trials. This is for people who have access to transportation issues, those in rural populations that can't get to study sites, people that are so disabled by their long COVID they can't come to in-person visits. So we really need to have decentralized trials, virtual trials that patients can participate in. We need to increase the scale and diversity of clinical trials. Again, this doesn't need to be run through one hub for this volume of patients. We need to have more academic sites involved. We need to have more clinical trials. We need to have a diversity of the treatments that are trialed. We need to coordinate data sharing and linkage. There are multiple cohort studies that are collecting data, really in silos. We need to connect this, leverage this data so that we can answer important questions about long COVID. We need to establish an NIH Center for Infection-Associated Chronic Conditions. This is really important, and we need to fund it appropriately with $1 billion per year. We need to be able to unify long COVID with other neglected diseases that have a lot of overlap. There's more power in numbers here. In terms of clinical care, we need to expand long COVID care and networks. We need to establish evidence-based clinical guidelines, identify bias in diagnosis and treatment. This is especially true in our marginalized and our vulnerable populations. And then we also need to create programs for these underserved populations. And the response was largely positive. And so it showed that the Senate was really listening to the messages of the patients and of the clinicians and researchers. And as a result, Chairman Bernie Sanders has released a moonshot bill, and it very much parallels what was discussed in that meeting. So $1 billion in mandatory funding per year for 10 years. This should be funneled through a centralized coordinated entity at the NIH that is created specifically for long COVID and IACCs. The NIH should establish a new grant process for clinical trials to expedite clinical trials, include decentralized options, and those that prioritize repurposed drugs. We need to establish an NIH advisory board that then oversees and quarterbacks this research. Require NIH to establish a long COVID database for that linkage of studies across cohorts. And then require federal entities to provide continued education support in form of programs for marginalized populations, for the community, for patients, providers, and for researchers. This has been put forth in front of the Senate in August and in front of the House in September, but we're already starting to see downstream effects of this. So NIAID, which was not historically involved in Recover, has moved into this space with Recover TLC, so treating long COVID. And they held a 3-day working group meeting where they included those same key stakeholders, patients, caregivers, researchers, and clinicians. And the themes here very much overlap what's been discussed in the HELP, the U.S. HELP committee meeting. So urgent timelines, patient partnerships, so patients helping to design these clinical trials that would be the most pertinent to them and selecting medications that they think will be the most helpful, inclusion of these vulnerable populations. Develop long COVID endpoints. This is really important because currently most clinical trials are based on patient-reported outcome measures. So do you feel like your fatigue is improving over time? This, as we mentioned, is a waxing and waning disease. So you can imagine that your symptoms may improve or decline irrespective of the medication. So this will affect the treatment results of the study. Also, this is a heterogeneous disease, so fatigue in one person may have a different mechanism than fatigue in another. So using one medication to treat both of those fatigues, you'll end up with different results, and this will impact the results of the study. So that leads us to the need to identify and develop biomarkers. These biomarkers will help us assess the change in physiology over time in response to the treatment. And these really need to happen in parallel and not in series. We don't need to wait until the pathophysiologic studies have definitively defined these biomarkers to be able to move on to clinical trials, because that puts us far behind in finding effective treatments for patients. We need to include these biomarkers in clinical trials as secondary endpoints and see how these medications affect these biomarkers. We need small exploratory clinical trials for treatments that have promise but less data, and then large clinical trials for those that have more data, we have more confidence in them, and have these be adaptive platform trials so we can trial multiple drugs against a shared placebo. So more drugs, less patients on placebo. We need to look at repurposed drugs currently used in clinics to ensure that they are effective. We also need to work with industry to design drug development so that we can find cures for long COVID. Both are important. And then we need to build on an existing infrastructure. So we don't need to reinvent the wheel for Recover. We just need to build on it. We need to expand beyond Recover. We need to learn from other effective networks like the ACTIVE network and acute COVID that rapidly identified treatments. And then if you'd like to highlight this QR code here, this is an agent submission portal. I think this is the most exciting thing that NIAID is doing. If you have medications that you think should be tried in long COVID, they're taking input from everyone. This is something that didn't exist when the Recover clinical trials were being designed, and something that I think is really important in helping with equity across clinicians, patients, and researchers. Okay, so let's shift gears. So now I'd like to talk about clinical care and long COVID care networks. This is the percentage of individuals in our healthcare system who have the ICD-10 code U099 post-COVID condition. So this is the diagnosis code for long COVID, and we found in our healthcare system, 2 different healthcare systems, that 0.1% of our patients carried a diagnosis of long COVID. And this is in comparison to the 7% that I mentioned previously out of CDC of the prevalence of long COVID in the population. So regardless of whether this is an overestimate or underestimate, you can tell there's a clear disparity here. And this is an area for improvement in primary care screening. And this creates a care equity gap. These patients aren't getting recognized, they aren't getting linked to care. And I suspect that this is common in other healthcare systems as well. Because this is from the HHS Health Plus survey, and I'd like to walk you through it. It's probably small for you, so I will walk you through it. In the beginning, this is the typical journey of a long COVID patient. In the beginning, the patient has symptoms, and the first branch point is they have to associate their symptoms with long COVID. And this is an important branch point because as I get out into the community, I recognize that there are patients, when I describe long COVID, they say, oh, that really sounds like me, but I thought I was just getting older. And they're only 45, so that shouldn't be the case, right? And then when they do associate their symptoms, the next branch point is they see a clinician. And unfortunately, too often, they end up down here, which is they see a clinician that is either unfamiliar with long COVID or doesn't believe in long COVID. And that results in their symptoms either being misdiagnosed or discounted. This is really disheartening for patients, many of which are fairly disabled from this condition, as you can imagine. In a better case scenario, they present to a clinician who is familiar with long COVID, at which point they are then referred to long COVID clinics or clinical trials, but we are few and far between for both. So what typically happens is the patient is then referred to subspecialists, and as this is a multisystemic disease, oftentimes they're referred to multiple subspecialists, each of which does their own workup, which results in a really cost-prohibitive workup for the patient. Oftentimes the results are negative. We know things are going on inside the body, but they're not part of our typical clinical diagnostic workup. And then the patient's left without treatment, without a diagnosis, also very frustrating. This impacts healthcare seeking behaviors. I hear patients say, well, the doctors don't know what they're doing. And so that impacts their willingness to seek care for their diabetes or their hypertension. So this is a real care equity gap. And you can imagine this is also amplified in populations who are marginalized, who have historic barriers to quality health care, those that are economically disadvantaged. So as Dr. Friedli mentioned, the Agency of Healthcare Research and Quality aims to mitigate some of these challenges by selecting 12 sites across the United States to establish a long COVID care network with the goals of improving access to equitable care, person-centered approach, and multidisciplinary care. And I will mention our approach in the Atlanta Long COVID Collaborative. As Dr. Friedli mentioned, each site has the latitude to have their own nuanced approach that's specific to their patient population, but there's a lot of overlap. So in terms of care access, I'll just highlight some of the key issues. We are expanding telemedicine services and expanding to e-consults as well. Telemedicine is one of the best things as a clinician you can do for care equity because these patients oftentimes have post-exertional malaise. It will actually make them ill to come into an in-person visit that can somewhat be mitigated from a telemedicine visit. It also allows better access for those that have transportation issues, caregiver issues, those in rural populations. So this alone helps bridge care equity and something that primary care doctors can already do. We have the opportunity to increase social services. This is particularly important in my population that is an urban safety net population, being able to help them get into care and then retain in care. So helping with disability, SSI, Medicare, Medicaid, and transportation. Also, community outreach to help those individuals that have these symptoms that need to associate it with long COVID so they can then get into care. We are also working with provider education, not only to increase awareness and increase referrals to our long COVID clinic, But to begin to build the infrastructure so that long COVID can be provided at the primary care level. In terms of person-centered care model, we have care coordination staff, and they're there to support the patient, to help them navigate the system, expedite referrals, and to mitigate some of the challenges that they experience. We also have a patient advisory committee comprised of individuals that receive care in our clinic, as well as some of those national patient advocates that have been boots on the ground since the beginning. And we do a person-centered programmatic evaluation, make sure we're meeting the needs of our community. And then in terms of multidisciplinary care, we have expanded the subspecialty service lines offered that have expertise in long COVID as well as behavioral health. And we do multidisciplinary case conferences. We get everybody together, we discuss complex cases, and this serves to mitigate these unnecessary referrals. We don't have to shuffle patients through the system, and also expedites care because they don't need to wait 6 months to see a gastroenterologist. And this has been really successful for our site. But we're not the only clinics in the United States. Here you see in the light blue, these are examples of long COVID clinics across the United States. But this is a gap as well, because this map is from 2021, and I know that some of these clinics have closed, and I'm not aware of any site that has an up-to-date listing of these sites, and we don't understand our care coverage for long COVID across the United States. That is problematic because you see in this figure, we have the percentage of adults who have ever had long COVID by state, so it gives you an idea of the density. And when you overlay these, you see that there are certain states that have a very high density of long COVID with very little coverage. And again, these are only in the light blue. The dark blue are physical therapy programs that have some capacity to support long COVID. I would also highlight that with a prevalence of approximately 20 million, this is probably still not sufficient, even in areas of low density. I'd like to compare this to a disease state like diabetes that has a prevalence of about 38 million. You could imagine as a provider, if we tried to provide diabetes care exclusively in subspecialty clinics like this across the United States, it would be untenable. And I think long COVID is the same way. So that brings us to our path forward. We need to extend our long COVID networks. We need to eventually decentralize long COVID care. So in terms of extending our networks, first thing we need to do, we need to have an up-to-date map of long COVID clinics, understand the regions that we have long COVID deserts. We need to be able to link these networks. As a long COVID provider, I have very much felt siloed until AHRQ came through and was able to link our networks. And I've heard this from other long COVID providers as well. So I think there's a real interest here. This is already happening through SIGM, Society of General Internal Medicine, where Jessica Bender has created an interest group, ACP, where Anita Chopra has an interest group. We really need to link these networks. We need to expand access and ensure that we have geographical coverage, especially in these areas of high density and low access. And we need to establish a common mission with guiding principles across these networks, so we're all aligned in what our approach is. And then it's incumbent upon us to then define the evidence-based approaches to diagnosis and management, as well as treatment of this disease. But as I mentioned, we will need to decentralize long COVID care. So what will that look like? We need to build capacity at the primary care level. They are overwhelmed with their current responsibilities. Long COVID is very complex and challenging, and so we need to help them to identify and address common barriers. And we need to prioritize federal qualified health centers as well as healthcare systems that support these vulnerable populations. These populations that are more likely to develop long COVID, these areas that have less access. Common barriers that we have encountered beyond awareness and education, there are a lot of time constraints. There are constraints in the providers being able to receive education from us, time constraints within the patient visit, being able to provide this care in a 15 or 30-minute visit that is forced upon the primary care doctors. There are staffing limitations to be able to provide this wraparound care that we provide in our clinics. And there are a lot of challenges with accommodations and disability. And I also hear providers mention they just don't have buy-in from leadership. So we need to help with that investment. So this provides multiple opportunities for partnerships between long COVID networks and primary care networks. And this is one of the things that I propose. So in phase 1, we could assist with providing symptom-specific patient-reported outcome measures that help with diagnosis and management and the workflow in a primary care setting. We can help with needs assessments, help them leverage the services and the resources that they have and provide consultative support on this. We can provide guidance on accommodations and telementoring about long COVID. In phase 2, I propose that we share note templates. This is something you can already find on the AAPM&R website and something that other members of the AHRQ community are already doing at the local level. This helps walk a clinician through the workflow, as well as EPIC dot phrases for institutions that have an EPIC electronic medical record. This also can help walk them through the workflow. We'd have our assessment and plan for a symptom like brain fog, how we might work it up, what treatments might we consider, and this can help guide them through the management. We can, as a network, provide culturally competent patient education materials. A lot of the visit is just trying to convey our knowledge to the patients and being able to fit these visits into that 15 or 30-minute allotment. We might be able to might be better able to do that if we have these patient education materials. In phase 3, we need to provide these evidence-based guidelines on management, modular protocols that can be modified in the community that are practical. Disability often falls on the primary care physician, but we don't receive any education on how to do it. So providing how-to guides to help the primary care physician. And then primary care physicians also mention we don't have the capacity to screen for long COVID. We already have a very busy clinic. So could we assist with AI-driven long COVID screening tools? These already exist in the Recover N3C, where they have used a machine learning tool to pretty effectively identify long COVID patients within the EHR. Is this something that we could harness to then alert the primary care doctor, hey, your patient may have long COVID? And so showing some of these phase 1 options, these are the patient-reported outcome measures that we use as triggered-based management in our clinics. These are not validated in long COVID. As I mentioned before, there's a real importance of validating patient-reported outcome measures, not only for clinical practice, but for clinical trials. But these are often used currently in clinical trials, and we found that these are really helpful in our clinic. They're not used across all AHRQ sites, but some sites do use these with benefit. Here are some accommodation resources, so the Job Accommodation Network, as well as the HHS Plus survey. And then there are multiple telementoring options at this point. These echoes are really fantastic. So I've watched a number of these, and even as a long COVID provider and researcher, I still learn something when I watch these. They're really great. The CDC COCO calls are great, and then we also will be launching the Long COVID Clinical Podcast soon as another mechanism for information. And in my last couple minutes, I just want to circle back to infection-associated chronic conditions. So as I mentioned before, these are largely neglected diseases that have not received the attention from the scientific community or clinical community that they really warrant. These patients oftentimes are dismissed during clinical encounters, and I think it's largely because these symptoms don't tend to fit into our illness scripts, like I mentioned before. And that's because we don't learn about them in medical school, and that's something that we need to work on. This was also recognized by NASM, and they had a working group meeting last year on a research agenda in infection-associated chronic conditions. Some of the key themes here. There's substantial overlap in the pathophysiology within IACCs. We see ME/CFS and long COVID very similar. We have a need for diagnostic testing at different stages of the disease. We see that the physiology may evolve over time in some IACCs, and the biomarkers may as well, so we really need to understand those better. We need to identify therapeutic targets, just like in long COVID, and we need to prevent these IACCs and have research in that space. And so this will all require collaboration and coordination between stakeholders, both clinicians and researchers, to advance the science. And that was the impetus behind requesting that we have one entity at the NIH to be able to fund this research. You can imagine if there are multiple institutions, it's so easy for this just to be dispersed and fall through the cracks. We need attention, we need a coordinating entity, and we need funding specifically for these. There's more power in numbers here. And in this vein, we have established the American Association of Infection-Associated Chronic Conditions. You see our key stakeholders here: Anita Chopra, myself, Andrew Schamess, Hector Bonilla, and Lisa McCorkle. Our mission is to advance education, advocate for research, enhance clinical care, and promote equity. And we aim to do this promoting equity by increasing awareness, hoping that patients ultimately won't be discounted during their clinical visit, advocating for policy change and funding in this space, and a universal center at NIH. In terms of education, this is more than just patient community education and clinician education. This is also medical school curriculum redesign. We need to talk about this in medical school so they're aware it fits into their illness script. But we also need to teach clinicians what to do when things don't fit into your illness script, and that we shouldn't then just discount patients and the symptoms they're experiencing, because we will always have new and emerging diseases that don't fit into an illness script. We want to promote research and funding for research. We would like to provide resources as well as professional development through echo sessions, podcasts, and professional society presentations. I think this is really the path forward in long COVID, unity with IACCs. These other diseases have been through the exact same experience as we have. However, we are actually better funded and there's more attention for long COVID than these other marginalized diseases, and we need to link together. And these are my references, and I'm happy to take any questions. Thank you. Yes.
What do we know about the possibility that everyone may have long COVID? As in, if it's a chronic virus that has viral persistence, potentially even people who aren't sick now could be sick in the future, since we're only 4 years in. Can you speak to anything about maybe everyone having long COVID?
Yeah, no, that's a really excellent question. We aren't at a place where we know enough about long COVID to understand these reservoirs. Some of the studies that we have, we see that in those that currently have symptoms, there are some evidence of reservoirs, as where those that don't have symptoms, there isn't evidence of reservoirs. But to your point, oftentimes, patients may have full recovery of their acute COVID infection and then go on to have long COVID symptoms. It's not always a persistence from acute COVID as this longitudinal direct line. And so symptoms could arise for people at any time. And we don't know what that time span is between one COVID infection and the latest possible time point where it could onset. And it's also challenging because as COVID becomes so prevalent, there are so many repeated infections. And so whether or not long COVID was actually related to this most recent infection or a previous infection is also unclear, and it gets really challenging to investigate that, as you can imagine, to design studies to understand that better.
Thank you so much, Dr. Walker. And I think in the interest of time, we will have more questions, opportunity to ask more questions in the panel discussion. So thank you very much for this enlightening talk. Thank you. So with that, I will go ahead and introduce our next speaker. So our next guest speaker is Dr. Elizabeth Unger, who will speak to us about myalgic encephalomyelitis, chronic fatigue syndrome, MECFS, to provide context for long COVID and other post-acute infection syndromes. Dr. Elizabeth Unger is Chief of the Chronic Viral Diseases Branch in the U.S. Centers for Disease Control and Prevention, and is responsible for guiding research and public health studies encompassing molecular pathology and epidemiology of human papillomavirus associated diseases and MECFS. She served as co-lead of the post-COVID conditions team in the CDC COVID-19 response and leveraged understanding of MECFS to address long COVID and to advance research and treatment for both conditions. She was a member of the National Advisory Neurological Disorders and Stroke Council MECFS Research Roadmap Working Group. CDC's MECFS program supports education about MECFS, chronic fatigue, through its websites and medical education courses. Dr. Unger has been instrumental in developing these courses. Currently, the program is also participating in CDC's Infection-Associated Chronic Illness Working Group. Dr. Unger is a path-breaking researcher, she's a teacher, she's a mentor, and I have had the honor of meeting with her in person. Please join me in welcoming Dr. Unger.
There we go. Thank you. Thank you very much for the invitation and for sponsoring this symposium. I'm really sorry I can't be there with you in person, but it's a pleasure to join you. Could you, we didn't have practice with my slides, so could you bring up the first slide, I hope? There we go. Okay. And then the next slide. I don't have any conflicts of interest to declare. And the picture here is of the members of the branch, as well as the Georgia chapter of ME Action, who met on International MECFS Awareness Day on the CDC's campus just before the dusk, when the blue lights on the building became visible. In addition, I need to let you know that the talk is really just mine and does not represent the official position of the Centers for Disease Control and Prevention. Could I have the next slide? I'm really glad I was able to listen into Dr. Walker's talk because we not only make some of the same points, we actually have some of the same slides. So apologize for repetition, but perhaps that means it's kind of important. So my outline is that I'm going to start with an introduction to MECFS, myalgic encephalomyelitis chronic fatigue syndrome. Describe prior considerations of infection-associated conditions and illnesses, and from now on, I'll probably refer to these as AHRQs. Describe the complexities of AHRQs and implications for how MECFS relates to long COVID. What we've learned from MECFS, and finally, a few closing comments. Could I have the next slide? So introducing MECFS. Next. MECFS is a serious long-term multi-system illness. You've already heard Dr. Walker talk about post-exertional malaise. This is a hallmark of MECFS. Post-exertional malaise is the worsening of all symptoms, not just fatigue, after previously tolerated activities, and these can be physical or mental. Activities are limited by the fatigue and associated symptoms, and the illness can persist for years, leading to poor quality of life and sometimes total disability. About 1 in 4 patients with MECFS are home or bedbound for prolonged periods, and sadly, patients are often not believed by healthcare providers. The lack of known pathogenesis and diagnostic tests contribute to this stigma. Also contributing, the illness does wax and wane, also as mentioned by Dr. Walker. Patients usually come to the clinic on good days and may not appear ill to their clinicians. Next slide. In 2015, the Institute of Medicine, which is now the National Academy of Science, Engineering, and Medicine, considered all the data on ME/CFS to develop clinical diagnostic criteria that could help clinicians recognize the illness. The first that they came up with is impaired ability to engage in pre-illness activities for at least 6 months that's accompanied by fatigue. Notice that the emphasis is on activity limitation. Second is post-exertional malaise, and I will occasionally use the abbreviation PEM. Third is unrefreshing sleep, and fourth is either cognitive impairment or orthostatic intolerance. Now, these are the symptoms that are required for the diagnosis or recognition of it, but patients often have many more symptoms. Could I have the next slide? As many as 3.3 million Americans have ME/CFS, and many have not been diagnosed. Most have been ill longer than 5 years, but only about 50% continue to seek medical care. ME/CFS can affect anyone, but the highest prevalence is in 40 to 50-year-olds. Children and adolescents are also affected. In adults, it is 3 to 4 times more common in women than men. And there's a suggestion that the prevalence is higher in minority and socioeconomically disadvantaged populations. And unfortunately, I say just a suggestion, as studies and surveillance are difficult to do in these populations. So our data is limited. Next slide. Diagnosis relies on recognizing the characteristic symptom profile and clinical history, and it follows the 2015 IOM diagnostic criteria. Objective biologic abnormalities are reported in many studies, but these lack the diagnostic sensitivity and specificity. Post-exertional malaise is characteristic, but this requires probing during the clinical interview. As you might imagine, patients, particularly those newly affected, don't walk into the office with the chief complaint of post-exertional malaise. Asking about what activities are limited and what happens if these are attempted are examples of how to probe and ask about PEM. A careful medical history, physical examination, and testing to identify treatable illnesses that could cause or contribute to symptoms is also required. And it really requires a very good clinician to care for patients with ME/CFS. There are no approved drugs for ME/CFS, and care is based on symptom management. And I can't emphasize enough that empathetic, supportive care can really reduce suffering. And next slide. Now I'd like to shift to considerations about infection-associated chronic conditions and illnesses. And ME/CFS has been recognized for years, and so have AHRQs. Could I have the next slide? In 2004, the Institute of Medicine first considered the infectious etiology of chronic diseases. And this report emphasized the breadth and complexity of the link between infections and chronic diseases, noted the wide range of pathogens involved, and the challenges to making the link between infections and these conditions. Challenges included the length of time between infection and illness, sensitivity of tests detecting the infection, and questions about the appropriate samples to test. The report also emphasized that the outcomes of infection were noted to be influenced by multiple factors, such as the specific infection agent, the environment, the route and dose of infection, host age, and genetics. In addition, a single infection may lead to one outcome, such as poliovirus and flaccid paralysis, or to multiple outcomes, such as SARS-CoV-2, leading to lung fibrosis, lupus, or migraines. In addition, different infectious agents may lead to the same chronic outcome, such as Salmonella, Shigella, and Klebsiella infections, resulting in reactive arthritis. Next slide. The 2004 report did not focus on what has been called post-acute infectious syndromes. These have been recognized for many years, mostly as failure to recover from a wide variety of infections. The infection is not always documented or known. The core symptoms will probably sound very familiar: exercise intolerance, activity limitations due to fatigue and symptoms, brain fog, sleep problems, and recurrent flu-like symptoms. A wide variety of additional symptoms may also be present, and this results in a very heterogeneous picture and a complex illness requiring symptom management. Next slide. In 2024, NASM reconsidered infection-associated chronic illnesses, focusing on the unexplained syndromic illnesses that follow acute infection. They decided against the use of post-acute infection syndrome because of the uncertainty about whether the triggering infection was actually cleared. The talks were largely infection-specific. The syndrome that followed each infection was studied individually, and none had specific diagnostic tests or treatments, and symptom overlap was significant. The importance of using a patient-centered view for these illnesses was emphasized, as well as the limitations of a siloed approach to studying these conditions. And Dr. Walker also highlighted this report with a very interesting quote about the challenges patients face living on the edge of our understanding. Next slide. ME/CFS was mentioned in most of the talks, as ME/CFS is sort of a prototypic infection-associated chronic condition, and that falls in the group of these unexplained syndromes. Infection is a recognized risk factor, although no one pathogen is implicated in ME/CFS. Long COVID brought attention to this illness, and ME/CFS is recognized as a part of long COVID. In addition, non-infectious risk factors are recognized, including stressors, genetics, and environment, a theme noted in the 2004 report on chronic conditions following infections. Next slide. As Dr. Walker showed you, the 2024 NASM long COVID definition states that long COVID is an infection-associated chronic condition that occurs after SARS-CoV-2. And I'm not going to go over the details since she just went over that with you. Next slide. I'm going to shift to emphasizing that the AHRQ terminology encompasses the chronic outcomes of infection discussed in both the 2004 and 2024 NASM reports on infection-associated chronic illnesses. And this has implications for how ME/CFS relates to long COVID. Have the next slide. This slide shows a grouping of the NASM-listed diagnosable presenting conditions of long COVID. And I've grouped them this way that may be helpful in organizing our thoughts about the complexity of AHRQs. It certainly is important to recognize the full range of illnesses that can be triggered by infections like long COVID, like COVID. Group 1 conditions include things like interstitial lung disease or cardiovascular disease, and could be attributable to direct organ damage from the infection. Group 2 conditions, such as are autoimmune conditions, such as lupus and rheumatoid arthritis. And group 3 are the unexplained syndromes, many of which are overlapping, such as ME/CFS, POTS, and fibromyalgia. Should be noted that mood disorders and anxiety are common in all persons experiencing chronic illness. Similarly, symptoms such as fatigue or cognitive impairment may be attributable to conditions with any of the 3 groups, whereas others, like post-exertional malaise, may be more prominent in only one group, such as group 3. It should be noted that the conditions in group 1 or 2, those that were focused on in the 2004 IOM report, have diagnostic abnormalities in clinical tests and established therapies that are not really altered by their linkage to COVID-19. Group 2 conditions generally require a combination of biomarkers and clinical history, and none of these conditions are particularly simple. All of them are complex and benefit from multidisciplinary support. However, I would argue the group 3 conditions, those focused on in the 2024 NASM report, present the most challenges to clinicians. They're symptom-based, poorly recognized, and correspond to the group that had been called post-acute infectious syndromes. Could I have the next slide? Of course, patients may not fall neatly into any one group. And the NASM 2024 report on long COVID describes long COVID as an infection-associated condition. But it may be more helpful to recognize that it's a group of infection-associated conditions, plural. In this sense, long COVID isn't a sort of an umbrella term, and this has already been emphasized by Dr. Walker. Group 3 conditions, those most challenging for clinicians to recognize, are the area where lessons learned from ME/CFS are most valuable. The next slide. I'm now going to describe how experience with ME/CFS helped and is helping the approach to long COVID patients. And I will say at the onset of the COVID pandemic, clinicians caring for patients with ME/CFS and the public health workers working with ME/CFS could anticipate and did anticipate that there would be a long-term illness resembling ME/CFS following this pandemic. Next slide. And CDC's ME/CFS program has resources that are applicable to long COVID and other AHRQs. These were developed over many years and weren't developed by CDC alone. We had the input of patients, caregivers, medical professionals, and multiple government agencies. The tools include standardized measures of symptoms because these are learning how to gather information on patients' self-reported symptoms is really important. We also have toolkits for patients and healthcare providers. We have clinical education materials and links to continuing education courses, guidance on management, guidance on recognition of PEM, partnerships with patients, and pediatric considerations, including specifically information for teachers and schools about how to accommodate this illness. Next slide. Experience with ME/CFS allowed us to recognize that there would be challenges in meeting the clinical need for the care of patients with long COVID. The most frequent question we continue to be asked at CDC by patients with ME/CFS is where they can go for clinical care. Access to healthcare providers with knowledge and expertise about ME/CFS remains a major concern of patients. Tertiary care centers have long wait lists, and there is a need for primary care clinicians to be educated and empowered to care for these patients. And this was the impetus for the Long COVID and Fatiguing Illness Recovery Program. Next slide. The Long COVID and Fatiguing Illness Recovery Program was developed to evaluate a multidisciplinary team approach to improve the quality of life and support recovery of people living with long COVID, ME/CFS, and related infection-associated chronic illnesses and conditions. This was a collaborative project with the Family Health Centers of San Diego, Project ECHO, University of Washington Medicine, and the University of New Mexico Health Sciences. And the goal was to develop confidence in managing these conditions among safety net clinic primary care providers at the federally qualified health center, and to disseminate and advance promising management practices. Telementoring through Project ECHO was at the heart of the program. Have the next slide. A unique and important feature of this program was that lived experience experts, many of whom had ME/CFS, participated in every session. This established a patient-centered dialogue. The lived experience experts provided a unique perspective on the illness, as well as their own experience with symptoms and approaches to management. Their voice validated the experience of the patients presented in the case discussions. The clinical subject matter experts included physicians with expertise in caring for patients with ME/CFS. They were able to explain the importance of guiding patients to avoid post-exertional malaise. They shared information on symptom management and diagnosis, and a lot of this information can be accessed at the ME/CFS Clinician Coalition website. They also suggested use of the office-based NASA lean test to diagnose orthostatic intolerance. And I think in summary, what I'd like to emphasize is that the ME/CFS patients led the way in helping patients living with long COVID understand their illness and were invaluable. Now I'd like to, next slide. Just a few closing comments. Next slide. And there are many arguments for why long COVID advances need to include ME/CFS and other infection-associated conditions, as well as vice versa. The shared symptoms and approach to clinical management argue for inclusion of all these conditions in one clinical setting, ideally one that fosters multidisciplinary care. And it has been very frustrating for patients living with ME/CFS to not be able to access the care that's being developed at long COVID clinics. Clinical guidelines that developed are applicable to both conditions. And as an example, the AAPMNR collaborative compendium that is being developed and the ME/CFS Clinician Coalition both have guidelines that are applicable. And the PAIS collaborative compendium, does include language indicating that the guidance is applicable, widely applicable. To avoid the siloed approach, including AHRQs with different known or unknown infectious triggers as comparison groups can help identify similarities and difference between these conditions in research. Research and clinical trials of these conditions face similar challenges and the need to account for the heterogeneity of these conditions. And next slide. Finally, just a reminder that facts don't convey the full picture of these illnesses. You really need to listen to your patients and their caregivers. Empathetic support can reduce suffering. And this includes considering your own clinic situation and looking around to reduce barriers to care by making accommodations. These include things such as providing space for lying down or at least raising feet to reduce this postural hypotension. Option for a quiet, dimmed lighting area, as sensitivities to light and noise are common. In addition, be sensitive to the patient needs when walking them to the exam room. Surprisingly, a rapid pace can leave them in the lurch and leave them feeling abandoned. Next slide. I would like to thank you for your attention, and I would like to thank and acknowledge my CDC colleagues in the chronic viral diseases branch for the work that made this possible. I'd like to thank those involved in the long COVID, fatiguing illness, and research recovery study, and most of all, study participants and caregivers. And the collage there is our another recognition of MECFS Awareness Day. And it says May 12th is International MECFS Awareness Day. We stand together and wear blue to support people with MECFS, their caregivers, family, and friends. Thank you.
For this outstanding presentation and this amazing learning experience. We really appreciate you. And we will now break for 5 minutes to give everyone some time to stretch out and just take a little breather. And during this break, if you guys want to step out and take a quick bathroom break, that's good as well. But we do have a lot of questions in the chat that our virtual attendees are sending over, and I would like to invite Dr. Walker to please come and answer some of those. Would Nikki, would you like to give her the questions?
Yeah, we'll start.
Okay. All right.
Here we go. Okay, we're back. Thank you, everyone, for being flexible with our schedule. We are going to jump into our next speaker. Our next speaker, who I'm very pleased to introduce, is Dr. Andrew Schamess, who will be speaking about the management of cognitive symptoms and small fiber neuropathy. Dr. Andrew Schamess is an associate professor in general internal medicine at The Ohio State University. He has been leading the post-COVID recovery clinic there since 2021. He has given many national presentations for clinicians on managing long COVID, some of which I've attended. He is the principal investigator of a pilot randomized control trial of amantadine for the treatment of cognitive symptoms in long COVID. He is one of the founding members of the American Academy of Infection-Associated Chronic Conditions, as you heard. In addition to long COVID, he has an interest in sickle cell disease, chronic pain, and mindfulness-based pain management. Please join me in welcoming Dr. Andrew Schamess, who will walk in the light, not the dark. Thank you, Andrew.
Oh, thank you very much, Dr. Bender. And just a couple of pieces of front matter. First of all, thank you so much. I'm really grateful to Dr. Friedli and Dr. Chopra for inviting me. I'm really honored to be here. There is wonderful work on long COVID going on here at University of Washington, and you have just a great team. Second, I should just mention the next slide is going to be interview with a patient, which lasts about 4 minutes and 40 seconds. One thing I have to clarify, she got something which was very likely long COVID on a trip to India in mid-2020 when numbers of when COVID numbers were surging. She then came back, kind of recovered from the illness and immediately got shingles. And so she says in the interview that her symptoms started with shingles. Interesting overlap in terms of infection-associated chronic conditions. Maybe the immune dysregulation from COVID triggered the shingles. Maybe it was just coincidental. But in any case, I think what we're treating her for, what she and I agree is the diagnosis, is long COVID and brain fog. So I think you can take this as a good description of that. Last point is, I may have too many slides here, so I've asked Anita to throw a pencil at me if I run over. I'm small fiber neuropathy, I'm going to try, but we'll cover what we can cover. Let's see. Am I using the... Okay. Yes, please do. What I want to talk about, if it's okay with you, is what your experience of brain fog has been. And what I recall is you first got COVID in India in 2020, before there was really even widespread testing for it. And it was a few months later when you first started to notice your symptoms.
So I got shingles, and after I recovered from the shingles, my brain felt wiped. I was just completely whited out. I lost the ability to drive to places that I had been to before. I lost short-term memory. So when my husband dropped me off at the hardware store, I went inside and he went parked, and when I came back out, I couldn't remember where the parking was.
Can you give me a sense of what your functioning was before this?
Yeah, it was high. I have a very complicated and technical job, and I was able to manage multiple amounts of data. I had memories of regulations, rulings going back about 20 years. I actually lost all of the memories of my life. I had no memories at all at first. The best way I can describe it is if you've ever seen somebody metal detecting on the beach, the thing I was looking for was that precious thing buried under the sand. And so I would start digging and the sand would keep falling back in, and I would dig and dig and dig, and finally I would get it and I'd pull it up, and then I would have it. And then from that, anything associated with it would just kind of radiate out, and all of that would be available to me. So I would put that on a shelf near to me, and I would dig for another piece. And then after I got a few pieces, what would happen, it was a little bit like walking through a snowstorm. I could feel, there would be like a rope, I could feel where I was going, but I couldn't really see it very well. And sometimes I didn't end up where I thought I was going to end up. And sometimes in the whole process, I dug and dug and dug and came up with a bottle cap. I didn't come up with what I needed. So I'm sure you can understand that at work, it was really challenging, because if somebody would ask me a question and I would be stalling with my mouth saying, oh, that's a really good question, and that hasn't come up too often, has it? While in my brain, I was digging. It was exhausting. And I got horrible headaches also. It affected my whole life. It was very difficult for me to socialize.
Before you saw me, you saw Jordan Bulcher in neurology. He put you on memantine and then I think amantadine after that. Can you give me a sense of how did those things work for you?
One of the first things you said to me was very helpful, which is that it's like a traumatic brain injury. And the first thing you need to do is rest your brain and let it heal. I hadn't heard that from anyone else, and I had not done that. And after I did that, at your advice, for about 6 weeks, things did improve. Amantadine didn't work at all. It made me like groggy. Amantadine, I actually asked him to prescribe, because for my long COVID group, that was one of the things. We're talking now 2021, so there were starting to be other people that had it. There were starting to be support groups. Solve.me got involved. And amantadine was one of the things I recommended, so I asked if I could have it. That had a very nice effect on my physical fatigue. And when I say nice, I mean that the amantadine brought it from maybe 10% of my normal up to maybe 20% of my normal. And then we added the modafinil, and that brought me maybe to 30% of my previous normal. So that was extremely helpful. Each time I get a vaccine, I improve to maybe 60, 65%. The second thing is to understand that it's a journey. There are multiple pieces to it, and anything that can be addressed that is outside of long COVID that can help to improve functionality will help a person cope better with the problems with the long COVID. So for example, when you and I decided I could get cataract surgery, my eyes they weren't that bad, but getting that helped to improve my overall sight, even though the long COVID part of it didn't change. Those are the two. And the third thing is to look at the research. Do research not on causes, but on treatments, because there's so many of us out here that are waiting, needing a path forward. And I appreciate all of the research and work that you have done. I feel very blessed that I have you.
Well, thank you. I feel the same. I've learned quite a lot from you as a patient, so I thank you for that. All right, so thanks. And let's see, can I click on? Yeah, there we go. I have learned a lot from her. She sends me articles like by the dozens. but she's great. And I think really I could probably just stop there. She just described brain fog, at least her experience of it, really well. But okay, so this talk, the context in which we're practicing in was well described in this article, and this is just from August of 2024 by Lisa McCorkle and Eric Topol. So, due to a near total absence of evidence from randomized clinical trials to guide treatment decisions, approaches for the assessment and treatment of respiratory sequelae, cardiovascular complications, fatigue, cognitive symptoms, autonomic dysfunction, including POTS, and neuropsychiatric impairment in adults and children are based on evidence of treating similar symptomatology from other conditions. So, and I think this makes it really hard for patients and also for clinicians that they're dealing with an emergent illness, a poorly understood illness where there really isn't a clear evidence base to guide diagnosis or treatment. And in a lot of ways, kind of what you could almost call a socially contested illness. Not everybody out there, even doctors, believes that long COVID even exists, right? Of course it exists. Those of us who see it understand. But patients have to face that skepticism, and it has a big impact on how they perceive their condition. Oh, oops, there we go. Yes, okay. So this is just some data that we collected in our clinic, and we published it in JGIM in February. I can't see the screen there very well. Okay. But yeah, just some of what our patients told us about their experience. In terms of access to care, and Dr. Walker covered this nicely with her branching slide, but provider disbelief, like they would just meet providers who didn't understand or would sort of misdiagnose. And by the same token, provider listening and validation really facilitated access to care. One patient said, "I cried when I first talked to Stacy, our post-COVID recovery provider, on the phone because she just believed me." The evaluation, patients had difficulty communicating overlapping symptoms to providers. We don't have a good illness script, and patients have illness narratives, and those narratives are long and confusing with a lot of parts, and so they have trouble getting that across to providers. And then frustration. How many patients have come to me, and they've been at this for a year, 2 years, and they've had every test known to man, and everybody say, "Oh, good news, your test results are negative." Okay, yeah, in some ways that's good news, but in some ways it's not, because there's no diagnosis. So, and then the third point, in terms of what patients' attitudes are toward treatments, we'd all love it if there was a miracle cure, like a shot I could just give patients and all this would go away. That doesn't exist. Patients understand that doesn't exist. They're just looking for somebody who's willing to work with them. And maybe, sometimes if you're going to treat long COVID patients, you've got to be willing to go a little out on a limb, because we don't have clear evidence, but there are things that are maybe worth trying if they're relatively safe and benign and the patient is willing and they might help the patient. Just to make the point, because I'm an allopath, I like prescribing, that's what I do, I know medicines, but sometimes communication is actually as important or more important than prescriptions, right? And validation is enormous for a lot of patients who've been through the mill of having their condition misdiagnosed and ignored and being told it's all in their head or whatever silly things that they hear. It's really not uncommon for patients to just cry at that first visit and say, you're the first person who's told me that I really have something. So, telling them 100% you have something, you have long COVID, it's real, like that makes a big difference. Also, diagnosis is useful because then they have something they can call this, which they can then explain to their family and their relatives and friends and their employer, and that can be the basis for disability accommodations, which are often very helpful for patients. I say a little often about prognosis at an early visit. I guess the best thing I can say is there's somewhat uncertain, but there is a rate of attrition from the disease state. So, if you've got somebody who just began getting symptoms maybe 4 or 5 months ago, there's some reasonable chance that they're going to be okay. Not necessarily soon, but they may get back to normal in another 6 months, let's say. Even patients who've had long COVID for a long time often will be helped if you give them the right treatments. So, and then there is, on the other hand, there is a fairly large core of patients who really have had this for 4 years and have not gotten better. So, but I think giving patients some reason for hope is important for patients. Okay, what I was going to try to do here is just dig down into some of the specific neuropsychiatric symptoms, because, and I really applaud any clinicians who are here who are not long COVID experts, because there's hundreds of millions of cases out there. Like, long COVID experts can't take care of all of them, so we're going to really need people to step up to the plate. So you guys are on the vanguard, you people are on the vanguard of learning this disease. There are basically, in making the diagnosis, okay, there's two risks that clinicians have to be aware of. One, which has been covered pretty well here, is just missing the diagnosis. Like, the patient's illness narrative doesn't fit with any script or it fits with 15 different scripts, and you just get lost in referring them to specialists and doing a kind of a huge unnecessary workup, and nowhere do you tell them you have long COVID, right? So patients a year later are saying, nobody knows what I have, right? So make the diagnosis. The other somewhat of a risk is because long COVID is a syndrome with a lot of different conditions and really no diagnostic markers, it can be tempting and it's dangerous to just put every symptom that you see into that basket. And it's important to make those comorbid diagnoses or alternate diagnoses. And so it's a matter of kind of knowing who to test or figuring out who you want to test and how you put those tests in context for the patient. So, okay, what does brain fog look like? It is really kind of distinctive. Almost every patient who I speak to, there's nothing you can say about every patient, but a lot of them will have word-finding difficulty, right? So, I mean, like, as in, could you go to the kitchen and go to the fridge and get me a round red fruit, right? They just can't think of the word apple. They haven't permanently lost the word apple. Like, a half hour later, it'll come to them, but they just can't remember it at the time. I had a patient who was a wildlife biologist and was taking her students, her trainees, out on a field, expedition, and she wanted them to look for a particular fungus in hollow logs, and she just lost hollow logs. So she had to say, look for it in empty trees, right? I mean, people can be creative about how they communicate, but word-finding difficulty, and it's embarrassing for people. It's embarrassing, and then people will tend to kind of mask, like they'll tend to try to cover it up. Recollection, like I had one patient who went into a store where she always goes and said, to the person at the counter, "You're new, what happened to Mr. Jones who was here?" And the guy said, I am Mr. Jones. How come you didn't recognize me, right? Trouble maintaining attention. A lot of patients will say that they're talking and they just, mid-conversation, completely forget. They lose the thread. They just forget what the conversation is about. Confusions in unfamiliar places and situations. So, like, people will, I can give an example, like a patient who was getting better, like felt well enough to travel, went on a trip by herself, and she got off the plane. She's in this noisy, confusing environment she's never been in before, and she spent 10 minutes just staring at the sign, trying to figure out where the baggage claim was, right, until somebody came up to her and said, "Ma'am, can I help you? Is something wrong?" So these are really upsetting events for patients. Brain fog really can be quite severe, so there's a range, and some patients really just, they can't assimilate new information at all, which is a really problematic thing, especially in many types of jobs where you have to do that. And they'll have difficulty performing multi-step tasks. Some patients tell me they can't follow a recipe. Some patients are actually using their GPS to drive to the supermarket 5 minutes from their house because they just can't remember. Some patients aren't driving at all. They're just afraid that they'll see a stop sign and not be able to figure out what that means. Okay. differential diagnosis, I guess kind of the bottom line question is, like, do you have to get an MRI on everybody who has these symptoms? No, I don't think so. And again, you don't want to send patients on a lot of wild goose chases. Like, you can recognize these symptoms and say, these are long COVID symptoms, and the key history is, did it start after COVID-19, right? Can you pin that down? Or something that sort of seemed a lot like COVID-19. Dementia, if you've got an older patient who's really been cognitively declining for a long time, think of that as a potential diagnosis. CNS lesions, I would do an MRI if somebody's having focal deficits, if they have new onset severe headaches. Multiple sclerosis occasionally will overlap in terms of brain fog, but there you're looking for the history of optic neuritis. You're looking for focal deficits, which may wax and wane. There a contrast MRI of the brain and spinal cord is appropriate. And then there's a lot of overlap between long COVID and post-concussive syndrome, which is just kind of a useful diagnosis to make. Fatigue, it's not quite exactly the same as brain fog, and some other speakers have talked about it, but I guess I think of it as mental exhaustion. I kind of make a distinction between that and physical exhaustion, although certainly some patients may have both. It can be constant. I have some patients who just every single day, they just feel like they haven't slept and they're just exhausted. Some patients have their good days and bad days, And then some patients, it's sort of cumulative, like they go to work and, they used to come home and make dinner and do things with the kids and all, normal family stuff. And now they come home and they're just so exhausted they can't do anything. And it's day after day. It's very discouraging. Think of sleep disorders, again, like just sort of take a history. What's their sleep like? How much is their sleep contributing to this? There are some lab tests that you can just get routinely that are easy to do, like a CBC and a TSH and a cortisol, and maybe think of, hypoandrogenism or hypoestrogenism if the age is right. And then do think of medications. Just look at what they're on. I had one patient, for example, who came with long COVID symptoms to their PCP, who inexplicably put them on like 200 milligrams of Seroquel and 100 milligrams of Trazodone and something else, I can't remember. And the patient says, just around that time, I started to feel really just tired all the time, way worse than it used to be. I'm like, yeah, there's a reason for that. So don't neglect to look at their medicines. This was an interesting study they did at the Brigham, where they're Harvard, so of course they have a dedicated post-COVID sleep clinic. And they basically just said for 47 patients, what did they diagnose? Obstructive sleep apnea, it's really common in long COVID, surprisingly, even in patients who you don't necessarily expect to have sleep apnea, and it's treatable and it can contribute, so look for that. Insomnia, like PCPs, we know how to treat that, right? We have an approach to insomnia with, medicines, not to mention Trazodone again, but, modest doses of medicines like amitriptyline and Trazodone. Primary hypersomnia, often treated with modafinil or armodafinil, and it's pretty effective. And then some other things that really sometimes respond to cognitive behavioral training for sleep. Post-exertional malaise has been mentioned. I guess I think of that as physical or mental exhaustion provoked by activity. It can happen immediately after, like a patient will say, yeah, I can go for a jog, I'm okay, but like the next day I just feel like I've been hit by a truck, and then it's 2 days in bed, like I've stopped jogging because I can't stand the after effects or exercising. So it could be immediately or shortly after, or it could be days after. It's just this crash. So what should you be thinking of? I guess I try to make a distinction. A lot of long COVID patients have chest pain and heart palpitations. And I do worry if somebody has something that seems like an exercise limiting symptom, like at a consistent point in exercise, I walk up a flight and a half of stairs, I just feel exhausted and I have chest pain. If the patient is in the right age range and has the right risk factors, maybe you do want to get a stress test or an echo. Think about, there's an interesting situation that you see occasionally where a patient, because I mean, if they've been through the mill a while and they've said they have chest pain, somebody's probably done a stress test. So you'll have patients who have positive stress tests and then they have a cath and the cath is normal. So everybody says, oh, false alarm, you're fine. But if the patient keeps saying, every time I exercise, I have chest pain and I feel exhausted and short of breath, they may have coronary microvascular disease. You see it at an increased rate in patients with long COVID. And so find an interventional cardiologist who can do coronary flow reserve testing. This isn't every patient, but just be aware of that. Occasionally you will see that. Mood symptoms. So, I have some colleagues and primary care docs I know who, if the patient is distraught or sheds a tear, they get put on an SSRI. Don't necessarily do that because polypharmacy can be an issue with these patients, right? So there's a bunch of different things that you'll see. First of all, I do see some patients with what I call just unprecipitated anxiety, like they weren't anxious people before. Their anxiety is not really triggered by a situation. They get COVID and suddenly they're anxious all the time. That is probably a primary phenomenon of post-COVID syndrome, right? Possibly excess sympathetic nervous activity or something that's just stimulating the amygdala and they just feel anxious all the time. Second, adjustment disorder, right? And this is the patient who, like if you think of what patients, like the economic stress and the family stress and the social stress and the pleasurable things that they've lost, like, okay, people get depressed and they get anxious and they get, it's a reaction. Sometimes by treating the primary symptoms and giving them some coping strategies, you can address that. And then PTSD, like people will get from being really sick and going to the doctor and being told there's nothing wrong with you again and again, they get PTSD, like be aware of it. So and then of course you will sometimes have, more straightforward general anxiety disorder, major depressive disorder that do respond to pharmacotherapy with typically SSRIs. Okay, so treating. What's my first line for a lot of patients is to talk about like rest and pacing. And what does that involve? Of course, it depends on the patient, but I'm always very struck by these patients who are trying to hide their symptoms and function in a social role and do things that they're basically just not capable of doing or that cost them an enormous amount in exhaustion. And they've been doing this for months or years, right? And long COVID aside, they're just utterly run down from trying to do this. So, I try to tell them, okay, you have limited energy, you can use it to work or you can use it to heal. It's the battery. Like your battery is going to run out fast, so you choose the things that are valuable to you. Giving them the diagnosis and helping them own their condition. Like feel comfortable telling people, like don't hide it, don't try to pretend everything's okay. I have a condition, I have a disease, I have needs. People I'm going to need some help from you guys doing the laundry and making your own meals. I'm going to need some help from coworkers. I'm going to go to my supervisor and say, I have a condition that's going to require me to make some accommodations in work. Ideally, if I can, for this type of patient, I'll put them off work for a month. Patients practically fall off their seats, some of them. Like, I've never taken a month off. Since I was 15 years old, I've never taken a month off. Now you got to, right? And patients get a lot better if they actually, and when they take, that's not the time to, build a deck or clean your basement, right? You've got to really learn to do nothing. Like Americans have no idea how to do nothing. So, you really have to sort of coach them on how to rest. It's really successful in a lot of patients. They really will feel a lot better. And then I'll get them back to work, little by little. But okay, we're going to go in for 6 hours a week. And you've got to communicate to their supervisor, this is a person who probably eventually will become, again, a really productive member of your staff. But for now, it's going to take a long time for them to recover. So being willing to do the paperwork, the FMLA, the short-term disability, it matters. Obviously, this doesn't apply to everybody. There are some people who are already so disabled by their condition, they're pacing because they have to. And of course, some people who, are work and family responsibilities are not a big stress. What happens if you PACE? Is there evidence that it works? Yes, there is. This was an interesting study, 86 patients, retrospective case series. They looked at their outcomes based on their engagement in pacing subscale. And what they found is patients who had a high engagement in pacing actually made about 60% made a recovery and another 30% made improvement, much less in patients who were moderate or low in the engagement in pacing scale. So yes, it does work. Another great resource, and I won't go into everything on this slide, but cognitive rehabilitation. This is something that in your hospital system or health system, speech therapists probably do. They've long done it with patients who have brain injuries and strokes and things like that. And if a lot of speech therapists now have sort of adapted their approach and figured out how to treat long COVID patients, what does cognitive rehab consist of? Kind of briefly, there's a lot of psychoeducation and information, so stuff you don't have time to tell the patient in the office. Like speech therapists will see them and really work through with them what their disabilities are in a concrete way. Compensatory strategies that can be really useful, recognizing how much mood and anxiety provoke your symptoms, writing things down. This particular study was of a kind of a group intervention. But they did find for patients who had cognitive rehabilitation, significant improvement in self-efficacy, depressive symptoms, social role participation. So this can be a great resource. Find the speech therapists in your area who can do this with long COVID patients. Okay, medications. It's not first line. I mean, we're really in kind of uncharted waters here in prescribing for these patients, but sometimes it can be helpful. I had taken care of a lot of brain injury patients, and so, amantadine is often used in them, and I said, gosh, this looks a lot like chronic post-concussive syndrome. I started using amantadine. I'm not the only one. As you've heard, there's a lot of docs out there who had the same idea. I looked at some preliminary data last year, just the PROMIS scores from patients who'd been treated with amantadine versus those who hadn't. And you can see there was really a kind of a striking improvement in fatigue, sleep disturbance, anxiety, and depression. I really can't stand on this data. We actually are fortunate enough to have the funding to do a pilot clinical trial, a placebo-controlled trial of amantadine. So more on that in the future. But in the meantime, this group from Iran did a little trial, just a 2-week trial, open label, but they got some pretty good results. Fatigue was their outcome, but on the fatigue severity scale and on the visual analog fatigue scale, after 2 weeks, patients really reported improvement. So I think it's not great evidence, but there's enough evidence, and I've personally had enough patients say it's a game changer. I tend to use it more for cognitive symptoms, although it does obviously help with fatigue. Guanfacine with N-acetylcysteine. So what this is based on really quite a small study. This group at Yale reported on 12 patients who were prescribed guanfacine and NAC, and they just kind of did a chart review with no formal outcomes, just kind of looking at did the patient seem to get better. 4 of them discontinued therapy, and 8 had reported benefit. And then, although they've only published 12 patients, they've published a bunch of articles on the potential like mechanism of action. So it's interesting because this is an autonomic modulator, right? So it's an antagonist of alpha-2 receptors. And you can see in the diagram, it does have a lot of potential target effects that are very relevant. Weakening the emotional response of the amygdala, reducing sympathetic outflow, reducing pain transmission, and then improving sleep. So I have used it, I consider it an alternative to amantadine. It helps, and it's pretty benign. It's well tolerated. Low-dose naltrexone, much talked about in the forums and surveys. What is it? What is that exactly? You may know naltrexone because it's an anti-opioid, and you'll sometimes prescribe it for patients with addiction. It comes as a 50 milligram pill. At a low dose, it theoretically has different effects on different receptors, and it can be a pain modulator and help with fatigue. You've got to have it compounded into a 1, 2, 3 milligram. It's sort of the doses between 1 and 5 milligrams or 6. There's a trick, actually, patients can make their own low-dose naltrexone, and if you ask me, if you want to know, I'll tell you about it in the forum or come find me later. But anyway, this is Hector Bonilla, who's our friend, his study. And so they looked at patients, again, kind of retrospective, non-controlled trial, but they did see improvements in fatigue, sleep abnormalities, post-exertional malaise, and unrefreshing sleep in patients who were treated. So there's a bit of evidence for it. So, okay, here's how I'm going to try to pull everything so far together. This algorithm just came off the printer like 3 days before the talk. It's a bit of a draft, but hopefully you guys will help me work through it. So, okay, patients have symptoms suspicious for long COVID, and you're kind of looking for those symptom clusters. Do the symptoms point toward a long COVID diagnosis? If so, very important, don't wait forever to tell the patient that, recognize the syndrome, tell the patient, I think you may very well have long COVID. Give them some basic information about it. Either, you really don't have any other, you really don't think, you're pretty sure they have long COVID. You don't need to do a whole lot of testing. You can just proceed to treating them. Or B, you do have concern for an alternative or comorbid diagnoses. And that's the stuff we just went through. Common tests to order to rule things out are brain MRI, neurocog testing, PFTs, chest imaging, EKG, echocardiogram. Some of them are outside the brain fog area. But, and I think you got to explain to the patient, I'm not doing this test because I expect it to be diagnostic of your condition. I'm doing it because we need to rule out some other things that could be very important that we'll need to address if they're present. So, but either way, don't hold off giving the patient the diagnoses. Okay, you're not going to do all this in one visit. I think of this as spread out over maybe 2, 3, maybe even 4 visits. That's your secret superpower as a primary care doc. You can't necessarily do a 2-hour visit with a patient, but you can do as many follow-ups as you need. And try not to do, it's not like a 3-month follow-up. You should try to get this done over the course of a month or 2 with the promise that there really is an end in sight, or at least help in sight. Okay, so kind of how I divide up the treatment. When cognitive symptoms are prevalent, assess cognitive workload. Do you need to is activity modification recommended and feasible? Really educate on rest for recovery, write for work release, counsel on role adjustment, and then cognitive rehab is a great referral. If the mood disorders are prevalent, are predominant, try to kind of fit it into one of those categories. Educate the patient about that, provide them with some reassurance, give them some counseling options. And then finally, I'm sorry, it's just too small on this little screen to read, so I'm going to look at the slide. For sleep disorders, so do think about, getting them tested if they have anything that suggests sleep apnea or otherwise, sleep CBT is first line for any sort of sleep disorder that's not sleep apnea. And the Veterans Hospital has a great free online module called Path to Better Sleep that's not just veteran-directed, anybody can use it. It's really good. All right, and then this is sort of your second or third visit. And if they're really not getting, if the patient is not satisfied and they feel like they want to try medication to help them, for pharmacotherapy for brain fog, I think of amantadine or guanfacine as kind of the first line things to try for brain fog, and then donepezil occasionally. And if the fatigue symptoms are more prominent, I think low-dose naltrexone is a good option, very benign, or modafinil or armodafinil. For the mood disorder, okay, so PCPs are very familiar with how to treat this. SSRIs are good drugs. Just be aware they can be a little fatiguing. Kind of be aware of the side effect profile. Bupropion is not fatiguing, and so that makes that kind of a useful agent where you have depression and fatigue. And then SNRIs can be an alternative, although they can sometimes worsen dysautonomia, so just be aware of that. And then pharmacologic treatment for sleep, melatonin, if it works, it's great. I happen to really like amitriptyline for this, just because it's long-acting, like trazodone puts them to sleep, but amitriptyline helps them sleep through the night. It's got this wide dosing range that's safe, and it may also have some anti-pain effects, which are useful. And then mirtazapine I've occasionally used, especially if anxiety is prevalent. Low-dose mirtazapine can be useful. If you get through that algorithm, you've gone a long way with helping your long COVID patients. Unfortunately, they're still going to be sick, a lot of them. We don't have the definitive cure, but as far as the state of the evidence now, I think that's not a bad way to approach it. Okay, do I have time to talk about paresthesia, or am I up? I can't see the light. Stop it. Okay, all right. Invite me back sometime and I'll talk about small fiber neuropathy. Thank you guys so much.
Thank you so much, Dr. Schamess. This was such an educational and such an enlightening talk. Thank you very, very much. Next, we will have a panel of clinicians, including our in-person guest speakers, Dr. Walker and Dr. Schamess. Joining them are two of our long COVID clinic physicians, Dr. Jana Friedli. You already met her this morning. And then I would like to invite our illustrious Dr. Nikki Gentili. Dr. Gentili is an assistant professor in the Department of Family Medicine and Family and Lab Medicine and Pathology, adjunct faculty in the Department of Rehabilitation Medicine, and the primary care medical director of the Long COVID Clinic at the University of Washington. Nikki's research centers around long COVID-related pain, including an NIH-funded clinical trial to explore acupuncture treatment for long COVID pain. She was a site co-investigator for the CDC-funded INSPIRE registry examining predictors of long-term consequences of COVID-19 and co-leads the AHRQ U18 grant with Drs. Friedli and Dr. Bender to improve care access for underserved patients with long COVID. She is a sought-after speaker at national forums and was recognized by the National Academies of Science, Engineering, Medicine as a long COVID frontline clinical expert. Please join me in welcoming Dr. Gentili as well. So all of our panelists are here. So we have questions from our audience, actually, in person as well as virtually. So I will address my first question to Dr. Friedli. Dr. Friedli, recover has historically misunderstood and ignored post-exertional malaise. What steps are being taken to appropriately evaluate, measure, and track post-exertional malaise?
So we heard this morning a lot about post-exertional malaise, and I think this is one of those conditions that I see in my patients very frequently, and oftentimes people don't recognize what post-exertional malaise is. I'll just say, before I talk about the research, one of the most important things is to identify it. And so many times patients won't put the name post-exertional malaise. They won't come to you and say, I have post-exertional malaise, unless they're familiar with that term. So you really have to ask people about their experience. What happens after you try to go for a walk, or you try to exercise, or try to resume some of the activities that you were able to do before COVID, or you have a particularly stressful day, or you've had to think, about something for some time. And people will describe that, I go up the stairs, or I go for a short walk, or I try to push myself, and then the next day I crash. And that will alert you to the presence of post-exertional malaise. There is a standardized questionnaire that is oftentimes used called the DSQ-PEM, the DePaul Symptom Questionnaire for post-exertional malaise. And that's just a quick standardized questionnaire that will allow you to assess the frequency, severity, and duration of post-exertional malaise symptoms. And that's one of the questionnaires that is being used in the RECOVER study to assess the presence of post-exertional malaise. As Dr. Walker alluded to, there are a number of different clinical trials. Most are assessing post-exertional malaise as part of the batteries for the RECOVER trials. And then the trial, the ENERGIZE trial, is a trial that I'm one of the co-PIs for. And that's a clinical trial for people with exercise intolerance and or post-exertional malaise. And so there are two parts of that trial, and it's essentially two different trials under the same umbrella. One is a cardiopulmonary rehab program that's individualized for people with exercise intolerance. But because of the concern that people have that if they participate in exercise when they have post-exertional malaise, that they will make their symptoms worse, the RECOVER initiative created a second trial for people with post-exertional malaise, and that's a pacing trial. And so there are these two trials, one for cardiopulmonary rehab for people who have exercise intolerance but don't have post-exertional malaise or have very mild post-exertional malaise. And then there's a separate pacing intervention. And that pacing intervention, we heard about pacing this morning as well, I think is one of the most promising strategies for helping to manage post-exertional malaise. And it sounds simple, but it's actually can be difficult, and I think patients need coaching on this. And so working with a health coach or a physical therapist or psychologist or someone on the team who can help patients to identify strategies for pacing, identifying what the triggers are for post-exertional malaise, and helping them to plan out their activities to reduce the frequency and severity of post-exertional malaise. So this trial is just, the ENERGIZE trial is just getting up and running. We're now enrolling patients into this trial, so we don't have the definitive answers. I think there's some data from ME/CFS about pacing, and there are some smaller retrospective studies that have shown that pacing is effective, but this will be the first large prospective clinical trial. So I think it's going to provide a lot of great information. And what I'm hoping from this trial is that it will be able to have the evidence that we need to demonstrate to employers and to insurers that these accommodations are really important for helping improve people's symptoms. And incorporating that into work accommodations, for example.
Thank you. Thank you so much. My next question is for Dr. Schamess. Dr. Schamess, how do patients with ME/CFS fit into the this question should go actually to one of our UW folks. So let's see Dr. Gentili take it. How do patients with ME/CFS fit into the UW Long COVID clinic? I am bedbound, but have been told to do PT and exercise by the clinic, but that has worsened my ME/CFS.
I actually wrote that question down to go to Jana over here, so I'm going to defer to her on that one.
That sounds good.
So if I think if I understand the question, there's two parts of this. One is how do we address ME/CFS in our clinic? And as you heard, there's overlap between ME/CFS and long COVID, and many of our patients meet the definition for having ME/CFS. So we do treat that in our clinic in patients that have long COVID. We in our clinic are not able to accommodate patients who have had ME/CFS prior to COVID or unrelated to COVID. As we've mentioned before, we are trying to expand access to the clinic, and there's a huge unmet need. But because of limited access, our clinic is really designed for people with long COVID specifically. But the management and the treatment strategies are similar, and we use a lot of the same treatment strategies for ME/CFS as we do for long COVID, and you heard a little bit about that this morning. I do think that there is a role for physical therapy in people that have chronic fatigue, but it has to be done in a way that with a physical therapist and with a protocol that makes sense for the individual person in terms of what their symptoms are. As I just mentioned, if you try to do exercise and you have post-exertional malaise, you can worsen your symptoms. So the therapist has to understand what post-exertional malaise is, has to understand dysautonomia if they have dysautonomia and orthostatic intolerance, and has to really individualize that program for that individual person. But I think you can learn to use your heart rate as a guide. You can learn pacing strategies. You can incorporate some of those techniques in order to be able to participate in activities that are meaningful to you. So we do refer patients to physical therapy, but we do that very carefully and make sure that we have the right protocol in place for them.
Thank you. Yes, please go ahead.
I'm curious. Oh, is my mic on?
Yeah.
Okay, sorry. I am curious. For some of my patients who really just can't tolerate any sort of exercise, I sometimes focus on breath training. Like sometimes just the breathing will help them, and at least it gets them started. And I'm also curious what your experience has been, kind of borrowing a page from POTS treatment, but recumbent versus, upright exercise, like somebody who can't walk a block, but could they do something lying down?
Yeah, those are great points, and absolutely, I think there's actually a fair amount of evidence for breathing exercises, and particularly in dysautonomia and some of the symptoms that people are experiencing, that it can help to stimulate the vagus nerve and really help to regulate your autonomic nervous system. So I think that is a cornerstone of all of our activities, and really is where we start with all of our patients. And then I do think for people who have orthostatic intolerance and or POTS, that some patients are able to tolerate exercises where they're recumbent. I usually encourage people to, if they are able to think about low intensity exercise, to start with the breathing exercises, progress to gentle stretching, yoga, depending on the type of positions. You certainly don't want to be doing inverted positions or many of the positions where you're going from sitting to standing if you have orthostatic intolerance. But I think you can adjust for your symptoms and incorporate some of that low intensity exercise. I think where we really run into trouble with many of our patients is when they try to resume aerobic exercise or weightlifting or activity that is pro-inflammatory. And that can be really triggering of their symptoms. So I think it really has to be individualized. You have to take a good history and really understand what their baseline was before COVID, what their goals are, where they're at now, what their symptoms are, and assessing for post-exertional malaise to help design an individualized treatment approach when it comes to activity and exercise.
The next question is actually for the panel, but I was hoping, Dr. Walker, can you take this one? Can you talk about the importance of providers masking with N95 with long COVID patients? Since we know reinfections can worsen long COVID, this is a huge barrier for patients who are going in person to see their physician.
Yes, I think that's a really important point. That's something that can be really challenging as we no longer have national guidelines that masking is required, and we don't have national guidelines around quarantine. So it is up to the individual within an institution to choose whether they mask. And it makes it very challenging for us to reinforce this in our clinics. In our clinics, this is something we highly recommend to all of our providers. I think it's important. I totally agree with you. It's not something we're capable of enforcing
for those reasons. But it is a concern of mine because just like I mentioned in our talk, just what you mentioned, Dr. Chopra, we see that your risk of developing long COVID increases with subsequent infections. And as you mentioned, your symptoms can worsen, or you can develop new phenotypes that you didn't have before after a new infection. Like now you have POTS, as where before you only had an ME/CFS phenotype. I think it's very important. I'm hoping that as we increase awareness and have this education to providers, they will understand the importance of this. So I'm in total agreement.
Thank you. So the next question, actually, if all of you can pitch in, it will be great. Would any speakers today be willing to share if they submitted clinical trial ideas to recover, since the initiative is soliciting ideas? So can we start with Dr. Gentili? And yeah.
Our team has not specifically submitted to recover, but we currently have an NIH-funded clinical trial for acupuncture, and we plan to submit 2 more in the next year. But again, not specifically to recover, but to NCCIH, which is the branch of NIH focusing on complementary and integrative health treatments, which are very much understudied in general. And we have seen in our patient population that patients tend to improve with some of these more conservative and complementary approaches. So our team, personally, we like to study those right now.
And I'll just add the other, certainly there's a lot of interest in identifying treatments and medications that can address the underlying immune system compromise that's happened, or immune system dysfunction that underlies many of the symptoms that people experience. But there's also a lot of interest in mitochondrial support supplements and medications to help support the mitochondria and sort of the energy metabolism. I would say there's a whole host of supplements that people are trying for long COVID for a variety of different things, to reduce inflammation, to improve the function of the mitochondria, support the immune system. And many of those have very good theoretical reasons why they might be helpful for long COVID. Like the NAC and some of the other ones that people are using, but there's just not enough clinical trial data on those. So that's where I would like to see more clinical trial data. You heard about low-dose naltrexone, which is commonly used. There is actually a large clinical trial that's going on now through the University of British Columbia. So I'm anxiously awaiting the results of that clinical trial. But I think for all of these medications and the repurposed medications and supplements, I think that's where I would like to see more research.
Yeah, I would like to second that. So the agent portal is hot off the presses. This was distributed to folks about 2 weeks ago. So this is an opportunity really for everyone to put their thoughts in. And I would very much like to see the repurposed drugs that we're trialing in our clinics investigated in these clinical trials, so that we know that they're actually effective and we're not running into the hydroxychloroquine situation in acute COVID. We suspect that they'll be effective because we are seeing that they are helpful in some patients. But again, in other patients, they just aren't. And so that goes back to really needing to define these phenotypes, understanding the nuance within long COVID so that we know which drugs are going to work for which symptoms, which phenotypes. I really want to highlight, like I mentioned before, fatigue may be different drivers depending on the individual, and there may be different treatments for that. That's true of shortness of breath as well. You could have some scarring from long COVID that's causing shortness of breath, but POTS causes a perceived shortness of breath as well. Totally different mechanisms. We need different treatments for those. So there's a lot of room for needing to improve our understanding so that those drugs are trialed in the correct conditions. But I'm most interested right now in repurposed drugs. I think that these are going to be symptom relief at this point and not cures. And that's why I also highlighted we really need to work with industry on treatments that will cure long COVID. And that's unlikely to occur, in my opinion, from repurposed drugs. So it's a stepwise effect, and these all need to be considered through this portal, which you all can nominate drugs for.
There's a gentleman who has a question.
So there are so many countries and so many medical practices, from allopathy to naturopathy. Everyone are doing lots of researches around it. How all of them are like collaborating and updating their knowledge. For example, I actually went to India. I took Ayurvedic medicine, 1 month treatment. My brain, I had a cloud in my brain. That kind of went away. Then my fatigue, I used to sleep like, I couldn't get out from the bed like 3-4 days, even continuously. Now, I do have fatigue, but not the worst case. So I just wanted to share something like, it's all we are trying to get the same goal, right? In different paths. And isn't it like better to collaborate also inclusively? Sorry, other practices and everything. There is a system around it. Because all the governments are doing the research, funding and everything going on, different medical disciplines. And isn't it better we have a system which can, all of them collaborate and update their knowledge and sharing what their findings, even is a different type of medicine.
Absolutely, yes. That's a very good point. Dr. Schamess, do you want to continue on the RECOVER trial and then?
Sure. Yeah, I was just I can just add briefly. We have a proposal we submitted under the regular R01 pathway, not RECOVER. But yeah, I mean, if you look at the symptoms of dysautonomia, right? We have long COVID patients who, they presumably have cardiac problems, but there's nothing structurally wrong with the heart. They're having respiratory symptoms, but there's nothing structurally wrong with the lungs. They're having GI symptoms, but there's nothing structurally wrong with the gut. But all these organs depend on innervation to function, right? So just like a small fiber neuropathy affecting the autonomic and sensory nervous systems is actually not a bad candidate for disease pathophysiology. And the interesting piece is, like, the vagus nerve doesn't just go one way, it goes two ways, right? So mental function and formation of new memories and hippocampal neurogenesis all depend on appropriate input through the vagal nerve and other pathways from the visceral organs, from the autonomic nervous system. So if we get funded, we're doing sort of a deep dive into small fiber neuropathy. We're going to get a whole bunch of patients and do biopsies, and we've got lab scientists who can do all kinds of interesting electron microscopy and various tests. And really, if you can figure out what the basis is of a small fiber neuropathy, then you're in a better position to look at treatments for it. So.
That's excellent. Thank you very, very much.
And I'd just like to make a small comment. I think you were alluding to collaborations across countries as well. So there is some infrastructure for that as well. There are ECHO talks through Silk that are really excellent with a goal of having a universal approach to long COVID across countries and providing some infrastructure to support low-income countries as well that are also very heavily impacted by long COVID to increase awareness and the ability to provide clinical care in those countries as well. I'd like to see this expand, but it's a really great effort.
So these are just great questions. We have some more from the live audience, and I'll have this nice lady.
I'm pretty loud, but I see Dr. Friedley at the Long COVID clinic, and my son, I think, also has long COVID, but he's 16. So he has been seen at Seattle Children's for the last year and a half, and he has literally been to every department. And there's nobody to help, and he can't be seen at UW. So I would just love to hear what the options are for the pediatric patients and what kind of collaborations are coming up in the future, because I think that's one of the underserved populations, but it wasn't mentioned, because as far as I know, there's nowhere to send a kid, and it's just so hard to get them the help that they need, and it's very defeating, I think, for them.
I can take this one because for a while, I think I was one of the only clinicians seeing pediatric patients in our long COVID clinic. As a family medicine physician, we see kids, adults, we do prenatal care and deliver babies. I think, it's difficult when there is not a lot of people to see the patients. I did have to close my panel for a period of time because there were a lot coming in. I'm hoping that is going to change soon and I can actually open again to see children. But I do think it is very important to acknowledge that all of the symptoms that we see in adults can also happen in children. And it is very hard for these kids because they go to school and their lives have been completely uprooted from having COVID. And one thing that I do try to teach primary care clinicians when I give talks is the importance, if a child is struggling from a cognitive standpoint or fatigue, to put in place there are plans like IEPs and 504 plans that are really, really important to have in place, because that then carries with the patient beyond public school system. And once they enter adulthood and they have jobs, that continues to carry with them. If we don't put those plans in place early and then the child graduates and they are out in the workforce, there's a lot of people that don't understand these limitations that patients experience. And so I do encourage primary care clinicians to remember that those IEPs and 504 plans are in place. And while we may not always be directly involved with development of those plans, we can write letters that support the school system with creating a good plan and make sure that we encourage parents to talk to the schools about their options. But yes, I wish that there was a better answer and that everybody could see the kids. And I'm hoping that we can train more primary care clinicians in long COVID who can then treat those kids across the 5-state region. That's my goal.
Thank you. We have, do you have anything to add? Okay, let's have you.
Hi, another question from a patient. I'm seeing myself and a lot of my friends go through different, as you described, many different specialists, subspecialists for their treatment, and we get kicked out into these traditional workflows. For me, it was Bell's palsy. For another, kidney failure, another, et cetera. But what I'm noticing is that it's not just that the PCP that we need the training, it's also the specialists, because when the treatments come back, we're talking about waxing and waning symptoms and repeated or different workflows. I'm curious, I work in supply chain. I'm a little bit curious about what are the plans for optimizing these workflows? It's a huge toll on University of Washington Medical Center to have me spit out to 5 specialties. And it's an efficiency problem as well. I mean, it's a toll on you guys.
Yeah, I think this is not a unique issue to UW, so I would love to hear your perspectives as well from your institutions. But I think it is really challenging. I think we have initially been focusing on training up the primary care physicians to be able to manage patients in their practices. Part of that training is to recognize when it's appropriate to send patients to specialists and when you don't need to. And I think you've heard Dr. Schamess, highlighted very well that many of the symptoms are not organ problems. It's not that there's a problem with your heart or a problem with your lungs or a problem with your brain necessarily. It's more the wiring and more of a systemic issue with the nervous system. And so sometimes you don't need to send patients to those specialists, and we know that that can be managed with either a long COVID team or through primary care. So part of what we're trying to do is to you make sure that patients are being appropriately sent at the right time to the right specialist when they need it, to try to reduce that burden. I think there also needs to be training for specialists as part of this, and so I think that's the next step in our thinking is then to focus on that. Although there is a lot of ongoing work to train specialists as well, but I think what we are all seeing is that there is a substantial backlog for many different specialists because of some of this burden of care that's impacting people being able to access the specialists. So I don't have a great answer to it except to acknowledge that it is a really big problem, but I would love to hear your perspectives.
Hear you.
Yeah, I think there's a lot to unpack in that question, and I mirror what Dr. Friedli said in terms of how we handle it from a long COVID clinic standpoint. And again, I mentioned that we have a multidisciplinary group that we meet together to put our heads together so we're not shuttling patients through the system. They're familiar with long COVID. But what do we do about those that are not seeing us in clinic, that are being referred to multiple subspecialists without ever having a touch point in our clinic? I think there are two ways to approach that. So we're fortunate to be one of the AHRQ-funded sites. So we also are taking a tiered approach where we begin with community engagement to help people associate their symptoms with long COVID. We next target primary care physicians to help increase that capacity. Within our pipeline, we will then work with subspecialists, really targeting those that are going to receive the majority of these referrals, the cardiologists, the neuropsychologists, neurologists, and trying to increase awareness and capacity in that aspect. But also, I think this is where evidence-based guidelines will be really helpful. If we have universal guidelines that people can reference, that there is some awareness about it in the medical community, that neurologists can then go to that website, see that this is the diagnostic workup. It does not have to be $1 million workup, and can understand how to diagnose long COVID. I think that will demystify the process for primary care physicians, but also for subspecialists as well, and to increase awareness of that.
Dr. Schamess?
I don't really have much to add. I think you guys covered it very well. Thank you.
I just wanted to add to what Dr. Friedli said, that at the University of Washington, we are really trying to reach out to providers and offer multiple opportunities for their education as well, including our partnership with the Department of Health, Power of Providers, where we do these webinars for physicians and other providers as well, in addition to hosting our national long COVID interest group meetings monthly. So let's go to the next question. Did anyone in the audience have? Okay. Did you have a question?
Yes, I would like to ask about Paxlovid for long COVID patients. It's something that physicians are really not prescribing a lot, even for acute infections. And right now they don't have the direction to prescribe it for long COVID or direction to determine if a patient is having ongoing years of symptoms because they still have an infection. Can you speak to that? I know that there's trials underway for treating long COVID with Paxlovid. Where are we with that right now?
Sure. As one of the site PIs from the VITAL trial that investigates Paxlovid, I'm happy to answer that. I tend not to prescribe medications to my patients that are currently in clinical trials that we suspect will have answers to soon, which I do suspect will have answers within the next 6 months to a year on Paxlovid. The tricky thing about Paxlovid is how long do you treat for? And that's one of the questions the clinical trial is trying to answer. Because do we find that we need to treat longer than the 25 days that we are investigating in the clinical trial? If that is the case, this is a medication that does have some hepatotoxicity, some toxicity on the thyroid. Is it a medication that we should be using long term? Or if we're starting to see some benefits of an antiviral in this disease that may need longer than that 25 days, do we look for another medication that might be effective that is more tolerant, the side effects are more tolerant on the body, so that we can keep this viral reservoir at bay. We don't have enough information on that yet. If we decide that it needs to be a long-term antiviral, I don't know that Paxlovid's going to be the answer, and that's why I don't treat with it long-term.
Are there ways for long COVID patients to find out if they are one of the people who has these viral reservoirs? Like what testing can they get?
Yeah, this is not tested clinically at this time. Unfortunately, it's been done only in research studies. This is one of the secondary endpoints in the VITAL clinical trial. It is something that if we find that it's very beneficial as a biomarker, I think we might start to see it more in clinical care, but not available yet.
I'm a patient of Dr. Friedli, though I've only met with you once. One of my questions is looking at maybe reframing some of the discussion that we're having. I know that we're talking a lot about long COVID as a set of symptoms and treatments and potentials, but for people who are dealing with long COVID, one of the things that comes up a lot, at least in my life, is how to not get COVID again. And what happens and how I have to mitigate against that and not be basically housebound for the rest of my life because I don't want to go out in public anymore. And I'm just wondering how we inject that into some of the policies and proposals that come out through the discussion in the community and with physicians and institutions.
Yeah, and thank you. I think it's a really good question, and I would answer it in a few different ways. I am curious about the experience of the other panelists in terms of what. All right, so if you have a patient who gets COVID and gets long COVID, and then they get COVID again, how often do you see either a regression or back to baseline or new phenotypes emerging? Because my experience is, it is interesting how much my patients with long COVID seem to be prone to being reinfected. Much more than my other patients who've had COVID. It's my long COVID patients who've gotten it 3 or 4 or 5 times. But it doesn't necessarily always lead to a catastrophic outcome. But with that said, I do caution people, still keep those same precautions that we had as much as possible. If you're going out in a public place, wear a mask, double mask. Try to avoid, if you can, those places where there's going to be a really, a large concentration of people where you stand a high chance of being infected. Ask friends and family to mask. I'm sure this is not news to you. I'm sure you're already doing all these things. I make sure that they know how to get me. If they were to get COVID, I'm happy to prescribe Paxlovid for them if that's what they want. And so I make sure they know how to reach me for that. But I guess I'm curious about the other panelists' experience.
I agree with you, and I do find that it really depends on the patient, on what happens if they were to get reinfected. I do like to have conversations with my patients about a balance of quality of life and risk, because I do think that there's something to be said with people who are very social beings who really miss going out and doing things with their friends, and they don't feel that they can do that because of fears of getting reinfected. Having those conversations with their support people and their friend groups about, can we go somewhere where we can mask and hang out? Can we, or optimize those opportunities during the summer months here in Seattle where you can be outside, and, working on mitigating risk that way and finding strategies that work for you. But making sure that there's some quality of life and something you're doing for yourself that you enjoy somehow. It may not be the same as what it was pre-COVID, but working on finding something that gives you joy, I think that that's important.
I think it's a wrap now for the panel. Should we move on to a break? Yes. So thank you very much to all our panelists. So we will now have a lunch break, and as a reminder for our in-person attendees, please remain masked unless you are in the designated eating area upstairs. We will return at 12:55 for our patient sessions, starting with a performance from the awesome Joshua Roman. Welcome back. Welcome back from lunch. We hope you had a nice break. And to those of you who are just joining us today, welcome to the UW Long COVID RISE Symposium. I'm Anita Chopra. I am one of the physicians at the UW Long COVID Clinic and co-investigator for the AHRQ grant. At this point, before we start, I request you to please switch off your phones because we are going to be listening to a powerful performance in a little bit. It is my absolute honor and privilege to introduce to you the next speaker or the next performer, a musician par excellence, a powerful speaker, the most positive human being, and an exceptional person. His music has the power to move mountains, and his voice can move you to tears. I would like to introduce Joshua Roman. Joshua is a cello soloist and composer. This was just the beginning. Now is the real deal. He's hailed for his effortlessly expressive tone and playful zest for exploration by the New York Times, as well as his extraordinary technical and musical gifts and blend of precision and almost improvisatory freedom that goes straight to the heart. This is San Francisco Chronicle, and I'm witness to it. His genre-bending programs have grown out of an enthusiasm for musical evolution that is contagious as his love for the classics. Seattle Times. He has collaborated with artists including Yo-Yo Ma, Edgar Meyer, DJ Spooky, Tony winner MacArthur genius Bill T. Jones, Grammy Award winner East African vocalist Somi, and Tony Award nominated actor Anna DeVere Smith. We will begin with a short video prior to his performance. After this performance, we will have some time for Q&A. Please join me in welcoming Joshua.
I started playing the cello when I was 3 years old. I have two parents who are both musicians, so it was very natural. I don't really remember a time where I didn't want that to be my life. I think it was around the age of 6 that I started telling people that I wanted to be a cello soloist. I think it's my favorite expressive tool for connecting with other people. The cello has yet to show me its limits. When I got COVID, I was in between two concerts. Friday night, played the Prokofiev Symphony Concerto. It's like 40-minute piece, big piece. Saturday morning, woke up anticipating playing it again that night, and instead couldn't smell and got the positive COVID test. Within 2 days, picking up a bow to play just would seem insane. So that was the beginning of what turned out to be long COVID. And long COVID is no fun, but it's been a good teacher for me. The guy who right before that was super proud of running the mile in less than 6 minutes, all of a sudden I actually couldn't make it up a flight of stairs that had a little landing in the middle, and I got stuck and I stayed on the landing for almost an hour. The general consensus was that dysautonomia is one of the first things to look for With dysautonomia, there's a miscommunication. So if I walk up 3 stairs, I might think I just did a marathon and make me exhausted. I think it's challenging to understand what long COVID is because so much of it touches on things that we experience in our daily lives already. So I think of like the brain having a processor just like a computer. If you put too many programs on it or running them at the same time, that can slow down the processor. Driving is a good example. You're steering a car. You have to be directionally focused. You have to see all of the obstacles on the road. You have to understand the lights, the signs. You have to look for people. So that's all taking processing power. But underneath that, there's this other part that's being processed, which is that you could die if you mess up. So like that actually takes processing power. And it's not something that I ever thought of before I experienced what happens now, which is if I drive for more than 10 minutes, my body just shuts down and my brain shuts down. My eyes close. I can't open them. So I have to pull over and stop. I sold my car because I wasn't using it. It was dangerous. As a performer, I know how to like save and direct my energy towards the performance. But if I've been pushing and doing too many things beforehand, the immediate aftermath is a crash. And what that looks like is that I literally can't speak properly. I can't lift my arms. I have gotten used to the look on people's faces, seeing a grown man slumped over in a chair, like eyes barely open, trying and failing to say something like, "It's okay." There was a moment where I put the cello in its case and let the dust collect. And I thought a lot about why I played the cello and whether I wanted to play the cello. I really, really considered stopping. Instead, I've been finally learning something that I had been trying to learn for years, to learn how to say no. They use a stoplight system for us. So there are red light activities, yellow light activities, and green light activities. If you really consider how you feel after doing something and while doing something, a lot of things we'd think of as green really belong in the yellow pile. There are people that we spend time with that just take energy. There are things that we do that just drain us. It's not that we can't or shouldn't do those things, it's that there has to be a balance. That starts with valuing our own energy and our own time, trying to understand what it takes to bring a present self to every situation. And so for me, that would be the big, beautiful lesson of a debilitating condition like long COVID. There is an idea of who I was that's no longer there. I'm still struggling to accept that might never come back. So finding ways to dig deeper and see what's underneath that has been very important. I am definitely a different cellist than before. I am much more intentional about what I choose to do and the music I choose to play. Technically, I can find my way around just as much as I always could, and it's been fun to actually dive back into the joy of playing the cello, getting better at it, doing things, and just nailing it and just learning to trust more and be open to that. I'm more excited now than I have been in a long time about where the cello and I are going, and because of that, super excited to share it with people. Thank you. I'm Joshua Roman, and that's how my cello says hello. It's the, you've probably heard it before, the prelude from the first suite for solo cello by Johann Sebastian Bach, and the piece that I've played more than any other in my life, hands down, no contest. Every time I play it, it brings me joy, and I really feel that it's important for me to start a set and a story that are so deeply personal as this with something that I've loved as long as I can remember. As you saw in the video, 3 years ago, I was facing the possibility of never playing this beautiful music again. After catching COVID in January 21, I have yet to recover. I could obviously tell something was wrong when the taste and the smell returned, but I continued struggling to read. Even simple sentences wouldn't make sense. You know, a list, forget it. And I saw myself speaking about that moment when I got back home to New York and collapsed on my way up the stairs, unable to continue, frustrated and crying. Long COVID, as we know, has a different set of symptoms, or as I've learned to say, constellation for each patient. Mine includes dysautonomia, trembling, which I take medication for daily now for almost 3.5 years. You can imagine what trembling would do to my career. Luckily, I no longer have the random heart rate spikes above 200. I still deal with a substantial amount of brain fog, which, who else hates that term? Like, yeah, I have brain fog, I haven't had my coffee yet. Not the same. Sorry. We need better words. So in my case, this, as I've come to call it, layered thinking, this overtaxing of the processor can really get in the way. And then there's the crushing fatigue, which can feel like wearing a heavy jacket inside of my body. Those first two performances that I had after I caught COVID and it wasn't going away were so important to me that I brute forced it in a way that was really kind of harmful to myself. And afterwards, I crashed hard. I didn't have anything ahead on the calendar because it was 2021, concerts were canceled. So that's when I put the cello in the case and left it there. And it was during this time that I started really asking questions and facing doubts that had been there for a long time, long before COVID. I'd been stuck in a kind of gig mentality for a lot of my career where I was waiting on other people. I wanted the phone to ring, and I was afraid to say no to anything. All that time, chasing, completely unaware of the exhaustion that ran through my body and spirit. I play the cello, and I've always wanted to feel somehow that it matters. But after decades of ambitious effort to play perfectly and to give the wishes of the composer the utmost regard and hand them to the audience through a perfect vessel, I was struggling to see at that point, when it was so difficult to even play, whether that mattered. The next piece that I want to share with you is something that touches something different every time. You know, that Bach is so joyful. And that's the first thing I think about when I think about music, is joy and sharing. But art and music in particular can allow us to explore things that are hard to say, or might even be hard to see in ourselves. And that's important too. Those things are a part of us. We hold them in our bodies. They affect how we act. They affect our relationships. This piece was written by Alison Loggins Hull as part of a project of music by women for women. And she gave me permission to play it, even though I'm a man, and asked that I share the story behind it, which is unfortunately all too common. It's the story of a child sold as a bride. It's in 3 parts. The first part represents that initial thing that is taken away, that childhood that is taken away, and the deep sadness of that. The second part is a frenetic, perhaps even angry frustration of trying to catch up to a new, busy life thrust upon you long before you're ready for it. And in the third section, forced acceptance or resignation of the life that now is. I offer this piece to you in the spirit of catharsis, of touching those things that have been hurt or taken that help us relate to each other. This is Alison Loggins Hull, Stolen. I just love how that piece I just love how Allison uses the depth of the cello to find something that I'm not even sure what it is that comes up for me when I play that, but it's something. So during that time when I wasn't playing at all, it was almost 3 months. In early April, that's when I put the cello away, and it wasn't until a summer solstice party, and I'm just gonna go ahead and admit guilt brought me back to the cello because I couldn't tell my friend at the last minute that I was gonna back out of her party. So the day before is when I started to play again, and I dusted off the case for the first time in my life. You know, I'm an everyday practicer. So this was huge for me. I was not sure what would happen. My fingers were pretty rusty. And when I started to play, I started with the Bach that I began for you. And I was overcome with the sheer physicality of making sound. Even though my fingers were a little all over the place, holding the cello like that, again, the power of her vibrations moved me to tears. She's been my best friend since I was 3 years old. And I realized in that moment that somewhere along the way, I had become so focused on music, and especially my career as an act of giving, of service, of taking a story with music and sharing that I had lost sight of my own need for nourishment and connection through music. I want to take just a minute before I go on with the last two pieces I have for you and do something that usually doesn't happen in a classical concert, as if the rest of what you've seen is normal. And I invite you to remain seated if you would like, or you can stand up with me and shake it out just a little bit. I'm curious, raise your hand if you've done a diaphragmatic breath before. Okay, that's a substantial number of people. I didn't know what it was. I took, maybe one vocal lesson and decided the diaphragm was fake. And I don't get it, but I've recently been learning, and so we're gonna do that together, and I want us all to start together. We're gonna do it the very simple way, which is that we're gonna put our hands below our belly button, on our belly, and then we're just gonna pay attention when we breathe in. We wanna feel that moving out, and when we breathe out, we want the belly to be coming back in. You can go ahead and be doing this, but in a second, we're gonna take 2 breaths together, and then after that, you're going to continue on your own while I talk again. So wherever you are, let's get to the end of the breath. We're gonna go inhale and exhale. I think you're already doing it, but this is through your nose. So inhale, expand, exhale, we're coming back. Okay, now you keep going. I wanna hear your breath through your nose at your own pace. Don't try to match the person next to you. The next thing we're gonna add is that I want you to feel your shoulders open. That when you breathe out, the belly comes in, but the chest does not collapse. And really make sure every breath you're feeling your hands move, get them to move as much as possible. Just a couple more of those. You can shake your head a little bit, relax your neck. The next thing we're gonna add is humming. So same thing, feeling all of this, the chest open, feeling the belly. Find your way to an out breath, and together we're gonna breathe in. Very good, we're gonna do that again. Great, you're going to continue while I speak. So when you get to the end, take a breath. Again, don't time it with the person next to you. This is going to be a continuous cycling of hums. You can keep it loud because what we want to do is feel that vibration in your jaw, feel it in your neck, feel it in your shoulders, feel it help them stay open. Feel it maybe even in your hands down by your belly. Find a pitch that's good for you. Take the deepest breath you can and hum. Great. So we're going to do one more all together. Wherever you are, head towards the end of an out breath. Beautiful. Thank you. You can have a seat. What we just did is actually a couple of exercises that I learned from a team in Vienna. Very simple, but have been proven through multiple studies to help alleviate certain symptoms of long COVID. We're stimulating the vagus nerve by humming, and generally activating the vibrations throughout the body helps loosen a lot of things up. I know many of you are doctors, you're gonna have to explain what happens next, but it's good. And in general, getting the diaphragm engaged and getting the oxygen down there, getting the full lungs engaged. So we have a QR code and a website out there that has not only resources to more exercises like this and information about them, many other resources as well, but also a questionnaire that we would love for you to fill out about this particular gathering moment together that we are having. But now back to the last two pieces. Thank you for indulging me. My dad is a choir director. My mom is a choir director. That's the closest I get. I'm also a composer. And I wanted to write a new piece for my project, but it was very difficult. I couldn't compose in the way that I used to. And I also really wanted this piece to capture all of the lessons that I've learned and to show the lows, the highs, the journey in between. I had this fancy idea that hope didn't have to be some dreamy thing. It could be really grounded. I'm not really sure what that means, but this was going to have grounded hope. And it's going to be real, super epic, and less than 5 minutes. So, of course, I gave myself writer's block, and I also improvised, so I began improvising every day to see if I could get things flowing, but it wasn't helping me find this mountainous peace. And it wasn't until 2 days before the recording session that I finally let go of any pretense of controlling the process and decided that rather than direct the music, I would follow it. And what happened was that very quickly, I discovered the most unabashedly joyful composition I've ever written, which I think taught me that I couldn't force myself to write the piece that I wanted, but when I let go and just followed my heart through the sound, I came away with exactly the piece that I needed. I gave it the same title as my project. I'll share it with you now. Here it is, Immunity. Thank you. It's pretty groovy. I I really love that, and it's not epic, but it is so fun. Thank you all, by the way, for being here for this convening in general and for being in the room here with me at this moment. And thank you for putting this on, for inviting me to be a part of something. It's, I think, so important that we gather, see each other, discuss things, and know that we're not alone. I love doing this. I've begun to love connecting with other patients and am learning to love telling my story. But as fun as the music is, and as much as I'm getting used to the practice of sharing, it's still difficult for me to actually be vulnerable with you. I sit up here as a performer, as a recovering perfectionist, and vulnerability can mean mistakes. and mistakes don't belong on stage. But I also know that the depth of the connection that I felt when I held the cello again only had space because I was open. And it wasn't by choice. I was open because I accepted that I was vulnerable. These days, I'm constantly adjusting to new symptoms, new limitations, new challenges, and I'm very lucky that my team, my care team at Mount Sinai in New York City has been helping me adjust and learn to better manage things and live a life that feels more full than before COVID, even though I'm doing it with less energy. But in a very real and a very measurable way, I am not who I was before I caught COVID, and it's unlikely that I'll ever be the same again. Long COVID is now considered a chronic condition, and we hope eventually there is a cure. So here we are. For me, rather than hide my struggles, I've decided to do the hard work of changing deeply ingrained habits, and it is hard work, and letting go of my attachment to an identity that prioritized perfection over connection. Learning to embrace a perspective that allows me not only to give, but to receive. In my case, not only the gift of music, but in as many parts of my life as I can find. I'm committed to doing that, and I'm committed to sharing it through this project and through every performance I do, and remembering that it is important to not only accept but embrace this vulnerability, because it is what takes me out of my comfort zone and makes not just music, but life an act, not of perfection, but of humanity. Well, I heard that there's a secret chord that David played and it pleased the Lord, but you don't really care for music, do you? Well, it goes like this: the fourth, the fifth, the minor fall and the major lift, the baffled king composing hallelujah, 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 hallelujah. Faith was strong, but you needed proof. You saw her bathing on the roof, her beauty and the moonlight overthrew ya. She tied you to a kitchen chair, she broke your throne and she cut your hair, and from your lips she drew the hallelujah, 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 hallelujah. say I took the name in vain. Well, I don't even know the name, but if I did, well, really, what's it to you? There's a blaze of light in every word. It doesn't matter which you heard. The holy or the broken. Hallelujah. 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 I did my best, it wasn't much. I couldn't feel, so I tried to touch. I've told the truth, I didn't come to fool you. And even though it all went wrong, I'll stand before the Lord of Song with nothing on my tongue but hallelujah. 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 Hallelujah.
Thank you, Joshua. I don't think I have words enough to express how I feel, and I don't think any of us has the words to express our emotion at this time. This was such a soul-stirring message of hope and life. And at this point, I invite questions from the audience. We have a few minutes. So if you have any questions that you would like to ask Joshua, please raise your hand and I will give you the mic.
As a fellow musician, I'm a guitar player and a piano player. I have long COVID, and I've been dealing with arthritis and also shakiness of the hands, and also memory issues, remembering like my own music. What would you recommend to other musicians in terms of continuing to grow in your skill, just handling these obstacles?
I'm sorry that you're going through that. That's really tough. I think each of us has to find our own way. The piece that I played, Stolen by Alison Loggins Hull, is actually an example of one of the moments when I began to learn the granular differences in symptoms that can make a huge difference when they play out over career decisions. And that is that Stolen was the last piece that I had memorized before I got long COVID. So to my mind, much less stable than the Bach, which I'd known for over 30 years. And it was a huge relief for me to discover that that actually was untouched. That part of my memory was still solid. Because at the time I was dealing with seeing the editing, not even the editing process, but a piece I'd written for 2 soloists and orchestra, so I don't know, something like 20, 25 parts. It was in the back and forth with the copyist phase where I was simply correcting their mistakes when they had put it into print. That's it, not even being creative. Doing that, a half-hour job took me a whole week. And chamber music, rehearsing with people, is still probably the most difficult thing that I can do. So I don't do chamber music festivals anymore. I've given that up, and it's really sad. But what I've done is find the things that I can do and lean into those. So because my memory is not affected, the trio that I am with, we're going on tour next, starting here at Meany Hall on Wednesday, and we just play from memory. But I can't do a chamber music theme. So it's a different situation, but what I would encourage you to do is explore the granular differences in how you're affected, find where you do have room, and play with that room where it is. And as far as building up tolerance for the cognitive difficulty of doing things that are currently too difficult, I think there are a lot of studies that are attempting to figure that out, and it's very challenging. But I do wish you the best in terms of getting back to a more full spectrum approach.
Thank you.
Yes, sorry. Thank you. Thank you for coming and playing. And I must say that was the most joyful version of the first Bach cello suite beginning that I've ever heard. My question is, for not people who are professional musicians, but just ordinary mortals with long COVID, do you think that there is potentially a role for music and art as a therapeutic tool?
So this is a great question. Another one of these differences in my life, music is heavy. I love it, but you know, if I look at the cello, sometimes I get stressed out. It's how I make my living. It's everything. When I first was trying to understand my life with long COVID, a friend of mine lent me a guitar, and I found that I could play simple things on the guitar for hours on end. Basically, it was a green light activity, whereas cello was at best a yellow light activity. And I think that, yes, if it's not something that is weighing you down because the emotions play a role in the cognitive structure in ways that I don't fully understand, then creativity and art, finding something that lets you express, can be so therapeutic. And for me, that's what life is all about. You know, it's about connection, it's about expression. All of the logistics are just logistics. So finding something that is, you know, I'm using my example just to say, if it's too difficult, try something else. Try something else. I love drawing stick figures, and people make fun of me for it, but I think it's fun. So that's good for me. Also, I do the coloring books with the mandalas and, you know, whatever. But yes, I think that a creative outlet is so important for a human being in general, and that getting hung up on it being excellent is where humanity starts to run afoul anyway. So we can start that revolution in ourselves by easy, daily, creative acts that bring us joy. And maybe they don't heal our brain immediately, but maybe they give us reasons to continue. Thank you. Thank you.
Thank you. Thank you, Joshua. It's my luckiest day, actually. So I'm not a musician, but the music was really uplifting. The main part I really learned from you, you're not only a musician, you are very analytic and intelligent. Something I really want to take from here is you said you don't like to, when you try to control the music, you're not getting. You just follow the music. So same thing like COVID patients, instead of you trying to control our energy, everything, you just follow, listen to your body, follow those things.
I love that. Thank you.
Something I really,
yes, I've struggled to not solve my problems by running. And now I'm in therapy, and I think I'm actually solving some problems. Maybe not all of them, but it's working better than running ever did. So there are probably things for each of us that letting go of that vision of who we used to be and accepting where we are can yield lessons across the whole of our life. Thank you for that observation.
Thank you so much, Joshua. I think in the interest of time, we will wrap up here. And I want to thank Joshua and his entire team. And this has been such a moving experience. Thank you very much for coming. I will now move forward, and I'm excited to introduce our next speakers. But I think let's take a few minutes break so that we can, let everyone relax and just take in this experience. And also, we would like to help Joshua's team, Hello, everyone, again. I'm very excited to introduce our next speakers, Jenny Long and Dr. Kristen O'Loughlin, who will speak to us about how to support your mood with long COVID. Dr. Kristen O'Loughlin is a postdoctoral fellow in the UW's Department of Rehabilitation Medicine. She balances her time between research and providing clinical care in the UW Medicine Long COVID Clinic. Dr. O'Loughlin provides short-term therapy for individuals living with long COVID and also leads group sessions designed to support symptom management and coping. Her research aims to understand patient preferences and priorities around care, as well as to enhance the implementation of behavioral health care interventions. Jenny Long is joining us from North Pole, Alaska. In 2020, she contracted COVID, which rolled into long COVID, which robbed her of her energy, strength, short-term memory, and the Alaskan adventures she lived to enjoy. She was left feeling disconnected from much of what she valued. Medically retired from her 28-year teaching career in early 2024, Jenny struggled to find adventures she could navigate. This is where the mandala dot art came into her life. Nurturing her creativity and artistic skills, she found a pathway to literally connect the dots of the stunning Alaskan landscapes and wildlife she had spent 2 decades thriving in, to the quieter life she inhabits now. Please welcome me in joining Dr. O'Loughlin and Jenny Long.
Hello. It's great to be here with you all. I really appreciate you being here. And I'm excited to be speaking alongside Jenny Long. So as mentioned, today we'll be talking about supporting your mood in the context of long COVID. So first, I just want to briefly discuss the long COVID experience. As mentioned, there are many, many different symptoms associated with long COVID. Some of the most commonly reported symptoms are fatigue, shortness of breath, and brain fog. Importantly, a lot of patients also report anxiety and depression, whether it's new symptoms of anxiety, depression, or maybe an exacerbation of previously experienced symptoms. And together, all of the symptoms they're experiencing have really important psychological impacts on their well-being. So it might be feeling trapped in the cycle of exhaustion, feeling disconnected from their previous life or the activities that are most important to them. It might be a loss of identity or life purpose, or fear of the future and the unknown. And these psychological impacts can be impounded by the context that someone's living in, which might include feeling socially isolated or navigating misinformation in the community around COVID-19 and long COVID. So understanding mood in the context of long COVID and how to support it is really important. So from my clinical practice, I hear about individuals' experiences with long COVID, which frequently center around loss of identity, loss of health, and loss of energy. I often hear patients talk about not being able to go to work or having significant difficulties with that, missing out on important life events, or maybe not even being able to show up for their kids in the way that they used to. And in some cases, when they try to do these things, they have really significant consequences with their symptoms. They have an exacerbation of them, and they have to rest for an extended period of time. So stories that I commonly hear from patients are, I'm too tired to do anything, or I'm no longer myself, or I don't recognize myself. And these stories are really important because they name the problem of long COVID or of specific symptoms that they're dealing with. Thinking back to 4.5 years ago, if I had said long COVID, no one would have known what that was. But it was patient-led efforts to describe what was going on with them, to describe their problems that made long COVID visible in the first place. So the problem story that patients are sharing are really important ones and ones to be respected. Because naming the problem and speaking up about experiences is what makes things possible. Things like diagnosis or getting connected to support that you need, from your medical team to your family or your community. Though it's when our lives are centered around or guided by the problem that can lead to more distress. Because problem stories, they sit alongside exceptions to values, to hopes, and to preferences. And so today I'm going to talk about expanding that narrative to incorporate preferred stories as well, which include your values and your goals and aspirations for your life. And also introducing activities in a manageable way that supports those preferred stories. Okay. So we can start with a strategy that comes from narrative therapy, which looks at the effects of stories that we can get trapped in and how being trapped in a problem story can dominate our life. And one strategy is called externalizing the problem. And this means seeing the problem as something separate from yourself and who you are. For example, I'm too tired to do anything might then become fatigue is getting in the way of my work today. Fatigue is something that I am dealing with. And this moves away from defining yourself with the problem and other challenges. Separating yourself from the problem can create opportunity to change your relationship with it. and to expand the focus to include the things that matter most to you. And in order to expand the narrative, you can also develop an alternative story, one that reflects who you truly are rather than the problems that you face. You can think back about times where symptoms were less prominent, times where you found support, or where you adapted to challenges. And I'd like you to reflect, what do those times suggest is important to you? And what do they say about you as a person? And what have you held on to despite long COVID's presence in your life? And who has supported those efforts? Perhaps recently you set a boundary with a friend, you went for a short walk, or you called an extended family member. Those might highlight values for you around self-care, of persistence, and of family. And so finding the themes that emerge from these moments helps you to begin to construct a story that emphasizes your decisions and your priorities and your values. So what was initially, I'm too tired to do anything, might then become, despite challenges, I find ways to honor my needs and stay connected to family. This new narrative can then become a guide for future activities. And so behavioral activation is an approach that can help with living that preferred narrative, along with helping your mood and other symptoms like fatigue. Because behavioral activation helps us to understand how symptoms of long COVID and behaviors impact one another. So according to the model behind behavioral activation, long COVID triggers symptoms like fatigue and low mood, which then gets in the way of your ability to do the things that are important to you and that bring you joy, which then in turn causes you to feel worse. So in this cycle, low mood and fatigue leads to decreased activity and then worsened mood and energy. And one example of how this might play out is you might wake up one morning feeling particularly fatigued and anxious. And that might lead you to not be able to engage in any of the things that you had planned for that day. So you might miss out on an important work obligation or a family event or a get-together with a friend. And then this would then lead to feeling more fatigued and possibly more anxious related to missing out on the things that are important to you and not getting up and moving around. So this cycle of inactivity can lead people to feeling stuck. And so behavioral activation aims to break this cycle of inactivity by helping you to do more of the things that bring your life meaning and joy. And symptoms like fatigue, which interfere with the way that you want to live your life, make it difficult for you to do the things that are important to you. So this model suggests that introducing activities in a manageable way can help create more of a helpful cycle. Doing the opposite of what our low mood wants us to do is actually necessary for our feelings and emotions to change. And it might seem paradoxical to increase your engagement activities that have caused you fatigue or exacerbated your symptoms in the past. But the key is to start small and manageable and do these things in a manageable way so that you're using your energy efficiently and most importantly in the way that is meaningful for you. Behavioral activation is not only about improving your mood, but it's also about aligning your energy with the things that are most important to you and to feel empowered and expand that narrative around long COVID. And behavioral activation has shown to have a lot of evidence and support in the literature. It's actually a gold standard for supporting mood and depression. It's also found to have other benefits as well. It helps with anxiety, functioning in daily life, perceived social support, and quality of life. Oh. Yeah, great. Okay, so let's talk about how to putting all of this in action though, with 4 steps. So the first step is to identify your values and your preferred story. Becoming more aware of your priorities can help you to figure out how to guide your action. And values are ways of being and doing that give your life meaning. They're not goals, they're more like a compass that helps you guide the direction that you want your life to go. For example, if you value having a healthy lifestyle, then you might prioritize getting good night's sleep or having balanced meals. Or if you value family, then you might make efforts to visit with them often or stay connected. And there are different ways to explore your values. You can imagine someone were to be writing a biography about you. How would you want them to describe you? What are the qualities that you would want them to highlight? How would you want them to describe the way that you spent your time? Or another approach might be to consider a hero of yours. It could be someone who's in your life that you know, or it could be someone that's a fictional character or a celebrity. And when you think of those people, what are the things that you admire most about them? What qualities do they have? And as you consider your values, you might notice that they're different now than they previously were. Long COVID's impact on different areas of your life, your daily routines, your abilities, and your relationships can lead to a shift in values and priorities. So consider what is really important to you now. What are the things that you've been holding on to despite long COVID's presence in your life? And what would your life look like if long COVID wasn't in control? And when we shift the focus to your values and your priorities, what does your new and preferred story become? So the second step, keeping that expanded narrative in mind, includes taking small steps towards activation to support your mood. Specifically, starting with small, manageable, and realistic steps, which fit within your current symptoms and energy levels. There are different types of activities to consider, ones that make you feel good, that give you a sense of accomplishment, or that help you connect with the people that are important to you. So using a previous example, if your preferred story centers around honoring your needs and staying connected to family, then your values of self-care might lead you to then journal or practice mindfulness. Or your value of family might lead you to have dinner with a family member or give them a phone call. So turning those values into small and manageable steps allows you to begin strengthening that preferred story and living in alignment with the story that you want to live and not the one that long COVID tells. And once you've identified a variety of activities, step 3 is to begin with scheduling them into your week. So you can start with scheduling out a week's worth of daily activities where you would want to have at least one activity a day. And consider including a variety of different types of activities like we talked about that make you feel good, give you a sense of accomplishment, or help connect you with others. You can also include activities that were avoided or responsibilities that you've been meaning to get to. And so scheduling activities in can be helpful in giving structure to your day. It can help build momentum, and it provides things for you to look forward to. And scheduling activities also helps you to plan for success. First, in keeping your overall schedule activities for the day as manageable. So to help with this, be specific when you're writing out your activities. What is the activity that you plan on doing? For how long will you be doing it? And will you incorporate breaks along the way? Also, consider your day and your week holistically. What else do you have scheduled? If you have an in-person doctor's appointment on Tuesday afternoon, you may plan activities for the morning before or the morning after, which exert less energy and are more restorative. And secondly, plan around your symptoms and your energy levels. If you know that your energy tends to be better in the afternoons, then you might plan activities in the afternoons so that you can engage in them better and benefit from them. And then finally, when you're creating your schedule, think about building up activity levels slowly over time and incorporating regular breaks along the way. And there are two approaches to doing this. One approach is time-based pacing. And this is where you schedule an activity and rest, where you do an activity for a safe amount of time, maybe slightly less than you are comfortable or confident that you'll be able to do. And once you've completed the activity for that amount of time, then you'll take a scheduled break regardless of how you're feeling before returning then back to the activity for the scheduled amount of time. An example of this is if you plan on doing the dishes, you might do your dishes for 10-minute increments and then take a 10-minute break in between. And you can do this until the activity's over or schedule a set amount of times that you'll cycle through this. The second approach is goal-based pacing. And so this is where you break down an activity into smaller chunks, and you will then do those activities one at a time, regardless of how long they take. And then when you finish that piece, you'll take a break regardless, again, of how you're feeling. An example of this is I had a patient tell me that they broke down their meal prep. And so they might have decided to chop all of their vegetables in one sitting, and then they took a break, and then they returned to the next step of the meal prep later. So alternating between periods of activity and rest allows you to slowly build up your endurance over time, avoid worsening symptoms, and also to consistently engage in your activities, which is the goal. And then the last step here is to track your activities and notice how they go over time. So either after you've completed an activity, or maybe later that day, or even the following day, you'll want to sit down and think about how things went. How much did you enjoy that activity on a scale of 0 to 10, where 0 is not at all, or 10 is extremely? And then secondly, you'll want to think about how that impacted your energy levels on a scale of 0 to 10, where 0 is no energy at all and 10 is very energetic. And then at the end of the week, you'll want to review your activities holistically and see how things went. What went well, what things helped this be possible, and then continue scheduling the activities that improved your mood and also didn't lead to an exacerbation of your symptoms. And then on the other hand, notice areas that were more challenging. Notice what barriers got in the way of those activities going well, and then brainstorm possible solutions. And once you've done that, pick one solution that you can give a try. So this might be revising an activity to make it more achievable, creating a reminder system to make sure that you follow through on doing it, maybe enlisting the support of an important person in your life, or building these activities into a routine that you already have in place. An example of kind of problem solving is if you notice that after an in-person doctor's appointment, your energy levels dropped pretty low. Maybe an obstacle was the long distance that you live from that doctor's appointment, that you had to drive really far both ways in addition to attending the appointment. So this might lead you to consider an opportunity to incorporate more pacing, breaking down that drive and taking breaks, or perhaps moving to telehealth if that's an option, or enlisting a family member, a friend, someone who might be able to drive you to and from the appointment. But behavioral activation is a learning process. The nature of symptoms, they might change from week to week. So really listening to your body and making changes as needed. But monitoring allows you to see how these activities influence both your mood and your energy levels, and to make changes as needed so that you're able to engage in those activities that are most important to you. So with that, I'd like to turn things over to Jenny Long so she can share her story and bring some of this to life.
Got to be able to see here. Oh, look at me, I'm already over clicking. So I'm Jenny Long. I'm from North Pole, Alaska, and I want to start by taking a look at my life pre-COVID. I refer to that era of my life as PC Jenny or pre-COVID Jenny because the version of me standing before you is very different from that person. I gotta take a deep breath for this. Okay. I was a fundraiser, a fun chaser, an outdoor adventurer, an event organizer, a computer sciences teacher, a fish chaser, a cabin builder, a soccer playing, soccer coaching, soccer mom. And I get exhausted now just thinking how insanely busy my life was during that era. So we move on to now. I first tested positive for COVID in October of 2020. I had all the usual symptoms and didn't get better. Like after 2 weeks, I went back in, did a chest x-ray, treated for pneumonia, and was given steroids. And they said, these steroids are gonna make you feel good, but you might feel a little crummy after you're done with them. And what happened was the first of many crashes, which led into a long COVID diagnosis. And from there, I ended up taking the rest of that school year off. I couldn't teach anymore. So over the next 2.5 years, I did all that I could to continue teaching and was well supported at home and at work. Teaching was not a job that you can pace yourself at. You cannot control all the variables that happen in a middle school classroom throughout the day. So it took a lot out of me. And I ultimately ended up retiring early with disability. Over these past 4 years, I have been grieving pre-COVID Jenny while learning to live in this new to me body. My long COVID came along with some depression and some anxiety. Depression wasn't new to me. It's something I have lived with my entire life. But the kind of anxiety that I had came at me really fast and really powerful, like a mama bear. I was grieving all that I had lost to COVID, the loss of myself, my passions, and my social life. Through medication, meditation, laughter, and focusing on the positive, and focusing on things to look forward to, my outlook on life greatly improved. I have an amazing husband, a wonderful son and daughter that were very supportive have been very supportive through all of this. And I have been really blessed with incredible providers and a therapist who has held my hand through a lot over these past 4 years. I'm just gonna say this. I'm using paper and reading this because something that one of my long COVID things with my brain, I get dizzy really easily, and using screens and things moving on screens gets me, so that's why I'm holding on to paper. So, this is my family. Teaching with long COVID really forced me to look at what I value. I had to reallocate energy to the most important things in my life. Families always came first, and at times it was the only value that I could even hold on to. Everything else just had to go. I was living in survival mode. We chose to laugh a lot, though, through a lot of what I was going through. We still do. I'm the butt of many jokes. So life is different now. I've learned to trust the journey that I'm on. I got an e-bike so I can enjoy one of my husband Scott's favorite hobbies with him. I go on the hikes and the floats, but I stop before I get tired, and I let the others go on, and I'm okay with that. I used to be like, I am doing this and going hard all the time, and I'm okay letting others continue without me now. I do schedule vacations, but they have a lot more downtime, like vacations really are supposed to. They aren't the go, go, go vacations that we used to take. I'm open to what each day allows me to do. I rest when I need to, and I've adopted the mantra, rest to restore. Focusing on filling my leaky gas tank as needed throughout the day. This means accepting that some days I may need multiple breaks, naps, or meditations to fuel me to take on the rest of the day. One of the most powerful lessons that I learned in this process was right at my 1-year anniversary of COVID, of getting COVID. I was really a mess. I was teaching, I was depressed, I didn't feel like I was successful at anything I was doing in life. It was just, I was really struggling. And my therapist asked me a question. She said, what would you say to 1-year-old Jenny right now if you wanted to give her some advice? How would you treat 1-year-old Jenny? And I had to think about it. And I realized, 1-year-old Jenny needed a lot of help, like with everything, and was going to accept help. She wasn't going to try and do everything herself. She needed multiple naps, and that was okay. She needed to be fed quality food. She needed gentle encouragement and positive reinforcement. This way of thinking about how old I am in long COVID years helps me recenter myself when life gets overwhelming. Today, I'm almost 4 years old, and I'm more independent, as a 4-year-old should be, and I'm also more accepting of my long COVID life. I'm still learning to treat myself gently and reframe thoughts with words of gratitude, I'm sorry. That's the other thing, I'm not supposed to apologize. I've learned to not apologize for everything all the time. It's okay, these things are okay. I try to let things go that I don't have control of, like getting COVID 6 times. I learned to communicate my boundaries, but still need to be reminded to set them. My husband is a wonderful boundary holder-upper for me, or reminder. I try to listen to my body. It is constantly telling me things. And we've learned to really celebrate even the little things, things that we would have let go of very easily as being, well, no big deal. We learned to just be very grateful in life. So, in the winter of 2023, after a long day of teaching, I was mindlessly scrolling through TikTok, and I saw something like this, when you need to just let your brain go. It was just somebody putting paint on something and pushing it around, but it caught me, and I loved what I was seeing. I found it very calming, and I found it very calming during a time when my life felt like chaos. I was in the process of fighting the state of Alaska for early retirement, and I was living to work and spending every minute outside of work recovering. Teaching was too much for me, so picking up a hobby wasn't something I was going to be able to do. I spent months watching videos like that and collecting images for inspiration and some paint and tools, and once school was out, I started. That's my very first painting over there, the little dots. That summer, I was all about sunsets and water. And I would be painting when Scott was out fishing. I used to be out there fishing with him, and I just don't have the stamina for it anymore. So now I spend time painting while he's doing those things. I had this in my classroom when I went back to work. It was just my reminder of something I enjoy and to just keep swimming. Why not? I really did fall in love with this dot painting. But when school started again, I did have to put it aside. I had nothing in me to do anything extra. after a day of teaching. So, when I was finally granted early retirement with disability in February of 2024, I was able to pick up my dotting tools again. I spent March and April tracking, much like you see, this is my calendar. That was just my little notebook. I spent March and April tracking and logging my days into the following categories: rest and restore time, cognitive and planning time, physical and social, which for me, those drain me in the same way. I get, if I'm doing something physical or if I'm having to carry on a conversation with somebody, I get equally exhausted. And my PAIS time. I documented when I had post-exertional malaise or long COVID symptoms. And after 2 months of paying really close attention, I kind of figured out what triggered me. I understood myself better in this retired situation where I just kind of had to refigure things out once I wasn't working anymore. I painted almost daily in short spurts, taking breaks often and using the timer on my watch to manage pacing and my short-term memory issues, to go, check the laundry, do those kinds of things, just reminding myself. I find the time when I'm painting, I'm just counting dots often, or just the repetition of creating a pattern, very meditative and calming. I did buy some small, cheap animals, and I tried painting them, and something clicked. By April, I had improved to the point where I was ready to start sharing my pieces with family and friends, and their feedback was really encouraging. Parts of pre-COVID Jenny started shining through, and it was really empowering. That always thinking of what I can be doing kind of mindset. So I started thinking about what I could do, how I could do more with my painting, and wondering, wow, could I actually sell these? Would somebody want them? Who would want them? And I honed in on that idea that when you live in Alaska and you talk to people that visit Alaska, there is something captivating about Alaska. People that come and visit want to have a piece of Alaska to take home. So that's what I focused on. I found out what it takes to get the Made in Alaska certification, and I got it. I have a retired friend who has a small business who cuts my shapes for me now. I contacted one of our local gift shops, and they take my pieces on consignment, and they're really, they've been in demand. It's kind of cool. So I've been selling them for a while. This was one of their posts that they did when I dropped some off a few weeks ago. I am also someone who loves connections. Where are we there? I have found so many ways that my dot art has connected me to others and to the things I value in life. I can't get out and enjoy the outdoors the way I used to, but when I'm painting, I'm drawn to moments from my pre-COVID life that are important to me, like chasing fish with my brother, who I lost to COVID in 2022, or counting 67 eagles with my kids on a single fishing trip. I've designed my color palettes based on places and experiences of life in Alaska. Perfect Day in Valdez, hunting season, and Denali Grizzly are a few. Every ornament that I paint is strung with repurposed fishing line that my family has used in Alaskan waters, giving my pieces a direct connection to me in Alaska, and some even have little fishing lures. I got one up there. That was obviously an idea my husband had. I got to dig into his fishing stuff. I named my small business Dot Along AK because I do hope that those that enjoy my pieces become part of my dot painting journey with me. They come along my journey. I use the video production skills that I used to teach, that I spent hours teaching middle schoolers, to create and post videos of painting, and I'm growing an online following and have a whole new connection with a completely different group of people. I've reconnected with past students and families through my art, and I've sent pieces around the world to people who have fond memories of trips to Alaska. I feel a direct connection to all of those places where my pieces have found homes. I have big ideas for my painting business. I write them down so I don't forget them. I'm working at a very slow pace on those plans so I don't overdo it and have to abandon it completely. I pace myself, doing things in small, mostly manageable chunks, and I rest to restore often. There are still days that my brain signals me that I won't be painting, signs I've come to recognize, like when I can't get things to line up and the dots are really wonky, or I get that squeeze around my temples. So I rest to restore on those days. Pre-COVID me never would have considered myself an artist, never. That never would have come into my frame of mind. But here I am. Really, I feel like I am a thriving artist that is living with long COVID. Long COVID is just a part of my experience, my journey. It's not who I am anymore like it was early on. I want to encourage you to accept where you are each day and do what you can to connect with the parts of you that you may have had to let go. Don't be afraid to try new things because you might surprise yourself. If you're interested in my art at all, you can scan the QR code. There were stickers, I don't know if there are anymore, there were stickers and the QR code out at the table, maybe you picked that up. And I really hope that hearing about my long COVID journey can help you on yours. Thanks for having me.
Thank you, Jenny. So I just want to mention that if anything that we've talked about sounds like it might be of use to you or you're interested in giving it a try, we do have some handouts that are available on the table out front where you registered or when you came in. So feel free to grab one and it'll walk you through those different steps of identifying your values and thinking of valued activities. And considering what a valued life, a meaningful life for you could look like now, despite long COVID's presence. So thank you.
Thank you. And we'll take a 5-minute break now so you guys can get a chance to stretch. And we'll come back with our next speakers. So let's take a 5-minute break.
We're going to keep moving on in the interest of time. Thank you all for having a seat for our next speaker. For those of you who were not here this morning, I wanted to introduce myself. I'm Dr. Jessica Bender. I'm one of the physicians in the Long COVID clinic here at the University of Washington. And I'm very pleased to introduce our next speaker who will be joining us virtually, Allison Sbrana, who will speak to us about adaptive recreation. Allison Sbrana, she, her pronouns, is a disability activist based in Fort Collins, living with myalgic encephalomyelitis and other chronic diseases caused by viral infection in 2014. She's passionate about helping chronically ill people understand their disability rights and access the services and support they deserve as a former care coordinator for Colorado's Medicaid program. She brought her lived and professional experience to the long COVID community through Body Politics starting in early 2020, where she helped sustain Body Politics' online global long COVID community of over 15,000 people until its closure in 2023. Allison now consults on peer support, provider education, and policy, in addition to her work facilitating advisory councils to bring lived experience into decision-making. Before her illness, Allison worked in communications while performing regularly as a classical flutist in small ensembles and orchestras. And after her presentation, Allison will take questions from the audience. So please join me in welcoming Allison Sbrana.
Thank you so much. I am really excited to talk with you today about finding joy again with my lived experience using adaptive recreation for energy-limiting chronic illness and disability. Can we go forward onto the slides, please? Great. Thank you. So a little bit about my story. 10 years ago, I got a virus and never recovered, which is now a familiar story in our world now. It wasn't quite as familiar at the time when it happened to me. And I was undiagnosed for several years. It took me almost 5 years to be diagnosed with myalgic encephalomyelitis. And especially in those early years when I didn't know what was wrong, I experienced a lot of loss. I lost community. I lost most of my friends. I essentially disappeared from society. I certainly lost my career. I was a classical musician before, and I couldn't sustain my work because I was a flutist and it was too cardiovascularly demanding. I lost financial stability, and I lost the life that I had planned for myself, which I think is a familiar statement in this room today. And every day then and now was fluctuating with unpredictable symptoms, and I struggled to access appropriate medical support. As the great provider who introduced me said, my story intersects with long COVID in that in April 2020, I reached out to a journalist who wrote one of the early op-eds about being a young person who gets COVID and doesn't have an easy recovery, which ended up turning into Body Politics Grassroots Emergency Response Support Group that grew to over 15,000 people when we were operating it. Next slide, please. So in my story, especially in those early years, but it continued for a very long time, I experienced a lot of loss. And I lost a lot of essential components of life. But one of the essential components of life is joy, having fun activities, having relaxing activities that we can participate in, and connecting with other people. And those were things that I lost due to my illness. I was a musician before I got sick, and even though that was also my career, it was a form of recreation for me. And there were many days where I would play, 6, 8 hours a day, and now I couldn't sit up in a chair for 30 minutes. So I lost that form of recreation. I also was living in Colorado at the time, which I still am. I lost a lot of forms of outdoor recreation, going for walks, just participating with people here who do outdoor activities, riding my bike, going skiing. And one of the points I want to make today is that it is absolutely hard enough for us to figure out our new normal, meet our basic needs, find medical care. It is hard enough to go through that. But it's another thing when you don't have access to joy, to relaxation, and to social connection, to build up your resilience, to tolerate all of those hard things. And so that's part of why, next slide, please, I want to talk about adaptive recreation for our community. So you might not have heard this term, adaptive recreation, and especially in our community of people with long COVID and similar conditions. Adaptive recreation is a pretty broad term. It just means inclusive recreation or leisure activities that can be adapted to all kinds of disabilities at any age. Typically, more formal adaptive recreation programs are available through city and county programming, but they can also be available from nonprofits and other specialized adaptive disability programming. What is adaptive recreation about? It is truly about improving our quality of life as disabled individuals by making joyful and fun activities easier for us to access and accessible for us to access. Next slide, please. So why do I want to talk about adaptive recreation specifically for our community? Because I think this is something that people like us would really benefit from. I'm talking about adaptive recreation for long COVID and similar conditions, because we know how challenging it is to live with these conditions on a daily basis. We're already in that struggle right now. We know that it is hard for us to engage with basic daily activities. It is hard for me to bathe. It's hard for me to get dressed. I can't safely prepare my own meals. Those are really hard daily barriers that we face. And it often means that we don't have the energy left at the end of the day or even the beginning of the day for fun things like recreational activities, leisure activities, which tend to be more like relaxation activities, and social connection. What adaptive recreation does for us is it helps reduce the energy and the barriers that exist for us to participate in fun activities again. And I really want to drive this message home to everybody online and in the room today that every single one of us deserves to experience joy, to have fun, and to connect with other people in a way that is safe for you and within your limited energy. Next slide, please. So, how did I, a person with moderate to mild ME/CFS, begin to feel comfortable with adaptive recreation? It was a journey for me. First of all, and I really want to make this point clear, I absolutely needed to have home services and supports in place from Medicaid to feel comfortable at all trying adaptive recreation. When I wasn't eating enough or bathing enough, didn't have clean clothes to get dressed in, didn't have help putting my compression stockings on, and meeting all of my other basic needs, I didn't have room to even think about fun activities. And so for, over 7 years of my illness, it was just about meeting basic needs, and I was missing a lot of joy in my life, but that's the reality that many of us face. So I needed to have in-home supports in place first. After that box was checked, which was a very hard box to get checked, I started thinking about adaptive recreation, and I was nervous that it wasn't for people like me, or that I would crash really hard after. And I came to accept that fluctuating and dynamic disabilities like ours are still disabilities, and we deserve these services too, just as much as any other types of disabilities. You can see these photos here, engagement photos with my husband from 5 years ago now, taken only minutes apart. In one, I appear disabled, and the other, I appear non-disabled, and that is our reality. Our symptoms fluctuate. The other support that I had, which was really important for me, is that my occupational therapist, who had never worked with ME/CFS before, learned about it and understood my needs, and she encouraged me, and we worked together so that I would feel safe accessing adaptive recreation. And what that meant is that adaptive recreation opened up my world again after being homebound for several years. Next slide. So, how did I access adaptive recreation? This is a very busy slide. I struggle sometimes with visual overstimulation. Don't worry about trying to read it if you're in that boat as well. What I wanted to communicate with this slide is that these are 2 pages from my city's recreation programming little magazine thing that they distribute seasonally. And this is typically where like kids camps are, or senior programming about reduce your fall risk, but they have adaptive recreation also. And in this spread, you can see a variety of classes that range from more relaxing activities like an art and nature class, creative cartoons class, to bird watching, all the way up to adaptive cycling, wheelchair basketball, adaptive hiking, and ice skating. One thing I want to say as we go into the next section of my slides is that I applied for a reduced fee program through our city, so I paid very little money to access all of the adaptive recreation that I have. And that's important for our community because many of us have lost our jobs or stable incomes, and we're on limited incomes if we are lucky enough to be approved for disability. So financial accessibility is also important here. Next slide, please. So now for the fun part. I'm going to take you on a tour of my adaptive adventures, and I really want to make sure you know that I am one of us, okay? I have previously would have categorized myself as moderate ME/CFS when I started this adventures of adaptive recreation. So my level of impairment was pretty significant. I'm not running around and regularly doing these kinds of activities otherwise. They really can be adapted for our population, and I want to make sure you know that. So as I take you through a tour of the activities I've been able to do, I'm going to tell you about the activity, and then I'm going to explain to you how we adapted it for my needs as someone with moderate ME/CFS, as someone with POTS that is very life interfering and hard to treat, and a lot of other daily symptoms that affect me. Next slide, please. So the first activity is adaptive cycling, and this was my introduction to adaptive sports. I live in a platinum bike city in Fort Collins, Colorado, and biking is part of our culture and our infrastructure here. But I hadn't been on a real bike outside for 8 years since I got sick. I say a real bike outside because I tried and epically failed to do the recumbent biking exercise protocol indoors. So I didn't think that biking would ever be possible for me again, even though it's such a part of the culture where I live. So I paid less than $3 total for an 8-week adaptive cycling class from our city that included all equipment, including the helmet and the adaptive e-bike that I used, as well as the support from recreational therapists and different staff and volunteers who were there to help us. I think that this is a video. Do we want to try to play it? It's okay if it doesn't work. That's okay. So, one of the most important things about adaptive cycling for me meant that I could participate in family activities again. My family had not been able to take a family vacation for almost a decade because we didn't know how to plan activities that worked for me. And what adaptive recreation gave us is a pathway to figure out how to do that. So this picture is from a trip that we planned last fall up to Grand Teton National Park, the first family vacation in almost a decade. And I worked for months ahead of time with my occupational therapist and then problem solving during my adaptive cycling class of what kind of equipment do I want to use while I'm up there and making sure my needs would be met ahead of time. And we had the most fun because I was able to equally participate in something with my family, and they were so excited to be able to do it with me. And we got to ride in a really beautiful space outside. Next slide, please. So, how did we adapt cycling to me as a person with ME/CFS and POTS and all of these things? The recreational therapist had talked to me about what my needs were ahead of time, and she started me on an upright tricycle, specifically for balance and ergonomics. It had electronic assist, which was absolutely critical to ease my fatigue and my POTS. And I wore a Bluetooth chest strap heart rate monitor that synced with my watch, and I programmed it to alarm me if my heart rate went over a certain point, and that reminded me to take breaks or bump up the level of power assist on my bike. I also then went on to try an electronic recumbent mountain bike in a nearby county. And that was so fun because it was the first time I got to go off-roading. That just means like on a dirt trail, but that's not something that I was able to do. Even walking on a dirt trail was pretty much impossible for me. So when I tried that electric recumbent bike, it opened up doors for me because I got to be out in nature on an off-roading dirt trail, and I had so much fun. I literally did not have to pedal at all. If I did not want to, I would just crank the electronic assist and have it take me forward. Next slide, please. So now we're going to talk about adaptive rock climbing, which was the next activity I went to after adaptive cycling. So I paid less than $16 total for the entire 8-week class through our city. That included our gear rental, so the shoes, the harness, and then the ropes come with the gym. And I will tell you that you can't even get a day pass without equipment for that cost to this climbing gym otherwise. And so what we did here is that each one of us participants was paired up with a knowledgeable staff person or volunteer who helped adapt to our needs. And then we had an adaptive climbing expert come up and help us. So you can go ahead and start this video now. So this is a video of me climbing in real time. And what I want you to notice is that right here, I'm taking a break on the wall. I looked at my watch because it started to alarm at me to say that my heart rate was too high and I needed to take a break. And it's no big deal for me to do that. That's part of the adaptations that I make as an adaptive climber. The other thing that I do is that I reduce my sensory overwhelm by climbing at off times when the gym is not busy. And then the other adaptation that happens for me while I'm on the wall, which is very important, is that my belayer keeps the slack really tight, which wouldn't be the preference of like pro climbers. They want the space to be able to maneuver, but I like my slack kept really tight because it means at any moment if I want to take a break, I just sit back into the rope and it's kind of a little chair for me and it allows me to take a break. The other thing we did during adaptive climbing is that because my husband and I climbed together, it was important for me to be able to belay him. And I didn't ever think that would be possible for me to do. And the expert adaptive climber, who's a disabled climber himself, teaches adaptive climbing across the country and the world. He got me belaying again. I sit from my rollator to belay. I use a belay device with extra safety mechanisms. I put gloves on so I reduce the sensory overload of the rope. And then I trust the rope so that I don't have to keep my neck uncomfortably up the whole time, which is something that the adaptive climber taught me that he does himself. Next slide, please. So now we're going to go on to a little slower paced class that I took. And I think it's important to show you the variety of things that I've done. It's not just all super intense, athletic activities. This art and nature class is a great example of leisure activities. Before I got sick, did a lot of visual art things. They were too hard for me to continue to do after getting sick because I found I either had the energy to set up all my supplies or do the art, but I didn't have energy for both. And it's really hard to make that happen if you can't do both. So I paid $6.10 total for this 6-week class. They provided all of the supplies, which was a substantial amount, and they cleaned up after us. And that's part of what made it accessible for me. Next slide, please. The other pieces that made it accessible for me is that it was located at accessible locations around town with easy access to nature views. So this is an open space that our city owns, but you can see concrete on the bottom right, and there's a whole accessible parking space that's fully accessible into the building we went into, which extended into an accessible patio that had a beautiful view out, and that's what I painted on the right. This class was also taught by an occupational therapist, and like I said, materials were provided and cleanup was taken care of. And that meant, for example, on this day that I painted that, I just had to have enough energy to get there, sit down and listen and paint, and an hour and a half later I left and I got to rest for the rest of the day. Next slide, please. So now that we've done a leisure activity, let's get into the most intense adaptive recreation I've done, which is river rafting. And where I live, in addition to biking, the river is part of our culture here. It runs through our town. Many people engage with river activities. I did not ever think I'd be able to do that again because I didn't think it would be safe for me as someone with ME/CFS. Well, adaptive river rafting proved me wrong. Next slide, please. So, I'm the one that the little arrow is pointing to. That is actually me in that boat for real. I don't know if I would have believed that if I had told myself that like 5 years ago. But here's how we adapted. The recreational therapist stacked every strong person they had in that boat. I think I was the only disabled participant in the entire boat, but that's what I needed. They installed a handle in the center of the boat for me to hold on to. They also allowed me the option at any time to slide down and sit on the bottom of the boat and lean my back against the bench thing we sit on. And they placed me in the middle row of the raft for safety. And then the other thing is that I rented wetsuit gear for temperature management. I have very poor temperature regulation. I also have Raynaud's. I can't let myself get too cold. I know that about myself at this point, 10 years in. And so everybody else here is in shorts, and I was literally head to toe in a wetsuit, even including booties on my feet, because that water was cold when it splashed up. This was so much fun. One of my favorite parts about it is that it was a totally new sensory experience for me. I got to see the river from a whole new perspective that you cannot see that just by driving by when pulling over to sit, because I got to see the river and the canyon from the middle of the river. Next slide, please. So I said that I live in Colorado. Snow activities are part of what we do here. And I am not ready to do adaptive skiing or snowboarding. I just don't feel comfortable with that yet. So what I did instead is adaptive snow tubing. You can see here how much fun that I was having. I literally had not screamed like from pure joy like that in such a long time. And it was such a fun experience and memory for me to have with my husband, who's in the front of the tube there. So you might be asking, how the heck do you adapt snow tubing? Well, first of all, it was the recreational therapist's job to investigate accessibility and communicate our needs with the facility. That included extra time to get me seated on the tube and then hooked up to the thing that drives you up the mountain, whatever that word is. And I also took frequent breaks with space to warm up, which is important for me. Again, temperature. And then everybody else rode in a large passenger van with the city. I did not. We drove ourselves so that I could manage car sickness and other symptom management. Next slide, please. So the last sport that I'm going to talk about is adaptive pickleball. And this is something that I just started like less than a month ago, I think. Our city had a one-time clinic. A Paralympic athlete came up and taught us adaptive pickleball. They had a whole fleet of sports wheelchairs that we could borrow. So that's what I'm seated in here. You can see that the wheels are really tilted at an angle. Yeah, you can go ahead and play the video. So that's me that you see over there in the mask that's going to serve it. And I did that the first time I had ever tried playing pickleball that night right there. So I really want to emphasize I've never played tennis or table tennis or anything like this in my life before. And I had so much fun. Let's go to the next slide, please. So how did we adapt? Well, first of all, like I said, we used these sports wheelchairs. I don't usually use a wheelchair in my everyday life nowadays. There was a time when I did, but now I typically use my rollator as my primary mobility aid. But using the sports wheelchair here meant that I was seated all the time. There's a lot of dead time where you're just waiting for other things to happen or somebody else to go chase after a ball. And I was seated that whole time. It allowed me to manage my heart rate. So in normal everyday life, when I'm standing in front of the microwave waiting for my breakfast for like a minute, my heart rate gets to 130 or 140. And while playing pickleball, seated, granted with all of my meds and hydration on board, my heart rate did not go over 130 or maybe 140 in a few moments. And it averaged like 100, 110 because I was seated in that sports wheelchair. That's what allowed me to participate in this clinic for 2 hours. 2 hours would have otherwise been completely impossible for me. If I tried to do this activity while standing, I wouldn't have lasted 10 minutes. Next slide, please. Oh, thanks. So now that I've taken you on a little tour of my adaptive sports that I have done as a person with energy limiting illnesses, you might think, well, what are options in my area? I want to know, so you can consider it. So first thing you should do is search adaptive recreation and then your city or county or even state, especially if you're in a rural area. And then you can look for city, county, recreation programs that are inclusive, or you can look for more specialized nonprofit organizations. When you do this, make sure to look for low-income programs or scholarships so that it's financially accessible for folks like us. And I did a little bit of research ahead of time for Seattle area. You guys have a really great nonprofit that does this called Outdoors for All. They have all kinds of programming. So options I saw just with brief researching: adaptive cycling, climbing, skiing, kayaking, power wheelchair soccer, sled hockey, wheelchair basketball, goalball, which is a sport for vision impairment. And then there was adaptive circus arts, which sounds pretty fun to me, honestly. And this screenshot that I took is from a program that has adaptive cycling equipment, I think in 2 different parks in the Seattle area, like Monday through Friday, most of the day, for free for you to try out. Unfortunately, it ended right in October, but I definitely would encourage you to put this on your calendar for next spring. Next slide, please. So, one of the last things I want to say about adaptive recreation is that the inclusivity there is such a huge benefit to us. There is an understanding and flexibility from everyone involved that we might need to do things in different ways or might need extra support. There's also that understanding from our peers of other people with different kinds of disabilities that, like, yeah, we all have different support needs or access needs, but we're all here to come have fun and play together, whatever that ends up looking like. And then the best thing about it is that it's not our job to figure out accessibility. That's probably my favorite thing, because the rest of the time in this world was not built for us to live in, and it's our burden to figure out, can we get into this building? How are we going to accommodate this activity? With adaptive recreation, it's the staff's job to figure out how to meet our needs. Yeah, we need to communicate our needs, but it's their job to investigate accessibility and adaptations. That's part of what makes it accessible for us, because it's less energy for us to do it. Next slide, please. The last thing I want to say, there's supposed to be little emoji pictures of spoons here, which hopefully other people in the room know what that means. They're just a symbol of units of energy for us chronically ill folks. I want to say that there's a lot of variety in the level of disability and support needs in our community. And I know that there will be folks in our community that the activities I talked about today would not be possible safely within their energy envelope. And my hope is that this gets the conversation started of all the different various activities and programming that exist out there to meet people where they are. Because adaptive recreation staff are used to getting creative all the time to meet so many different kinds of disability needs. I really want to make sure you hear me when I say that this is not about pushing people past their comfort zone or past their energy envelope. It's about bringing joy to our community in an easier and more accessible way to stay within our energy. Next slide, please. So, in conclusion, I want to say that adaptive recreation helps people with long COVID and similar chronic illnesses and disabilities. It helps us access joy again in a safe way within the boundaries of our energy. Social, leisure, and recreation activities are important for us to have a full and balanced life. And we know that long COVID and ME/CFS makes it really hard to do those things. That's why we have adaptive recreation, to help make it easier and safer for us to engage with fun activities again. And finances should not be a barrier because there typically are scholarships and reduced fee programs that we can qualify for so that we can have fun without it impacting our financial stability, which is an important consideration. So with that, I will open it up for questions and comments. Oh, and you can go to the next slide.
Thank you so much, Alison. In the interest of time, I think let's take a 3-minute break before we go on to the next speaker. So we'll meet you again after 3 minutes. All right, welcome back from your break. We will now move on to our first of 2 panels we have scheduled for this afternoon. We are really excited to offer you these panel discussions. This first panel consists of experts who will speak to us about cognitive symptoms associated with long COVID. They will each tell us a bit about their work in long COVID and what they see in clinic, or how they address these symptoms with their patients. After all 3 of the guests have had a chance to speak, we will open to Q&A from attendees in the audience as well as those who are here virtually. So our first guest is Fleur Gottfried. Fleur is a speech-language pathologist at the Comprehensive Outpatient Rehabilitation Program at Harborview Medical Center. She has 25 years of clinical experience working with patients and neurological injuries and conditions. She also holds a certification as a brain injury specialist. Since 2021, Fleur has worked with long COVID patients who have come through University of Washington Medicine's long COVID clinic. Welcome, Fleur. Next is Dr. Gina Formia. She is a board-certified clinical neuropsychologist who provides outpatient neuropsychology services at Harborview Medical Center and also serves as the rehabilitation psychology clinical director for the Comprehensive Outpatient Rehabilitation Program at Harborview. Welcome, Gina. Our third panelist is on her way. It's Dr. Payal Patel. She is Assistant Professor of Neurology at the University of Washington. Dr. Patel is supported by an NIMH-sponsored K23 Career Development Award to evaluate immunological and imaging markers of cognitive outcomes in young adults living with perinatally acquired HIV. She is the lead investigator of an NIH-funded R01 study on advanced white matter neuroimaging in young adults living with HIV. And she is the site PI for the decades-long NIH-funded Charter Plus study on cognitive outcomes in older adults living with HIV. She's also a co-investigator in the AHRQ grant to improve access to care for long COVID in the Pacific Northwest. Her current research is dedicated to evaluating biomarkers to predict cognitive outcomes in young adults with HIV and pediatric COVID-19. Dr. Patel is a practicing neurologist caring for adults with HIV and children following COVID-19 and other infections. So I welcome the two panelists here and the third panelist on her way. I hope that you can talk for a few minutes about your work and what you see in clinic. And yeah, please start, Gina.
Maybe that's better. So as I was introduced a neuropsychologist at Harborview and began to see post-COVID patients really from the very beginning when our clinic started, first very few and many more recently. And really, from a practical standpoint, what we're doing is meeting with patients to assess neuropsychological cognitive functioning across multiple domains, so memory, attention, problem solving, verbal skills, visual spatial skills, as well as psychological functioning, to get an idea where patient skills are at this point in time, like a snapshot at that point in time. And we do that to add as much as we can to help physicians with diagnostic questions, but really a big part of what we look at being in a rehabilitation medicine setting is how to help people manage functional cognitive issues day to day and also help with recovery. And so a lot of what our data goes to clinically is to help with next steps in terms of rehabilitation planning and addressing functional cognitive symptoms. And in that way, we work a lot with speech therapy because so much of what they're doing is implementing different recommendations and ideas about how to functionally improve. So Fleur, if you want to give a few minutes.
How about this? Okay. So I think being here all day, my job is kind of done. Everyone's talked about brain fog and cognitive symptoms from long COVID. We've heard a lot about from other speakers about how to manage those symptoms. So I feel like I'm a little bit echoing what others have said about pacing and using strategies and tracking and being consistent. But I guess we're the therapists that you're actually going to sit down and talk with and figure out and customize those strategies. And as a speech therapist, we want to know what your goals are. That's really, really important to help us focus on something that's achievable and attainable.
Thank you so much. I think I'll go over to questions that we have, and please feel free to add stuff, but I will start off with Gina. Gina, what tips do you have for pacing when it comes to cognitive issues?
I think a couple of things to consider with cognitive issues and pacing, and one is sort of a macro level and one's a micro level, meaning are you thinking about what cognitive things do I do in my day and how do I get through of all those? So let's say you sum that up to be 4 or 5 activities. How can I get through those in the day successfully versus the idea of, is there a cognitive activity that's really important to me, like let's say reading or using computer that's been very difficult to get back to? And what are the techniques I'm going to use to specifically increase my endurance for that activity? So I think that's maybe a good way to first approach it as to what the goal is. I think folks have talked a lot about, to some degree, what to do with the pacing for that general, how do I do this load of cognitive activities in my day, right? Where you're going to break it into smaller chunks and take rest breaks throughout the day and intersperse those. I might just say a couple words on that other idea of if there's a specific skill that you want to be able to participate in longer or do longer. And one idea with that is to think about what's my baseline, meaning let's say it's reading. How much can I successfully read each day, even on good days or bad days? And let's say you figure that out to be 10 minutes. So that's a good thing. So that's where you're starting. And make that the goal that you're going to do that each day because you know that's what you can reliably do. And then we get into that idea of a percentage, of increasing that by a certain percentage each day, very small amounts, but you can see what the idea is. You're going to get your baseline, so to speak, to grow. And so I think that's maybe just a good framework to have in mind when it comes to how do I get stronger and better on certain specific cognitive tasks versus the idea of just how to do more cognitive demanding things in the day. And Fleur, I don't know if there's some things you want to add to that as well.
There are a lot of, is that working? There are a lot of, we've heard, it didn't show up, but the spoons that came up with Allison's talk, so the whole spoon theory, which I think came out of this autonomia, is one idea I've used. So that's something you can look up in terms of how many spoons it takes to do certain tasks. I heard a version of the Pomodoro, which is kind of the idea of doing a task for a set amount of time and then having a forced upon break, or I modify the Pomodoro a lot based on what my patient's goals and activities are. I've used tracking charts, just like in rehab psychology. Some patients use spreadsheets to help them understand what symptoms are exacerbated by what activities, or how they've slept, or if they have pain. So all of those, I think, my colleague uses a kind of a bank analogy where you deposit and take out, you would withdraw, so you understand how much energy you have left. All that goes to say that, pacing and energy conservation is a large part of what we're doing here and trying to understand how much you have, how much you're going to use, and what happens when that, doesn't go as planned. What do you do to compensate for that?
Thank you for that. That's such valuable, very helpful information. My next question actually is for both of you, and perhaps Gina can start off first. What have you seen work or be helpful for patients who have very severe long COVID or ME/CFS, who cannot listen to music or cannot learn new things? What are some of the strategies that work for them?
Well, that's a good question. I think it's hard sometimes to do broad ideas because I think each individual has their own specific learning situation and things that affect it. But I think a couple things I would think about is, one is what's the goal? Again, like Fleur had mentioned, what is it that you are trying to achieve and want to learn? And I think we can think about it a couple ways. One is breaking it down again into small segments to learn, and to have frequent reviews and sessions to learn something. The other idea is saying, do I also just need backup systems? Meaning, do I need a way to compensate? So is it all going to be just trying to memorize and learn things? Or is it going to be, gosh, if there's some things that I want to hold on to and remember, do I have a good system to record those things, to be my memory backup? And I think that's a really good way to look at it, because your goal is to be as independent as possible with memory tasks. And whether it's going to be, I'm just going to memorize it like I used to, or find ways to do that, or I'm just going to have a system so that if I need to refer to something, I can do that, look at my memory book, look at, if you like written things like me, or if you like electronic things, you can do it electronically. But you've got a place to go so that your memory won't fail you, right? You'll have this backup, and that makes you be more independent with what you want to do. So I think setting the goals and then also determining what fits best for the point in time where you are in your recovery. Is it finding ways to enhance memory, which might be taking smaller chunks, doing it repetitive intervals with rest breaks, or is it, I'm going to need a backup system, and what's the best one I can devise for myself, which is, again, my colleagues in speech do a great job at customizing that to people's interests, right? If you're electronic, if you're written, what styles work best for you?
Yeah, I think that's a really hard question to answer broadly. If I use an example like somebody who's working and has had trouble kind of listening to and integrating in meetings what's being said, trying to take notes and also ask questions, answer questions, which is a common complaint. Like with all the Zoom meetings we're doing now, it's hard to keep track of who's on the call, who's saying what questions are being in the chat. And so we've come up with very customized strategies, like maybe there's somebody who just monitors the chat, somebody who is taking notes, actively taking notes, setting agendas, following up with people after meetings, having So I think it just depends on what problem you're presenting with and what you're trying to accomplish and what's available to you in terms of strategies or accommodations in the workplace. So those are pretty common complaints, people having trouble keeping track of what's being said in meetings. What are my action items? And so talking through that with, I think, a speech pathologist is really helpful because you can really personalize those strategies.
Thank you so much, Gina and Fleur, for talking about this, because it's so very important for our patients to know that these services are available to them and that the approach can be customized, which can be so integral to their recovery. My next question is, can you talk about the Visible app and its helpfulness for chronic fatigue? Have patients found it to be helpful and worth the cost, or are you familiar with this app? Gina? Okay, so I think we'll probably get back to someone who asked this question virtually. So my next question is, what has been most surprising and or challenging to you about cognitive symptoms in long COVID? So Fleur, you want to start?
I'll go. How long it takes. I think my understanding of how recovery occurs in brain injury and stroke, it's obviously a very different population with long COVID. And so expectations of how long things should take, how people implement strategies, how they get benefit from it, I had to kind of redo that entirely. Typically I would see patients weekly. With a lot of my long COVID patients, I would stretch that out. So every other week, sometimes even less frequently. So they would have more time to try to implement some of the things that we discussed in our sessions. And the general trajectory was a lot more kind of plateau versus kind of seeing this nice improvement in symptoms. Not that my long COVID patients don't get better, they do. And I want to emphasize that fact as I see a lot of improvement in my patients. It just doesn't occur quite as quickly or as neatly as I would like. And so that's kind of, it's good to understand that, and it's a good expectation setting as well, that this might not be a very quick process. It does improve, and hence the tracking charts are helpful so you can kind of see where you started and what you're able to do now. With or without setbacks, right? Because those are obviously a thing. So that was, I think, the most surprising thing, was just kind of recalibrating the timeline for recovery and understanding that things take a lot longer than I think either of us want them to take.
Gina?
I just think what I could add to that is the range of symptoms. So when I do an assessment, we look at all domains of cognitive functioning, like I mentioned in the beginning. And it was interesting to me how patients would have symptoms that varied between people, but also so many domains, from problem solving, visual, spatial, attention, memory, verbal, word finding. And that was just maybe a bit of surprise to me. And also, I think, speaks to some of the challenge that people have, because there can be such a range of experiences. So.
Thank you for that. The next question actually is very relevant and often faced by a lot of our patients. Why do I get lightheaded, dizzy, flushed when I try to carry on a conversation with more than 2 people in the room? It feels like sensory overload. I slur my words and I stutter. So, Fleur, do you want to take a stab at it?
Sure, I'll take a stab at it. I mean, I think it's just the overstimulation. Yeah. That would be my guess. And I think the hallmark too is that it isn't always there. Those symptoms aren't always there. They come and they go. You have good days and bad days. And so maybe one day when you have a conversation with 2 friends, you don't notice that. But another day, if the environment is different or you're more fatigued or whatever the factors might be, then it becomes more of a problem. I don't know that I can explain why. But I do acknowledge it happens and that there's variability.
Gina, do you want to add anything to it?
Yeah, I was going to say Dr. Patel, when she writes, may have something to say about the physiology behind it. But I would just say what Fleur was getting to, and I agree with, is sometimes it's just good to think about the environment, right? In terms of what's going on when you're trying to listen to those people talk. Is loud music playing? Are you in a restaurant? There are bright lights. Are you fatigued? that's just something to consider is to terms of amount of stimulation coming in, and is it making more difficult to track what you're really trying to focus on, and are there ways to alter that other stimulation to make it easier?
So Gina, my next question is for you. Can you talk a little bit to our patients about the specific cognitive testing that you do, and when patients come to you, how do you walk them through those steps?
Absolutely. So sort of a typical day would be that you arrive to our center, and the first thing I do is meet with you and just learn more about you and your background, what symptoms you're experiencing, sort of across domains, cognition, but we also want to know coping, psychological functioning, and physical functioning, because they're separate slices of the pie, but yet they all kind of interact together, is what we find and what I'm sure you've experienced. So part of it is just a general intake, and then the next part is I determine, based upon my interactions with you, sort of the best measures to give to assess cognitive functioning. So I'm trying to be thorough, but also really listen to what you've been experiencing and make sure we're targeting those areas. We have the benefit of really experienced technicians who administer our neuropsychological measures. The provider is there, but the technician will come in and go through the measures. We're also fortunate in that these measures have been standardized and normed extensively, so that's very beneficial. But yet we're also aware that these are still tests, and they're not perfect. They don't take into all of maybe your personal background factors, and we try to really keep that in mind when we interpret the results. But in terms of the day, what you would do then, though, is go through the measures. We really try to think about rest breaks, giving you time to sort of regenerate and get through it, because it can be several hours. And so we're trying to be sensitive to getting good data and comprehensive data, but not wearing everybody out, right? And getting you where you feel like I'm not measuring fatigue, but I'm measuring your cognitive skills. I think that's an important thing to think about. The other part that we do that I think is really important is, you go home at the end of the day, I interpret the results, but then I like to hold a time to just go over results with you. All our neuropsychologists do in rehab medicine. I think that's super helpful, because it's just another opportunity for me to talk with you about findings, for you to ask questions. What does this mean? What are good next steps? So, and then we're also fortunate to work with a team. So then I can talk with your team, speech therapy, your physicians, about what might be really helpful therapies, given what we found, right, from our piece of the pie. So yeah, that's sums things up.
At this point, I invite questions from the audience. If you have specific questions for our wonderful providers, please go ahead.
I'm curious about, could you use the mic, please? Thank you.
I imagine that is this on? Yes. I imagine that I'm not alone in navigating work accommodations not actually meeting my needs. I've been dealing with a hostile work environment, some discrimination, laughter, being called weird, mocked. I'm saying this partially because I don't think that I'm alone. I have pursued the avenues that are available to my company for managing that. But at the end of the day, we're really alone in those situations. And it is, I mean, when your cognitive ability declines, it really changes. Is there a way to talk to your advocates and make a more supportive environment? Because there's a limitation to what managers and agencies can actually do.
Thank you.
This is, I'm going to put a plug in for VOC, Vocational Rehab Counseling. It's another professional that we work with. So if my patients are working, I usually try to pull the vocational counselor in, because we can, along with neuropsych evaluation data, come up with some recommendations for accommodations. And so I'll generally generate a few with my patient, like, do you need extra rest breaks, or should you work from home, all the time, full time, or, do we want to start your workday at a different time, or are there, only one project at a time, whatever accommodation we've come up with. But the vocational counselor is really the person to help kind of finalize those along with the physician input and data from neuropsych testing, and then communicate as a liaison between the medical professionals and your workplace. So I rely heavily on our voc counselor to help with that piece, because that's outside of what I do.
Any other questions, please? Yeah.
Is this on? I don't know if this is on. Great. My question is, do you have any connection or knowledge of resources or yourself around the intersection of neurodivergence and long COVID? And do neurodivergent patients differ in any particular way? I say this as someone who is diagnosed autistic and with ADHD.
I mean, I think all I can talk about is anecdotally. You know, patients that carry a diagnosis prior to their COVID infection of ADHD or autism or any other neurodivergent diagnosis, you know, it seems like it's pretty common. I encourage them to continue managing whatever they were doing before. So if you were on a medication for ADHD, this is, of course, with physician approval, don't stop taking it. If anything, like this is the perfect time to be continuing it. You know, I will ask them to ask their physician if there's a change in dosage or something like that might help, because I think it all plays together. Nothing is in isolation here. So don't remember the exact question. Do I see any difference? Is that, I'm gonna let Gina talk, I'll think.
You know, I would say it's a really good point, and so much of why I try to focus on getting a really good background, right? To try to understand what factors are in play before you got COVID and how that might affect your current experience and your cognition, frankly. And I think that I can't say there's one pattern, but sometimes what I'll see is things that were challenging before have become more accentuated now than before. So, you know, maybe attention, I'll just say, was at this level, and now you're noticing, boy, it's dropped lower than maybe somebody who pre-COVID had attention right at that level because they didn't have, let's say, ADHD, if that's making sense. So it just feels like it's making some of the current symptoms even more noticeable to the individual, which is hard and frustrating, and we try to address that. I think that's why really an individualized approach is so important in the assessment, to try to understand the interaction. And like I say, are things becoming more accentuated or more difficult than they were before?
So it's kind of a two-part question, so I apologize for that. The first one's really simple, which I have ADHD, so I definitely understand that question. When I heard the word spreadsheets, and when I heard the word like schedules, I had like a flashback then to like, I don't know, something that happened at work. But it really took me back to, is there anything for people with ADHD that can help them with memory that's not like the A, and by that I mean ALEXA or Siri or any of those, that can help you, that doesn't involve a spreadsheet that you're aware of? And the other thing is, this is more to do with probably what happened this morning, and I wasn't here, unfortunately, but is there anything being done from the doctor's side on cognitive and other symptoms with workplaces? Because to carry on with that last lady's question, I'm feeling as though corporations are essentially just dropping you in the trash. They don't care about it. They want you to be working. When you can't work, they'll put ridiculous restrictions on you or things that will make you quit. And then when you've quit or when you've been forced to go to LTD and they've denied you, you're kind of left on, the garbage heap. I was wondering if there's anything that doctors are doing proactively with corporations and the workspace around trying to get them to identify that and understand and make the process better.
So I think our neurologist has walked in at the right time. Yes.
Would you mind repeating the question for me? Apologies.
No, that's quite all right. Well, the first one, it was a two-part question, so I apologize. The first one was regarding ADHD and any specific apps or things that can help people remember or stick to schedules. And I mean like things like the laundry's on, go down and take it out, or take your medicine. I use Alexa and other apps, but they're very frustrating when you're out in public or out with other people. And I find spreadsheets and things like that just impossible. The second part was regarding workplaces and are doctors and institutions doing more to help workplaces understand what we are going through as patients, because we're being abandoned, we're being dumped, we're being let go, we're being forced to apply for LTD and then getting denied. I have a lawyer. I've been off work now for 3 years and haven't been paid. What is being done to try and help companies recognize what is happening? Because I feel like we're the tip of the waterfall, right, that's about to hit them. I don't think they know what's coming.
Absolutely. Very important questions, and thank you for asking them. To address the first is only anecdotal evidence that I have that's worked for other patients. They too face similar struggles, and some have gone to paper and pencil, particularly sticky notes. Yeah, that has been the most common thing that's come up, and people have put sticky notes in like key areas, like right before they leave the front door, and that, you know, tried and true method has really been what people have been forced to rely on, but it's very effective. I missed the introduction, but I primarily work with kids. And so I can take a page from my work in the pediatric clinic, which is really working with the 504 plan. There's a lot of laws in place, particularly for public school systems, to help kids engage with schoolwork again. I think one of the most challenging things is that the process is very dynamic, right? So what you are able to do one week is very difficult to do the next week. So I really encourage people to reevaluate on, you know, a month by month level, to set the expectations that today is a good day and I'm able to meet all of my, you know, requirements for work, but that doesn't necessarily mean tomorrow. I put that in a letter that I send out for kids, for families, for therapists, for schools and administrations. And so really having that in writing and saying, we know that this, you know, is a challenge, but it may not look like a challenge every day. You just need to recognize that long-term process, I think has been helpful overall. Sure.
I just want to say something really quick. Sticky notes are great. Be careful not to go into sticky note hell. So this is where your therapist can help you, because there's a right way to use sticky notes and there's a really bad way to use sticky notes. And then I will just say, I'll just acknowledge what you've said about the workplace. I have had a lot of patients who have lost their jobs, who have been laid off, been denied disability, or left their jobs because they didn't feel supported. I don't have an answer to the question. I just want to acknowledge that I've seen that.
Question for you. It's a simple question, but probably a complicated answer. I don't know about the rest of you, but at certain times I'm perfectly all right, and then I just fall apart. Do you know what, have any ideas what triggers this? And I mean, I know I'm asking you a lot, but if I could find some way to slow down these, I call them episodes, it would be fantastic, or at least a little bit.
I just say it's a difficult question, so we're all looking at each other. You know, I think for me, just from a practical standpoint, is trying to do sort of analysis of the situations. And I know it's sometimes hard to figure out, and maybe you've done a lot of that, but occasionally sitting across from somebody else and trying to go through, here's what's going on, in terms of sleep or the environmental demands, busy situation, stressful situation, nutrition, all those things, to see if we could find some key factors that may seem to be playing. And sometimes their roles, they play a role individually for the person, right? What may be something that triggers you doesn't trigger the next person, but at least for me on an individual level, that's where I think I've seen the most gains, is trying to just go through and analyze those situations and see if we can see any patterns, any triggers, and then how we can try to address those, right? To sort of specialize at your situation. From a broader standpoint, I don't know, Dr. Patel, if you have ideas there.
Yeah, that's exactly, the first thing that comes to mind is I give my patients homework and I say, you need to sit down and write whatever causes or precedes some of these events. Then I partner with the therapist, right? And I say, this is the challenge. This is what is the trigger that's causing some of these events. And how do we create an environment that eliminates those triggers, but steadily creates gains in activity, for example, or whatever measurement we're tracking? And it's not really a perfect answer, because I really wish there was like a one-size-fits-all. Personally, I wish there was a one-size-fits-all. It would make all our lives a lot easier. But each patient that I've seen has been different. And so each patient has their own tailored approach. They have their own starting point, they have their own triggers, and then sometimes they have unexplained declines. Maybe even another illness that's asymptomatic or something that we don't even recognize. And we really, kind of work with keeping the hope and trying to re-engage with this process, the pacing, the skills that we're trying to continuously acquire over time. I really do wish I had a better answer for you, but that's what we do clinically.
That was kind of a long shot, but it's worth asking.
It's worth asking.
Thank you very much.
Dr. Patel, can you take this opportunity to talk a little bit about your work with pediatric long COVID patients that may be beneficial?
Yeah, absolutely. If this has already been covered, I apologize for the redundancy, but I am a pediatric neurologist at Seattle Children's, and though the rate of pediatric long COVID is very low, given the fact that so many people have gotten COVID, the number of children facing long COVID is pretty high. And what we do, thankfully, because we have a 504 in place and a whole lot of tools from a legal standpoint to help kids with disability, is we create this tailored approach. We create goals that the child wants to achieve. We create goals that the family wants to achieve. We try to prioritize those goals. So for example, if their number one priority is doing well in school, then those first 6 months of recovery is focused only on that, not on, going back to sports, and not on other things. And we really look at the long-term plan. This is kind of gradually developed over time. Another thing that I recognize in our pediatric clinic is that medications are even less effective in children, and they come with the same amount of side effects. So we really encourage habit setting, sleep, using sticky notes, implementing a 504 plan, and pacing. And that has actually worked really well in most cases. And a few of our patients have actually needed some medication, but really as a boost to get to their final goal. And so it does affect kids, but the kids are actually all right. So I think there's a message of hope in there, hopefully.
Thank you. In the interest of time, I'm sorry that we should probably move on to our next panel. And thank you so much to all three of you. Let's take a 2-minute break, and then we'll come back with our last panel. Thank you. Hello, everyone. Should we get back to the next panel? This is our final panel. So And it's also, hopefully, we will have some of the questions that we did not get to answer before. So our next panel, which is our final panel, consists of clinicians from our very own UW Medicine Long COVID Clinic. Like our last panel, each of the panelists will have a chance to speak a bit about their experience treating long COVID, and then they can take questions. Actually, we have a lot of questions here already. We are joined by Dr. Nikki Gentili. You met her this morning. Next to her is Dr. Jessica Bender. Dr. Bender is a clinical assistant professor in the Division of General Internal Medicine at UW. Her clinical work is at Harborview Medical Center, where she sees primary care patients and does long COVID consultations. She has been the General Internal Medicine Medical Director for Long COVID Clinic since 2021. Next to Dr. Bender is Dr. Kendall Sankri. She is a physiatrist who has been seeing patients in the UW Long COVID Clinic since 2022. Her clinical specialty is the rehabilitation from neurological conditions, including spinal cord injury and sequelae of COVID-19 infection. Her research interests include the epidemiology and characterization of neurological complications of COVID-19 infection. And seated next to her is Lindsay Knowles. Dr. Lindsay Knowles is assistant professor in the University of Washington Department of Rehab Medicine and an attending psychologist in the UW Medicine Long COVID Clinic. She provides individual therapy and leads groups designed to improve symptom management and coping in people living with long COVID. Dr. Knowles also conducts research to improve behavioral health treatments for common and disabling symptoms in people living with chronic health conditions in long COVID. So thank you, everyone, all of our experts. Let's start off with a question from the audience, actually. So can you please talk about apps and wearable devices for pacing and in long COVID patients? Brands, specific brands, etc. And the Visible app, which was talked about earlier, is heavily advertised on Facebook, but I have no idea if it is legitimate.
All right, I can start talking about this. So in terms of specific apps, the only one that I've really come across is Visible, and that's really been kind of anecdotally, just have patients who are coming in and using that app. There are some patients who seem to get a lot of benefit from it, and it seems to provide real-time information that people can use to kind of more objectively monitor their fatigue and energy levels throughout the day, and it helps some people with pacing. So I've generally found that to be fairly helpful for people. I also have some patients who use wearable devices like Apple Watches or Fitbits to help when they are active throughout the day, and they can use it to help monitor their heart rate or use their heart rate as a sign of how they're doing, if they're kind of overdoing it with one particular activity. For example, I have one patient who makes their heart rate really big on their watch, and then that allows them, when they are exercising, to take a step back, take a rest break when their heart rate's getting above a certain level that they found is kind of their threshold for causing them post-exertional malaise the next day.
I can also add that I have several patients that have Oura rings, and for those of you that don't know what that is, it's a ring like this. It's pretty small. They really love it because it helps them track sleep, and you can tag things. So if you had a particular meal and maybe there was indigestion involved, or if you had a certain level of activity that may be impacting you, that app or the Oura ring can track over time and tell you things that you've tagged that are associated with different sleep patterns and activity levels. So a lot of the patients that I see that do use Oura rings, both in my primary care practice and also in my long COVID practice, really love them. The disadvantage of it is expensive. It's a couple $100s to actually buy the ring. I got mine as a gift, and I'm very grateful for that. And you have to pay a small fee every month. I can't remember if it's like $2 or $5 a month. So it's not free, but it works really well.
Thank you for those really valuable answers, and I hope that our member in the audience who posed this question got their answer. So that's great. The next question is actually for Lindsay. Lindsay, the question from the audience is: I hear speakers talk a lot about support and reaching out. What if you are completely isolated, no partner, family, friends, and can't afford a therapist? Where do you get support? I was very social and now abandoned by everyone. It's hard alone.
Thank you for this question. I guess I'll come on. Thank you for the question. I'm so sorry that this is your experience. I would say first, in terms of therapeutic support, which I would recommend for someone who's feeling so isolated, is there are therapists who provide therapy at a sliding scale. One organization that I looked up that can provide, you put in your zip code and you can find providers who provide therapy at a sliding scale, would be openpathcollective.org. Also, trainees in universities and medical centers also can provide free or therapeutic services on a sliding scale. So in terms of finding therapy, that sounds really important, and I would just recommend finding affordable therapy. In terms of community and engagement, I think what Allison said in her presentation earlier was really important, and Kristen as well. So maybe using your values, so identifying what's important to you, what you value doing, and using that to figure out kind of what kind of community you may want to engage in or re-engage with. Also thinking about how much you share at first about your needs versus just getting interested in whatever this valued activity is, for example, and then building those relationships over time, and hopefully they become more supportive. So I would just recommend exploring values and getting engaged in valued activities, communities who are doing those, and then also definitely getting affordable therapy, and there are various resources for doing that.
Thank you. And my next question is for Dr. Bender. Do you have any suggestions on an appropriate way to recommend to our PCP or specialist to watch this symposium? It would be comforting to know that doctors we receive care from take the time to learn about long COVID and be aware about why we are so concerned. Maybe you can take this opportunity to address some of the ways that we are trying to do that.
Great question. If only I had the power to make everyone listen to me. I would use it for good, but this seriously is such an excellent question. And I think it reflects the huge, enormous need for this new disease, right? We've talked today and you've heard from experts on research, on establishing the diagnosis, on coming up with evidence-based treatments, on providing education to the healthcare system, to changing the healthcare system, to the policy that doesn't exist to support people with long COVID. So it's a large ask. I'm also a primary care doctor at Harborview, so I see people, adult patients with lots of complex medical needs, and I know that the job of a primary care doctor is very challenging in our American healthcare environment, especially with these 4 years, almost 5, of the pandemic. To that end, though, we are working on this area through the AHRQ network. One of at least our institution's objectives is to train really a healthcare workforce. You know, if we had pie in the sky, if our dreams could come true and we had the people and the funding, we would be training the entire WWAMI region that this medical school supports. That's Washington, Wyoming, Alaska, Montana, and Idaho. And that's our goal in the next 5 years, to get started with that, at least through networks that already exist through the medical school, through networks that we are growing through AHRQ, as well as professional societies that physicians really go to for guidelines and for ongoing continuing medical education. So Anita and I have both worked with the Society of General Internal Medicine, which is really the professional home for academic internists across the country. Dr. Gentili has been working in her professional society in family medicine. We've also been working with the AAPMNR for physiatrists to really to create CME and make that available. And that includes events like today. This will be online and available for free. It won't be for official CME credit after today, but it will be used as a resource. And I think I'd like to actually turn it over to Dr. Gentili to talk about our future plans for our mini fellowship.
Yes, and that was actually the next question.
Oh,
go ahead, please.
Great. Before I address that one, I would also add that we recently decided to expand our office hours outside of our UW primary care network to focus on primary care clinicians outside of UW who are interested in meeting with us about complicated cases or about general questions. We are still talking about the best way to go about advertising this, but what I would say for now is any of the patients that are in the room or on Zoom, if your primary care doctor is interested in meeting with us to learn a little bit more about how to better manage your care or care of others that they might take care of with long COVID, then I would encourage them to email us, and our email will be attached somewhere in some of our materials at some point, a post symposium survey or online, but that would be the best way as of right now to at least get things going until we can figure out a better PR route forward for office hours. And then as far as the future goes, Dr. Chopra and I are co-chairing, along with our phenomenal Nova Rivera back there, who has helped put this event on, we'll be creating a mini fellowship for long COVID that will be accessible to any primary care clinician in the 5-state region. And we are currently developing that. We have a list of modules we'd like to include and some speakers that we want to include in this. And the fellowship will run regularly. It will have a set of modules, 6 to 8 modules that will happen once a week. And then it will, get a little bit of a break after that 8 weeks, and then the next cohort can come through and do the fellowship for that next 8 weeks. And so lots of information will come about that once we've developed more of the materials and the plan, but hopefully next year sometime.
So I have a wonderful question from the audience, and I think each of you please take a turn to answer this. Can you please talk about how you will use what you took away from the symposium, hearing from patients, their concerns, and how will you translate that into patient care? So Lindsay, can we start with you, please? And we can, yeah.
Well, I was just thinking, Anita. So yeah, great that I want to reflect longer to answer this question, so my answer might be different tomorrow. But I think what I've heard from patients today is an incredible, sometimes you think about it as holding both. There's incredible resilience in this community, but to be resilient, you also have to hold the pain that is living with this condition and the uncertainty of it, and acknowledging that, and at the same time, as we talked about, and you heard a lot of speakers talk about, what do I value, what brings joy and meaning to my life, and how can I do those things in a sustainable way? And it takes time and trial and error, and that in and of itself is frustrating. But I think I've just seen across the presentations today, and especially from our patients, that it is possible. It's just can be a journey.
So for me, I feel like one of the biggest takeaways was that accepting where you're at right now is so important. I feel like, especially earlier on when I was working in this clinic, I was really trying to help patients get back to where they were before COVID. And I feel like a few of the people who spoke today really made me understand better the idea of embracing kind of the new you post-COVID infection and still trying to reach to achieve all of the functional goals that you have, but that it may look very different than before COVID in each individual case. And I think in a practical sense, I have a lot of experience with recreational therapy and with adaptive recreation, and so I think expanding, distributing that information to patients in this clinic would be a very helpful next step.
This is such an excellent question, and as I've sat here today and for the last 4 years, I've learned so much more from my patients that I've learned from medical school, but learned from my patients and from my colleagues on this incredible team. But when it comes to how today will change my practice, I think it has really energized me and reminded me how important it is to advocate, to continue to advocate strongly for my patients who I work with, really partner together. But it's reminded me of all of the systems that are in place that make it near impossible to live with a chronic illness like long COVID in our country. And so, it takes extra work. It's things we didn't learn about in medical school, like how to support somebody's disability case, how to help them access resources like recreational therapy. I didn't learn about that as an internal medicine doctor, but I've learned from my colleagues. So I feel really energized that we need to continue doing the work we're doing and partnering.
Tough to follow those of you that went before me, but I echo everything that was said. Also, I will just add that in academic medicine, we often teach residents and medical students, and so one thing I would just add is that I do vow to not just continue teaching residents, but pushing a little bit more for them to be responsible for their own patients' care with long COVID and helping them through that, even if it might mean taking a little more time on my end. And then also, I have med students almost every time that I am in clinic, but I don't always have patients with long COVID on my schedule, but I plan on, even if they're not on my schedule, taking 5 minutes to teach them about the condition so they can leave med school and at least be aware.
Thank you so much. And I know that people in the audience will have questions. So if you do, please go ahead and ask us.
Hey there, thank you. One thing, I just talked quickly with Dr. Chopra at the break. It's as easy to hear people with mask on as it is mask off. I'm curious what you all know that we don't know in terms of taking off your mask in a room. That's just a basic question. The other question is, I'm often arguing with my parents and they're like, people aren't getting long COVID anymore. What is reinfections like? If people were coming down with long COVID, you wouldn't see stewardesses, you wouldn't see pilots on the plane. Sort of where are we at in terms of how people are getting long COVID through the new variants and strains? And what is it like to get reinfected now if you already have long COVID?
Thank you very much for both of those questions. And I really apologize. We did say this is a masked event, and here we are taking off our masks up here. And that was sort of a calculation that we did not ask for your input in as audience members. So if you can hear me right now, which is great, I will put my mask on right now for the rest of the session. I know that doesn't make up for the time before now that I didn't have my mask on. I see that you're in the back, and maybe that was a decision you had to make as a calculation that you're making every single day. So I'm sorry if that added some cognitive burden to all of you. To your other question, It's a good question. I wish I had a good answer. We're still seeing new cases of long COVID, and we are still seeing people with long COVID and other chronic illnesses who have those illnesses triggered or worsened by reinfection with long COVID, influenza, RSV, strep. I think we've seen all of these and more. So I think there's more to come on that. So our hospital system, for what it's worth, works closely with Seattle King County Public Health to monitor levels in the community of some of these common respiratory viruses, to then use triggers sort of on the communal level. Okay, this is when we need to really worry about this. This is when we trigger full masking protocols or N95 masking protocols in the healthcare system. I know that wasn't exactly your question, but thinking of ways we can protect everyone from reinfection is very important.
Yeah, we have more questions.
My question is, I've had COVID, long COVID, for over 2 years. The majority of my problem is cognitive. I had to step down from full-time and work part-time because I don't have long-term memory anymore. I can't remember things. My speech, I'll say other things instead of the words I want to say, and it's a daily struggle. I want to know, is there any support, financial support out there for people who have long COVID and can't work, full-time, and don't have the medical insurance to cover the diagnostic that needs to be done to find out what is wrong with you? I'm not worth a lot of money, and I have put out so much ever since I've gotten this disease. And are there grants, or is there something out there that can financially help us besides having to go on disability? And I think I speak for everybody that this is a very expensive disease. I mean, it's taken a lot out of us. For me, COVID has taken my career. I went to college, and I can't go and do the job because I don't have the mental facility to be able to do the job I went to college for. It has taken my future away from me. And I think we need help in being able to find a path that we can have some light at least to say, okay, our future's been taken, but we can take another path. But there's no support out there financially for people with long COVID.
I am not aware of any grants that are available to support people financially who are going through this, but I totally recognize that it is incredibly taxing from a financial perspective, and that Social Security disability does not make up for that by any means. I will say, at least more recently, Social Security has been recognizing long COVID as a disability, so there is that, and I think as physicians, we're happy to support people's disability claims in any way that we can, but I am not aware of any grants or extra financial resources that are out there.
I'll speak a little bit about this really challenging issue and complete lack of safety net, and not just sort of a long-term better safety net, but a short-term one for people who maybe are not deemed fully disabled by Social Security disability's intensive process that doesn't as easily allow people with long COVID to claim the SSDI that they are eligible for. And for people who do qualify, it's a long process, and there's nothing in between to support you for that year or 2 years while you're going through it. From a medical perspective, every state is different, but I will say for Washington State, we encourage people to apply for Medicaid, which is, based on your financial income. At Harborview Medical Center and UW Medicine, overall, we have a financial assistance program. I want to, again, acknowledge this is not perfect. This does not pay your rent or your cell phone bill or put food on the table. or relieve that huge stress, but it might lessen it a little bit to be able to access the medical care. Most of our clinics have social workers who we work with as well, who are far more versed in this area than I am as a physician, but it's very important for us as physicians to understand this huge challenge.
Hi, I'm Jessica. I come from Wenatchee, from the east side. I am a patient of Dr. Concanum from the Long COVID clinic. I am an RN. I have been on disability since April the 22nd from 2022. Sorry, since September 21st that I got COVID from a patient in the ER. My life changed, but I want to say thank you for doing this because it's very important. My health went down the drain. I ended up having like 4 major surgeries, and the last one even a little brain surgery. But anyhow, again, I want to say thank you for doing this. It's very important for the community to be aware, for all of us to be supportive from each other, and for the doctors, to primary care physicians to keep supporting us. I have a wonderful team. And like Dr. Concannon has been super supportive from the beginning. And I have a wonderful husband. Thank you.
Thank you so much for this message of gratitude. It really warms our heart. And I just wanted to add something that Nova alerted me to. We recognize that the funding is not, often enough, and we don't really have any perfect answer, but we are coming up with a patient guide to SSDI, which should be released within the next month. And if people are interested, please email our clinic.
Hi, thank you. This may have been discussed this morning, but I have long COVID and I'm too tired to go to an all-day conference.
Yeah.
So, but I'm just wondering if, regarding if you run into any situations with MCAS, and if you know any either pharmaceutical or nutritional strategies that help with that, such as there's a lot of stuff on the long COVID support groups about the low histamine diet or anything like that. So any information you can give me about that would be really appreciated. Thanks.
Thank you for that question. This does come up a fair amount. We work closely with clinicians that primarily function out of the Unger Center for Integrative Medicine. And they will also be involved in this mini fellowship to help teach primary care clinicians about supplements and various things. MCAS is part of that plan. MCAS is incredibly difficult to diagnose, as I'm sure you are aware. In order to diagnose it officially, it requires a lab test that has to be done in a very, very specific manner, and if not done properly, it will not come up with an accurate result. And it has to be done when somebody is in a flare of symptoms. And even then, if it is negative, it doesn't necessarily rule it out. And so it is really difficult to make that diagnosis. A lot of clinicians, unfortunately, rely very heavily on lab tests in order to make a diagnosis when it may not necessarily be needed to try to move forward in the patient's care. So in instances where MCAS might be on the list of possibilities, given the symptoms, regardless, there are certain options that can be tried that are histamine blockers, like, things like fexofenadine or Allegra, and various, allergy medications or Pepcid that a lot of patients have found beneficial. But there are other histamine blockers that have helped people that are prescription, like blanking right now because I too struggle being in an 8-hour symposium with a history of COVID myself. There's a list of that stuff, and if you'd like to send an email, I'm happy to actually connect you with our integrative medicine specialist that has materials on this. I can answer some basic information myself, and I'm happy to talk about this, even stay after and talk about this. But low histamine diets are also really helpful for some people. But again, there's no real evidence to support this right now in the long COVID population per se. While some might maybe studying some supplements and whatnot, more needs to be done in the area of nutrition and supplements in clinical trials. And everybody is different, so treatment regimens really should be tailored to the patient, and it depends on certain circumstances and symptoms that people are experiencing.
I was just going to say real quick, MCAS stands for mast cell activation syndrome, just for anyone who wasn't aware of the abbreviation.
I have one last question that is, I really would love you guys to address, which is, should long COVID patients be vaccinated? Should they get the booster, the COVID booster? Can you please talk about it, Dr. Bender? Yeah.
We certainly have seen repeat infection cause worsening symptoms for people. And so, yes, I would say absolutely yes. And I recommend a COVID booster, an annual flu shot to all of my primary care patients and patients with long COVID. Of course, there are some asterisks there, right? If someone has had an allergic reaction, you can't do it. There are different types of vaccines too, though. If you've had an allergy to one of the mRNA vaccines, you can take the newer Novavax vaccine, for instance.
Thank you. I think in the, just in the, do you have one last, so let's just take one last question from there, and then.
Thank you. I haven't heard anybody talk about any treatments or medications to help strengthen immune systems. Since I got long COVID, I am just susceptible to everything. And I've not, even with my primary doctor, with the long COVID clinic, I've not heard anything that would help with that. I don't know if there's anything that is being researched or anything that you're aware of. Thank you.
We are looking at each other puzzled. So we don't have a good answer for that. But I do want to validate that experience that you've had, because we see it as well in people with long COVID who get other infections, and maybe their kid had what seemed like the sniffles for 2 days, and then it hits that person with long COVID for 3 weeks. And it's just really hard to see. Acknowledge, again, anecdotally, in our Society of General Internal Medicine long COVID interest group chat that we have, someone brought up immunoglobulin testing. This is not in the guidelines, and again, anecdotal, seeing people with changes in their immune system with long COVID. Probably rare that it is measurable on these tests, but just something to think about for people who get recurrent infections.
Thank you. I think we have someone here. Do you have a question? Yes. Okay. Let's take this.
Thank you so much. And in the interest of time, I'll be quick. I have a long experience with being chronically ill because I came up with ME/CFS more than 10 years ago. and everything experience is terrifying. But does UW Medicine Long COVID Clinic, I have not heard you guys talking about connective tissue disorders and the impact that we see in long COVID in people with connective tissue disorders. Do you have specialty in UW within your clinic that addresses the connective tissue? The second one, without the connective tissue, mast cell been brought up. I was diagnosed with MCAS in 2016 on the first positive test, the 24-hour methylhistamine, and one of my relatives got diagnosed with mastocytosis. So it was interesting to see the family picture. It's not just one picture to assist in diagnosis, but the Mast Cell Disease Society is an excellent resource to start with, and they have an emergency protocol I found useful. So connective tissue disorder, mast cell, oxygen and oxygenation. Do you use hyperbaric soft chamber to facilitate progress in oxygenation of the brain, or just oxygen supplemental therapy, the 20-minute therapeutic 2-liter dose, especially if somebody had a pulmonary emboli or suspected pulmonary emboli or stroke or just long COVID, because we know it has. And that's an excellent hematology. I have not heard hematology, coagulation, endothelial damage mentioned today. I know it was little time and it's already a long day. Does long COVID clinic has hematology, coagulation, referrals, and work? Because again, if you don't have blood going into your brain, all the sticky notes, they're not gonna helpful. And my last one, connective tissue, blood flow, vascular compressions. We've got muscles, maybe it's nerve misfiring, maybe it's just muscle connective tissue, maybe our fascia not working very well. Maybe there was pre-existing concussion, whiplash, that's all exacerbated now. We have vascular compressions up here at the neck level. We have it in mouth, stomach area. May-Thurner syndrome, that's is also, it's extremely dysautonomy, symptoms of dysautonomy, the symptoms of POTS and vascular compressions go hand in hand. It's just like, how do you tell? Connective tissue vulnerability, mast cell makes connective tissue more vulnerable, oxygen, coagulation, blood clots. We come to our spinal brain connection and intracranial hypertension or intracranial hypotension. And part of my story with chronic fatigue syndrome was to patch my leaks, spinal fluid leaks in my spine. And it was amazing. I started tolerating music. I could listen to music again. I could tolerate this voice barely for 8 hours. And I'm just like, the MRIs are useful, the research is useful, the understanding all this. But I haven't heard any of it today. And does the clinic provide this, or is it still outside of UW scope of work with long COVID? Thank you.
So I will take the connective tissue question specifically and then pass it off to others for the rest of that. There's a lot to unpack in that. So I think it's important that there's a difference between inflammatory connective tissue disorders like rheumatoid arthritis, lupus, Sjogren's syndrome, the autoimmune rheumatologic conditions, and then there's connective tissue disease that where you can classify things like hypermobility and things that fall in that category. From an inflammatory standpoint, one of the concerns that we have on the lab medicine side is that people's immune profiles may change. So somebody who has an underlying inflammatory condition, like an ANA-associated connective tissue disease like lupus, for example, once they get COVID, their immune profiles can shift, meaning their autoantibodies can change and their disease process can change and worsen, and there can be flares associated. As far as, and because of that knowledge of on the inflammatory side. There is some question with the hyperdysfunctional immune response that does occur after a SARS-CoV-2 viral infection. What does that do to the body? There's been a lot of research done on the lab side for biomarkers, and there's no one biomarker or inflammatory marker that is suggestive of long COVID, but there are patterns that we think about that could be helpful, but these aren't consistent across the board in patients, and so more needs to be done on that. And I think therapies that target those answers, kind of from the inflammatory standpoint and biomarker standpoint, is really going to depend what we find, with those biomarkers. I will also say that we work with wonderful rehab medicine specialists that are experts in muscles, bones, and joints, and mobility, and so that is usually we address in every long COVID visit is how people are moving and how it's impacting their body. And that's part of the rehab plan that we develop for people, and whether or not we write specific physical therapy referrals that are very tailored to the patient, that's very important, particularly when ME/CFS is involved. As you know, you can't just send a PT referral off into space and expect the physical therapists to do what needs to happen with patients with ME/CFS. And so I think very tailored plans and exercise prescriptions that match what the patient is experiencing is very important. And so I addressed kind of the lab side and what some of the concerns are, and that, we don't have any one answer for treatment, and I wish we did. But to address some of your other questions, I think I'll pass it off.
Yeah. I'll actually have a few comments from you, Dr. Bender, and then we'll wrap up just because we are at time.
Great. Thank you for your question. And I think you identified a lot of topics for a future symposium, because as we've acknowledged, it's been a balance. How do we have an event like this while respecting where people are at and their needs? And this has been a long day. So kudos to those of you who made it here in person, who made it online. Both of those things are hard and take your energy. We know that every time you log on and see us in clinic or come to see us in clinic, that we are taking your energy. To answer the question about hyperbaric oxygen in particular, we do not have that at UW Medicine at this time. And there's a lot of other disease states you mentioned that are very important, and some of the pathophysiology of how long COVID may happen. It's so important, and I would just say we try to individualize, as you've heard, a holistic plan for each patient. So for somebody that might mean seeing a hematologist, for someone that might mean using oxygen depending on their conditions. So I'll leave it at that for the sake of time, but we're happy to chat after this as well.
Thank you very much. So we are at the end of this mammoth day, hopefully a good day for all of you. Thank you for being here today and for your engagement throughout the symposium. As we come to close this important gathering, I want to reflect on the incredible progress we've made in understanding and addressing long COVID, as well as the work that lies ahead. Today, we've heard from esteemed experts of both clinical and lived experiences, shared insights, and engaged in meaningful discussions. Together, we've highlighted the need for a multidisciplinary approach to care, emphasizing collaboration between clinicians, researchers, and patients. This collective effort is crucial as we navigate the complexities of long COVID. To the patients in our audience, in person and those of you joining virtually, I want to express my deepest gratitude for your courage in sharing your experiences and for advocating for your health. Thank you. You are at the heart of our work, and your voices remind us of the urgency of our mission. Your resilience inspires us to strive for better outcomes and innovative solutions. To the clinicians who joined us for these sessions, you may have been reminded of the importance in continuing to challenge yourselves to think creatively and, more important, compassionately about care delivery. research, and patient advocacy. I request that you keep that with you as you continue in your career. In collaboration with our patients and communities, we can pave the way for advancements in long COVID treatment, ensuring that every patient receives the comprehensive, compassionate care they deserve. Let's take what we have learned today and translate it into action in our clinic and the communities. As we move forward, let's all remain committed to fostering a community of support, empathy, and shared knowledge. Together, we can make a meaningful difference in the lives of those affected by long COVID. Thank you for your patience, for your passion, and your commitment to this vital work. I want to take this moment to thank perhaps the person who is most important in organizing this event, which is Nova Rivera, and I hope that we can applaud for her. Nova has been there in the back, working, managing everything, and I call him an opera composer who is sitting there and pulling all the strings and making us, be on time. So thank you, Nova, for everything. Thank you, everyone, and safe travels, and we will see you next time.